Hello everyone. Good morning. Am I visible? Am I live? Everything is good to go? Can someone respond in the chat box if everything is clearly visible, audible? I will start the session at. Give me a minute to confirm. I guess it's doing good. Yes. So I welcome you all for today's session. A very good morning to all of you. So today, a new morning, an energetic morning. We are going to start the rapid revision, the remarkable rapid revision of pathology, right? We are having 2 days, today and tomorrow. So today and tomorrow, we are going to take all the high yielding topics of pathology, which are specifically important for FMG exam. So for FMG exam, we have seen the papers of last 10 years, okay, 20 papers, every 6 months we have an exam, and we took out the list of the topic which are ultra important for you to revise before going your exam. So we are going to cover all those topics here one by one, and I just want your attention. If you are attentive, you will understand as well as learn, and we will solve the PYQs related to that topics in the class only. Today only, here only. The only thing I want from your side is two things. Number one, your time, and your time with attention. With attention, you should sit here. Anytime you feel drowsy, you feel sleepy, you just get up quickly, have a cup of tea, coffee, and recharge yourself and come back, and we will continue. Okay, so let's continue with this, full energy, full enthusiasm. We are going to finish the pathology. So in the pathology, we are having 3 sections, right? Just a second. In the pathology, we are having 3 sections: general pathology, hematology, and systemic pathology. And we are having 2 days. So the plan is that we are going to cover entire general pathology and, if possible, a portion of the hematology today. And tomorrow, we are basically completing the hematology and systemic pathology high yielding topics. So let's start with general pathology without wasting any further time. In the general pathology, we are having all these chapters to be covered one by one. Let's start with chapter number 1 and take the important topics from this. Okay, the first chapter I am starting is cell adaptation, cell injury, and cell death. Let's start with this cell adaptation, cell injury, and cell death, the first chapter. I will cover everything, don't worry. Okay, so first chapter is cell adaptation, cell injury, and cell death. Okay, let's start with the first one. So let me tell you what is cell adaptation, what is cell injury, and what is cell death. Can you see this cell? Can you see this cell? Now, human body, from head to toe, we are made up of cells. We have millions of cells in our body. Each and every organ is made up of cells. Cell is the structural and functional unit of life. In human body, all the cells are in homeostasis. Normally, all the cells are in homeostasis. You will say, ma'am, what do you mean by homeostasis? A particular cell performs its function particularly. They have a specific structure and they perform their particular function. For example, the cells of the salivary gland, they do the function of the secretion. The cell of the intestine, they do the function of the absorption. No, the cell of the brain, they do the function of the cognition. So they have different functions allotted by the God, and they are doing that. That is homeostasis. But whenever any stress acts on the cell, whenever any stress is acting on the cell will do 3 things one by one. The first thing cell will do is cell adaptation. Cell will try to coop up. Cell will try to coop up the stress by doing adaptation. The adaptations are reversible. Once you remove the stress, it will reverse back. Okay. If the stress is continued, the second thing cell will do is reversible cell injury. The cell will have reversible cell injury. Again, if you remove the cell stress, it's also reversible. The third and the last thing cell will do is irreversible cell injury if the stress is continued. Not even on removing the stress, it's not reversed. As the name indicates, it's irreversible. Why irreversible cell injury is not reversible? Because actually, irreversible cell injury is cell death. And once the cell is dead, you cannot make it alive again. So basically, I want to teach you 3 things here. Okay, maybe the session will be 5 to 6 hours long. Today also, tomorrow also. So we are having 10 to 12 hours. Okay, in which we are going to compact the pathology in a super compact way. Okay, so if you have any doubt, please write down in the chat box. If I'm in the middle of the something, after finishing that topic, I will come on here. I will address your doubt. Okay, but if you have any doubt, if you have anything in your mind which you don't understand, please write down clearly in the chat box. Okay, chalo. So I want to teach you 3 things here. The first thing I want to teach you is cell adaptation. Then I want to teach you reversible cell injury. And then I want to teach you irreversible cell injury or cell death one by one. Let's understand the same thing by taking an example. Okay, let me ask you a question. How many hours you study daily? How many hours you study daily? Can you answer? Some students say, ma'am, 5 hours, some say 6 hours, some say 8 hours. So it is 6 to 8 hours, the average medical students study. They self-study daily, routinely. So this is your homeostasis. This is your homeostasis. What about a day before exam? How many hours you study? Let me ask the same question. A day before exam or few days before exam? How many hours you study? Some students say, ma'am, 12 hours. Some say 15 hours. Some say 18 hours, So you are increasing the number of the hours. Actually, exam is acting as a stress. And you want to cope up the stress. You do not want to fail. So you want to survive over the stress. So exam is acting as a stress and you are increasing the number of the hours. That is your adaptation. But that's reversible. I mean, once the exam is over, you will not continue 15 to 18 hours. You will shift back to 6 to 8 hours. So you will shift back to your homeostasis once the exam are over. Okay. Don't say 1 hour. Okay. Got it? Hannah. But what if the exams are continued for 1 month? For 1 month or for 2 months, daily, you are studying for 18 hours. You will become sick. You will have certain diseases because of lack of sleep and all the things. So that is reversible cell injury. Your body is having certain injuries, but that's reversible. Once the exam is over after 1 or 2 months, you take treatment. Again, it's reversible. It's still reversible. But what if the exams are continued forever? It's continued forever. Is it possible for any human to study for 18 hours forever, ever? After some time, the person will die. And that is irreversible cell injury. So we have understood the 3 types of adaptation by taking an example. So basically, I want to tell you whenever the stress is acting on a cell, 3 things happen one by one. The first thing happens is cell adaptations, which are reversible. The second thing happens is reversible cell injury. And the third thing is irreversible cell injury. As the name indicates, irreversible cell injury is actually cell death. Okay, there are 2 types of cell death, apoptosis and necrosis. These are the 2 types of cell death that I will teach you in detail. So let's start with cell adaptation. So my topic to teach you is cell adaptation. Okay, how many types of cell adaptations are there? There are 5 types of cell adaptations: hyperplasia, hypertrophy, atrophy, metaplasia, and dysplasia. These are the 5 types of cell adaptations: hypertrophy, hyperplasia, atrophy, dysplasia, metaplasia. What do you mean by that? Hyper means more, plasia means number. So it is increase in number of the cell. Okay, hyper means increase, trophy means size. So it is increase in size of the cell. So increase in number of cell but not size is hyperplasia. Increase in size of the cell but not number is hypertrophy. A matlab absent or reduced. So atrophy, reduction in size as well as number. Okay, reduction in size of the cell. That is atrophy. Metaplasia is transformation of one type of cell to another. If it is squamous, it converts to columnar. If it is columnar, it converts to squamous. And what is dysplasia? Disordered development. It's a pre-malignant condition. So can you see a cell here? Let me show you the 5 adaptations here. You have to learn quickly their examples. That's it. You have learned the 5 types. Now you have to learn their examples. Can you see a cell? This is a normal cell. Please appreciate this is a normal cell. What you can see here, you see, ma'am, still the size is same, but the number is more. Here I can see one cell. Here I can see multiple cells. So this one is hyperplasia because the number is increasing. See this cell. Here the size is more. Here still one, here still one. The cell is one, but the size is more. So it is hypertrophy. This one is hypertrophy. Here you can see the size is reduced. So it is atrophy. Here it is convert from squamous to columnar or columnar to squamous. So this one is metaplasia. And dysplasia is disordered development. How many of you got it? You got it, the 5 type of the adaptations. Did you got it, the 5 type of adaptations? So let me give you the examples of all of them. So let's start with the first one, hyperplasia. Please learn the meaning of the plasia. Plasia matlab number. It is increase in number of cell, not the size. Okay, you can see here is one cell. Whenever there is a stress, it becomes multiple. But the size of them is same. Size of the original cell and all these cells is same. It is only the number which is increasing. Now, hyperplasia is of 2 types, physiological and pathological. So I want you to learn 3 examples here and 3 examples here because you get questions in MCQs in the form of examples. So let me help you to learn the examples. Can you tell me 3 examples of physiological hyperplasia in human body? And can you tell me the 3 examples of pathological hyperplasia in human body? Let's first start with physiological hyperplasia. The 3 examples are in front of you. The first example is the female breast. Okay, this is a female breast. This is the pectoralis muscle. And this is a female breast, any female breast. Okay, now during 3 conditions, okay, these are the cells of the female breast. Let me draw a few cells. Okay, these are the cells of the female breast. Okay, now during 3 conditions, what are the 3 conditions? During pregnancy, during puberty, and during lactation. Puberty, pregnancy, and lactation. The size of the female breast increases drastically. and it's physiological. This one is physiological. It's not a disease. This one is physiological. So you can see the size of the female breast increases drastically during these three conditions. Have you ever thought why it increases? Why? Actually, the number, because during these three conditions, what is happening now? During these three conditions, there are hormones, there are more hormones in the blood of the female. That is estrogen and progesterone. And that is acting as a stress for these cells. So these cells will divide. They will increase in number. They will increase in number, not the size, number. So if there are 10 cells here, 100 cells here. I'm just saying a number to understand. This is why the size of the breast is increasing. So the first example is the female breast. The same diagram shown to you. Give me a thumbs up. Female breast during puberty, pregnancy and lactation, and the stress is the hormones. The second example is the pregnant uterus. Can you see a diagram here? Can you see this is a non-pregnant uterus of a female, and this is the same female become pregnant. So the size of the uterus increases drastically during pregnancy. The size of the uterus increases drastically during pregnancy to accommodate the fetus inside that. Why it is happening? Why it is happening? Now take a biopsy of both of them. See the biopsy here and see the biopsy here. Okay, here you can see the cells which are small and whatever is the number. Here you can see the cells of the same uterus, but it is pregnant. This one is non-pregnant and this one is pregnant. Got it? This one is pregnant. Okay, so but here I can see the size of the cell is also increased, and if you count, the number is also increased. So basically the pregnant uterus is an example of physiological hypertrophy as well as hyperplasia, very important PYQ, repeated many times. So what is the example which is common in hypertrophy as well as hyperplasia? The answer is pregnant uterus, and you repeatedly get questions on that. So you can see, this is non-pregnant, this is pregnant. Let's take the slide of both of them. Let's biopsy. So you can see this is non-pregnant uterus biopsy, this is pregnant uterus biopsy. And you can see the size of the cell is also increasing, and if you count the number, it is also increased. So it is the pregnant uterus, number 2. And number 3, the compensatory hyperplasia. What do you mean by compensatory hyperplasia? We know humans have a pair of kidney. We all have 2 kidneys. Okay, imagine if one of the kidneys lost. It is donated, it is having a tumor, it is having a disease, so it is lost. So what about the other kidney? The other kidney will increase in size automatically to compensate the loss. And this is physiological. It don't occur only in kidney, it occur in liver also, in partial hepatectomy. So it is compensatory loss. Here the loss of the organ is acting as a stress. Here in pregnancy also hormones is acting as a stress. So learn the stressor. What is the stressor in each of them? Got it? Give me a thumbs up, everyone. So these are the 3 examples of physiological hyperplasia. Coming on pathological hyperplasia. Can I come on pathological? Now tell me 3 diseases. Pathology matlab diseases. These are not diseases. These are physiological condition. Now tell me 3 diseases where hyperplasia is taking place. You know, in the females, uterus is there, and in the uterus, there are 3 layers. What are the 3 layers? Endometrium, myometrium, and perimetrium, that is serosa. This is endometrium. Okay, you can see this is endometrium. The myometrium is the thickest layer, and outermost is the perimetrium or the serosa. This one is the outermost. Now during menstruation, every 28 days in a healthy female, menstruation take place. And during menstruation, the endometrial lining get degenerated and it is lost in the form of the bleeding. The female have vaginal bleeding during menstruation. It's not a disease, it's physiological condition. And the endometrium comes, and again it regenerates in the next 28 days, and again it happens. So it is getting degenerated and shaded in bleeding. This happens normally. Now some females are taking estrogen, exogenous estrogen, in the form of some drugs, tablets or food. So estrogen act as a stress for the endometrium. So whenever the female is taking estrogen, it is acting as a stressor. Now what will happen in the same female? See the endometrial lining. There is no change in myometrium and perimetrium. I'm not drawing in that. But the endometrium cells will divide, and they will make a thicker lining of the endometrium. Now such female will bleed heavily. They have heavy bleeding during menstruation also and intermenstrual also. So they present to the gynecologist that, doctor, I'm having a complaint, I'm having heavy menstrual bleeding, and between the menstruation also I bleed. So she is having a thicker endometrial lining, and it's a disease. The name of the disease is endometrial hyperplasia. It's a disease. Endometrial hyperplasia, the stressor is the estrogen. So the first example I taught you here, endometrial hyperplasia, the stressor is the estrogen. See the lining of the endometrium in a normal, healthy uterus, and see the lining of the endometrium here. So these females are bleeding heavily. So this is an example exclusive in females. Now let me tell you example exclusive in males. You know, males have a gland around the urethra of the bladder. Okay, this is the bladder and this is the urethra. The males have a gland. The name of the gland is prostate. Females don't have that gland. Okay, in the prostate gland, you can see this gland is prostate gland. Okay, in the center, there is a opening from which the urethra is passing. This is prostate gland, and these are the cells of the prostate gland. These are the, now sometime in old males, and testosterone is more in the blood. Actually, it is dihydrotestosterone. Dihydrotestosterone acts as a stressor for these cells. So basically, these cells will divide. They increase in number. And because they increase in number, the size of the gland increases drastically. And the cells are increasing. So here, if 10 cells are there, here 100 cells are there. So basically, they will compress the urethra. It will compress the urethra. It will compress the urethra, and urine cannot be passed from here. That male will present to the genitourinary emergency that I cannot urinate, or I'm feeling my bladder is full, and sometimes rupture can also happen. The name of the disease is benign prostatic hyperplasia, BPH. This is the name of the disease you have to learn here. So these are the diseases. Okay, so here male, there is the disease that is benign prostatic hyperplasia. Okay, and one disease is common in male and female. One in female, one in male. One is common in both. In the skin, है ना? Have you heard about a virus, HPV virus? नाम सुना है क्या? Have you heard about the name of the virus HPV? Human papilloma virus. It is known as human papilloma virus. Okay. This virus enters the skin cells. In the skin, we have cells that is keratinocytes. Okay. Imagine this is one of the keratinocyte of human skin cell that is keratinocyte, and this is HPV virus, which is entering inside it. So it acts as a stress. Now this cell will divide, and it will form a mass of cells. It will form a mass. The same cell divide, and this one is known as wart. It will produce a nodularity. Can you see small nodules? These are warts because the cell is dividing like anything. So you can see this is the HPV. It is entering in one of the skin cell, and that cell divide, and produce a wart over here. So skin warts is the name of the disease. So I am summarizing whatever I taught you till now. I'm teaching you the 5 types of adaptations. I have started the first one. Okay, the first one is the hyperplasia. Okay, remaining I will teach you one by one. In the hyperplasia, I want you to learn 3 examples of physiological hyperplasia and 3 examples of pathological hyperplasia. Okay, tell me the 3 examples here with their stress, and tell me the 3 examples over here with their stress. Okay, here 3 examples I told you. What are the 3 examples I told you here? The first example I told you, female breast. Female breast. Okay, the second example I told you, this is the female breast, yeah, pregnant uterus. And the third example I told you, compensatory hyperplasia. So here the stress during puberty, pregnancy and lactation, the hormones are acting as a stress. Here in uterus during pregnancy, again the hormones are acting as a stress. And here loss of organ, partial loss of organ is acting as a stress. You have to learn the summary. Okay, the details are for your understanding. Okay, in the pathological, again, I taught you 3 examples. Yes, very good. What are the 3 examples in the pathological? One in female, endometrial hyperplasia. One in male, BPH, benign prostatic hyperplasia. And the third one is common in both of them, the warts, the skin warts. Tell me the stressor. Here the stressor is the estrogen. Here the stressor is dihydrotestosterone, and here the stressor is human papillomavirus HPV. So how you get the question in your exams? You get a question that BPH is an example of what? Is it an example of hyperplasia, hypertrophy, atrophy, metaplasia, like that? You get simple. Warts is an example of what? Hannah, pregnant uterus is an example of what? So I told you pregnant uterus is an example of both. Hannah, hyperplasia as well as hypertrophy. How many of you got it? How many of you got it? I will share the PDF with the team, and you will get it on the Telegram group and with the team only. Okay. So just understand, PDF will be provided to you. Everyone got it? Say yes if you got it. You have any confusion till now? Let's come on the second type of adaptation, hypertrophy. What's the definition? Here, hyper means increase, trophy means size. Trophy in pathology matlab size. So it is increase in size of the cell, not the number. Increase in size of the cell, not the number. Can you see a cell? This is in homeostasis. Now, whenever the stress is acting on the cell, due to adaptation, it increases in size, but not the number. Here also we have one cell, here also we have one cell. So the size is increased, but not the number. It's also of 2 types, physiological and pathological. I want you to learn 2 examples here and 2 examples here. You have to learn the examples, that's it. Definition you already know. You have to learn the examples. In the end, we will summarize everything. So tell me 2 examples. Let's start with physiological. One you already know, pregnant uterus. I told you it's a common example. So physiological hypertrophy, one example we already know. I know. You can see this is a non-pregnant uterus and this one is a pregnant uterus. Okay, I will take a section here, I will take a section here. So this is non-pregnant, this is pregnant. See the cells here? See the cells here. So cells here are increasing in size as well as number. So pregnant uterus is an example of hypertrophy as well as hyperplasia. We are proving it again. Number one. Number two, some of you do gymming. You go to the gym. Some athletes. Have you seen some athletes or manual laborers worker? So why you go to the gym? You want to make your biceps, triceps, six abs. Why? So have you ever thought whenever we do a laborious exercise, why does the skeletal muscle increase in size? For example, this is the bicep of this person. This is the bicep. These are the cells of the bicep. Just suppose it is having few cells. Now the manual work, the manual exercise is acting as a stress. For these cells, it is acting as a stress. So these cells will increase in size, not number. Mind my words. Here, if we have 10 cell, here also we have the same 10 cell. But the only thing, number is same. Here the size is increased. Size is increased. That's why the muscle is increased. Got my point? So the second example is the hypertrophy of the skeletal muscle. So we have two examples here. One is uterus, which is common, and skeletal muscle. Physiological is done. Let's come on the pathological hypertrophy. Can I start pathological hypertrophy? Okay. Can I start pathological hypertrophy? Yes. How many type of muscles human have? Human have three type of muscles. Skeletal muscle, which you have seen already here. Skeletal. We have smooth muscle and cardiac muscle. Skeletal, smooth and cardiac. So smooth muscle and cardiac muscle are coming in the example of pathological. Skeletal muscle is coming in the example of physiological hypertrophy. The remaining two muscles are coming here. Can you see the heart? Can you see the left ventricle of the heart? You know when the left ventricle pump, it do the systole. The blood comes in the aorta and get distributed in all the organs. Say yes. Okay, Hannah. Now here we have aortic wall. Can you see? Here we have aortic wall from which the blood is coming. Now imagine the person is having aortic stenosis. What will happen? The left ventricle will contract, but the wall will not open. So blood is not going in the aorta, or less blood is going in the aorta. So basically more blood is left in the left ventricle even after systole. Even after systole, the blood is not ejected in aorta. It remains in the left ventricle only, and that will cause us the stress. The increased volume of the blood causes the stress on the wall of the left ventricle. So these are the cells of the wall of the left ventricle. Let me show you the cells of the wall of the left ventricle. This is left ventricle. This is the thickness of the left ventricle, and these are the cells over here. So these cells will increase in size and the wall of the left ventricle become thickened. The name of the disease is left ventricular hypertrophy. So it's a disease. I'm telling you the details just for your understanding. You don't have to learn the details. You have to learn the summary, the examples. So left ventricular hypertrophy, where the stress is more volume of blood in the left ventricle because of aortic stenosis. So that is a disease. Say yes. So it's an example of hypertrophy. Here the cells increase in size, not the number. The second example, let me tell you. Do you know we all have esophagus and we all have stomach? Of course we know. What is the lining of the esophagus and stomach? What is the lining of esophagus and stomach? The esophagus is lined by squamous epithelia. I guess most of you may be knowing. It is lined by squamous epithelia. And the stomach is lined by columnar epithelia. We know that. This is normal. This is normal. Now, have you ever thought why God has given two different lining in the continuation organs? Why? God is great. There is reason behind everything. If we have different lining over here and different lining in the stomach, there may be a reason behind that. It is not ki aise hi hai. It is not like that. Why? The reason is very simple. We have hydrochloric acid, HCl, in the stomach. We don't have HCl in the esophagus. At the junction of esophagus and stomach, we have a sphincter. The name of the sphincter is lower esophagus sphincter. Normally it is closed. Only at the time we eat and we swallow, it opens. Otherwise, it is closed. In me, it is closed now because I'm not eating anything. Okay. So, HCl is present in the stomach. So, columnar lining can bear the stress of the HCl very easily. But squamous is very delicate. It cannot bear the stress of the acid. So, that's why God has given the columnar in the stomach and squamous in the esophagus. Now, in some people, this LES become loose. It becomes open. It becomes open even without eating. So, what happened to them? The HCl get the reflux. Reverse reflux. It is known as gastroesophageal reflux disease, GERD. That is acting as a stress. So GERD is the stress. What is the full form of GERD? Gastroesophageal reflux disease. So when the HCl is doing the reflux, it is hitting the wall of the esophagus. It is hitting the wall of the esophagus. It is hitting. So because it is hitting the wall of the esophagus, okay, it is hitting. So the lower esophagus, the lining will change from squamous to columnar. It converts from I'm sorry. I was telling you about the metaplasia. This is an example of metaplasia. This is Barrett's esophagus. This is coming in the next metaplasia. Currently, I am teaching you hypertrophy. Sometime what happened, this LES, the cell of this LES become increase in size and it closes it permanently. So even on swallowing, है ना, it is not opening. And the name of the disease is achalasia. So we have two diseases, है ना, Barrett esophagus and achalasia in the esophagus. Achalasia is an example of hypertrophy, and Barrett esophagus will come in the example of the metaplasia. Okay, yes, metaplasia next step. Filal, I want to teach you achalasia. The next is Barrett esophagus, है ना. Here it is achalasia. You can see here ileus is opened, and here the cell become increase in size. It become closed. It become closed. So here the food can pass, but here food cannot pass. The food cannot pass. So food will accumulate in the esophagus and esophagus will dilate. It is megaesophagus. The name of the disease is achalasia. How many of you got it? Let me summarize till now. Can I do the summarize? Huh? There are 5 types of adaptations. Say yes. How many types of adaptations we have? We have 5 types of adaptations. What are the 5 types of adaptations we have? The first is the hyperplasia and second is the hypertrophy. I taught you 2 till now. 3 more to go. Okay. Now each of them is of 2 types. Physiological, pathological, है ना? This one is also 2 type. Physiological, pathological. I want you to learn the examples because you get questions on that. So learn the examples 3 over here and 2 over here. That's it. Just learn the summary. The details are for your understanding. Ultimately, you have to learn the summary. Okay. Now tell me the examples of physiological hyperplasia. One example is common, है ना? Here also we have pregnant uterus. Here also we have pregnant uterus. During pregnancy, the hormones act as a stress. And pregnant uterus is a common example of physiological hypertrophy as well as hyperplasia. Okay, let me modify it. This one is hypertrophy. Okay. So you tell me, first you should know their definition. And aplasia means increase in number, not the size. And trophy means increase in size, not the number. We know it very correctly. So uterus is coming in a common example. Here one more example is female breast during puberty, pregnancy and lactation. And third example is compensatory. Compensatory, loss of the organ. On loss of the organ, there is compensatory hyperplasia. Here one more example we have is athletes. है athletes or the one person who is doing the gymming, that is skeletal muscle, है ना. Now what about the pathological? Tell me the examples of pathological also. Here we have 3 examples. One in female, that is endometrial hyperplasia, in which the female bleed heavily. That is one disease in females. One is benign prostatic hyperplasia in males, where male cannot pass the urine. Okay, and one is common skin warts due to HPV. Here the stress is estrogen, here the stress is testosterone, and here the stress is HPV virus. Learn the stressor. Now tell me the 2 examples in pathological. One is cardiac muscle, one is smooth muscle. Cardiac muscle mein the example is left ventricular hypertrophy. It's a disease. The stressor is the aortic stenosis, which is causing more blood in the left ventricle, which is putting a stress. Okay, and the second example is achalasia. Achalasia in the esophagus. Okay, where the lower esophagus sphincter, the cells inside that closed permanently. They increase in size and they close, they don't open. So it will lead to megaesophagus. Everyone give me a thumbs up. This is a summary till now what I taught you. Now I'm coming on the third type, that is atrophy. Can I start the third type? Here also it is of 2 types. So let's come on the third type. Learn example. That's it. You are going the question either on definition or example. That's it. That's it. You have to understand the example. Don't even learn. Coming on the third type, atrophy. What is atrophy? Reduction in size. Can you see this is a cell? It's in homeostasis. Whenever the stress acting on it, it shrinkage. Now it is reducing in size. So reduction in size is known as atrophy. It is also of 2 types, physiological and pathological. Okay, so I'm having 4 examples over here and 6 examples over here. So you have to learn the examples. There is no other way. You have to learn the examples. I'm trying to super simplify it by explaining the details. Yes, absolutely right. Hannah, I cannot read your names, but yeah, absolutely right. It is decrease in size as well as number, you can say. Hannah, so increase in size of the cell known as what? Increase in number of cell known as what? And decrease in size as well as number. We have same term. We don't have different terms. It is known as what? So increase matlab hyper. Increase matlab hyper. Okay, hyper. Size matlab trophy. Hypertrophy. And number matlab plasia. So this is hyperplasia. And decrease in size as well as number. It's atrophy. It's atrophy. We don't have the term aplasia. We have atrophy only. Yes. Atrophy. Atrophy is reduction in size as well as number. Absolutely right. Now, let me come on the physiological and then pathological. In the physiological, we have 4 examples. The first, we have a thymus. whenever we are fetus, but in adult life, it just disappear. The thymus, it shrink and disappear. So, it's physiological atrophy. It's physiological atrophy. Females have ovary, but after menopause, when the menstruation is stopped at the age of 45 to 55 years, the menstruation is stopped. It is known as menopause. After menopause, the ovaries shrink in size. So shrinkage of the size of the ovary is because of atrophy. Hannah, the third example is the brain. Okay, this is the brain of a young person. This is the brain of the same person when the person become old. Now compare the two brains. Hannah, I want you to see the gyri and sulci. Gyri and sulci. Can you see the elevation, depression, gyri and sulci? Can you see that? Now you see here during aging, when the person become old, the gyri thinned out, the sulci deepens. The gyri thinned out, I can see deep sulci, and gyri are very thin because it is atrophied. Hana? So during aging, the brain get atrophied. Maybe after 60, 70 years, all of our brain will be like this. Currently, my brain is like you only. I'm not very old than you. Okay. So currently we have brain like this, and later on, after aging, so it's physiological. It's not a disease. We cannot stop it. It's aging. So this is the brain. Okay, this is the brain. And fourth is the best example I can give you. I told you this is a normal uterus in a female. During pregnancy, I told you it increases in size because of two things, because of hypertrophy as well as hyperplasia. So there is increase in number as well as size of the cell, so it increases in size. But now the delivery happened. The fetus is out. The delivery already happened. The fetus is out. That is parturition happened. Now what about after parturition? After delivery, after parturition, what happens? It will not remain in the same size forever. No. It will again shrink and become normal size. So after parturition, it is atrophy. So uterus is coming in three examples. I say uterus during pregnancy. What is your answer? And if I say uterus after parturition matlab delivery, parturition, the baby came out. So what is the example? So during pregnancy, it is hypertrophy as well as hyperplasia. But after parturition, it is the atrophy. So here increase in size, here reduction in size. How many of you got it? So uterus is coming in three examples of the adaptation out of 5. Uterus triple example mein aata hai. Okay. So this is the fourth example, the uterus after parturition. How many of you got it? So I told you the 4 examples of the physiological. Learn the organs. Hana? Thymus get atrophied in adult life. Hana? Brain get atrophied in the old age. Okay. Ovaries in the female get atrophied after menopause. Okay, and uterus get atrophied after parturition. So this is after parturition, this is after menopause, this is after aging, and this is in adult life. So this is physiological, it's not a disease. ये सब में होता है, आप में भी, मुझ में भी, in all healthy humans it happens. That's why it's not a disease. This is physiological atrophy. Now coming on pathological, I want to give you 6 examples over here. Don't learn the numbers, just hear it. In the exam you have the options. Looking at the options, you can easily recognize. Okay. Now coming on pathological atrophy. Pathologic atrophy. Okay. Now look at this person. This person is chronically ill, or it is having some end stage disease. It is having an end stage cancer. Okay. And the person is unable to eat since last many days. The person is not eating anything. Hannah. So all the organs from head to toe shrink. And the complete person is shrink like anything. Hannah. It is known as cachexia. It is known as cachexia. Now, cachexia is due to starvation atrophy. The person is not eating. It is deprivation of the food. And all the organs get atrophied because of deprivation of the food. It is known as cachexia. It is known as cachexia. Now, see the second example. Can you see aorta? Yes. From the aorta, can you see the 2 renal arteries are coming, supplying the 2 kidneys? Okay. See, this renal artery is obstructed. It is having atherosclerosis or it is obstructed. So, this kidney is getting less blood. So, see the size of this kidney is less as compared to this kidney. So the organ which get less blood, not only kidney, any organ which get less blood, it will shrink in size. Hana? So this is an example of ischemic atrophy. Here the atrophy occurs because of deprivation of blood. The organ is not getting blood. Here the organ do not get the fluid, it's a starvation atrophy. Here the organ do not get the blood, it's ischemic atrophy. Say yes if you got it. The second example. Okay, see the third example. Have you seen the polio patients? See the limbs of the polio patient. They are very thin. Why the limbs, arms and feet are very thin? Why? Polio is a disease which is caused by a virus. The virus kills the nerves supplying to the muscles. So the muscles are normal, but the nerves supplying the muscles, they are damaged by the virus. Okay, so this atrophy is known as, in polio, it is known as neuropathic atrophy. It is due to deprivation of the nerve. There is no nerve supply. So deprivation of food is starvation atrophy. Deprivation of blood is ischemic atrophy. Deprivation of nerve is neuropathic. You can get a question like polio is an example of. The answer is neuropathic atrophy. It is neuropathic atrophy. Okay, got it? Say yes if you got it. The second, for example, I'm having a fracture over here. In the humerus. What you will do, you will put a cast and you will ask me, ma'am, do not use this limb for the next 2 months, 3 months, we will put a cast. Once you remove the cast after 2 months, I will find this limb is the thinner as compared to this. Why it become thinner? Initially, these both are equal. But now if I measure the circumference here, it is less as compared to this because I have not used it. For a long time, I have not used it. So if we don't use an organ for a long time, that organ gets shrinked. So it is known as disused atrophy. It is deprivation of the use. If we are not using it, it's disused atrophy. See this limb, see this limb. This limb is having fracture and it is not used since long. Got it? So this is disused atrophy. The fifth one, humans have an axis. Human have an axis. The first we have a hypothalamus over here. Then we have a pituitary over here. Okay, you can see this is pituitary and we have 3 organs. We have adrenal, we have thyroid, and we have gonads. By gonads, I mean ovaries in females and testes in male. So from hypothalamus, there is the TRH, for example. Here we have TSH, which is coming from here. Here we have ACTH, which is coming from here. And here we have FSH and LH, which is coming from here. So these organs will secrete the certain hormones in the blood. This is the complete axis, we know that. Now imagine in someone the pituitary is damaged. The pituitary is non-functional. Either there is trauma or there is accident or there is cancer or congenitally it is hypopituitarism. The God has not given the pituitary. Forgot to give the pituitary or it's very small. So these hormones are absent. If these hormones are absent in such a child or a person, the size of these organs is reduced. So they have small adrenal, small thyroid and small gonads. Okay, so this type of atrophy is due to deprivation of hormones. It is known as endocrine atrophy. You can see if the pituitary is damaged, the adrenal, thyroid and gonads, they all are small in size. So it is known as endocrine atrophy. It is due to deprivation of hormones. It is seen in hypopituitarism. Say yes. Okay, so this is the fifth. And the sixth and the last one, you can see pressure atrophy. Pressure by one organ to another. For example, can you see? This is the skull. You all can see this is the skull. Now see, this is the meningioma. Can you see the white color skull bone? This is the skull bone, white color. I can see everywhere except this portion. This portion, the white region is absent. Why? The white skull bone get atrophied because it is getting a pressure from the meningioma. Meningioma is a tumor. It is putting a pressure on the skull bone. It get atrophied. So this is pressure atrophy, and if no cause is known, it's idiopathic. So if deprivation of food, it's starvation. Deprivation of blood, it's ischemic. Deprivation of nerve is neuropathic. Deprivation of use, it's disuse. Deprivation of hormones, it's endocrine, and pressure atrophy. And idiopathic is there. Say yes if you got it. So we are done with three adaptations till now. Out of 5, 3 are done, 2 more to go. How many of you are with me? So first I taught you is hypertrophy. Then I taught you is hyperplasia. Okay. Second we have seen is hypertrophy. And third we have just finished is atrophy. And the fourth and the fifth I want to teach you is metaplasia and dysplasia. Okay. Got it? Anyone have any confusion till now? Okay. So here it is of 2 types, physiological, pathological. We have already seen the 3 examples. I'm not repeating. Here we have seen again physiological, pathological. We have already seen 2 examples. I'm not repeating. Just you have to keep in mind which example is coming here. I want to revise the examples over here. Physiological hyperplasia, atrophy and pathological atrophy. Okay. I want you to revise here. So I want you to tell me 1, 2, 3, 4 example in physiological and 6 examples in pathological. Can you help me out? Anyone? So what are the 4 physiological? Atrophy of thymus in old age, in adult life. Atrophy of brain in old age. Atrophy of ovaries in females after menopause. And atrophy of uterus after parturition. So you can easily identify. Coming on pathological. If there is no food, it is starvation atrophy. That is example is cachexia. If there is no blood, example is ischemic atrophy. Example is atherosclerosis of the renal artery leading to renal atrophy. Okay. If there is no nerves, okay, it is neuropathic atrophy. Example is polio. Okay. If there is no use, it is known as disused atrophy. Example is fracture, and we are putting a cast over the fracture. If there is no hormones, it is known as endocrine atrophy. Example is hypopituitarism. Okay. And last is pressure. This is how you have to learn. Coming on the 4th one. How many of you are with me? Coming on the fourth one, metaplasia. Let's start metaplasia. Can I start metaplasia? Hana? So let's start the next adaptation, metaplasia. What is metaplasia? It is replacement of one type of adult cell to another type of adult cell. So initially if it is squamous, it get converted to columnar. And initially if it is columnar, it get converted to squamous. Because of adaptation, it is vice versa. So it is of two types. Listen. I taught you hyperplasia is of two type, physiological, pathological. Hypertrophy is also of two type, physiological, pathological. Atrophy is also two type, physiological and pathological. But metaplasia is always pathological. It's never physiological. So what are the two types of metaplasia? We have two types, squamous and columnar. We don't have physiological and pathological. We have squamous and columnar, 4 examples over here, 2 over here. Okay, so I want to teach you metaplasia now. It is not physiological, pathological like others because it is always pathological. I want to stress this point, highlight this point. But it is of two types, squamous and columnar. What do you mean by squamous and what do you mean by columnar? Listen. You have to see, please understand, huh? It's confusing. Please understand. You have to see finally what is formed. What do you mean by finally? Listen, there are two options now. Either columnar get converted to squamous or squamous get converted to columnar. There are two options. See finally what is formed. Finally here squamous is formed now. So this conversion is known as squamous metaplasia. What is formed finally? That is the name given. That is the nomenclature. Okay. And here finally what is formed? Finally columnar is formed. So this type of metaplasia is columnar metaplasia. We have 4 examples here and 2 here. How many of you got it? How many of you got it? Yes. So please understand the nomenclature is based on what is formed finally. Here squamous metaplasia, you don't even understand ki is it conversion of columnar to squamous ki squamous to columnar. So see what is formed finally. Based on that we are giving the name. And here columnar metaplasia, finally columnar is formed. How many of you got this concept which I am stressing? Okay. So there are 2 types of metaplasia. We will take them one by one. So let's first take squamous metaplasia. Give me 4 examples of squamous. Rather than reading the text, see them in the form of the diagram. There are 4 diagrams, 4 examples, 4 diagrams. Squamous metaplasia. They all have one thing in common. What is the common thing? They all have columnar epithelia. God has given columnar epithelia in these 4 organs. But because of the stress, they get converted to squamous. They get converted. Now, stress is different. Now, this thing is common in all of them. But the stress is different. There is 4 stress in the 4 organs. Are you getting it? Are you getting? I'm trying to super simplify it. Okay. Now, see the 4 organs. You know, the first organ is the lungs. You know, respiratory tract. The God has given us trachea, bronchi, bronchioles, lung. What is the lining? The complete lining of the respiratory tract is pseudostratified columnar epithelia. The complete lining is the columnar. Now, why God has given the respiratory tract? To do the respiration, to do inhalation and exhalation. Like this. Hannah, it is not given for smoking, but unfortunately, some people smoke. But it is not given for smoking. Hannah. So some people smoke. Can you see? The smoke is going inside. The smoke. So whenever the person is smoking, the smoke will irritate the mucosa. The smoke will irritate the mucosa. Okay. The smoke is going inside. And because of the smoke, the columnar get converted to squamous. The stress here is the smoke. Smoke is doing this conversion in the lungs and the respiratory tract. Smoking is the stress, which is converting columnar to squamous. You can see columnar converted to squamous. The second example is the gallbladder. Do you know what is the lining of the gallbladder? This is a gallbladder. Can you see? Gallbladder is also columnar. Hana? But in some people, the gallbladder have stone. That is calculus. Calculus ka meaning has stone. That will act as a stress here. And it will convert squamous to columnar. It will convert columnar to squamous. Okay. So here the stress is the calculus. Calculus. The thing is same. Columnar get converted to squamous. But the stressor is different. The third organ is the prostate gland in the males. This is the prostate gland in the males. What is the lining? Again, the lining is columnar. And here, the stressor is the inflammation, prostatitis. Due to prostatitis, the columnar get converted to squamous. Here also, due to prostatitis, the inflammation. And the last organ is difficult to understand is female cervix. Let me draw this female cervix on the next page. Can you see this is uterus? Okay, can you see this is cervix? And can you see this is vagina? Now, I'm telling you the lining of the uterus is columnar. We all know. It's columnar, the uterus. The lining of the vagina is squamous. Okay, this one is squamous. We all know vagina is squamous and uterus is columnar. What is the lining of the cervix, which is connecting uterus and vagina? What is the lining? I'm asking you, what is the lining? Does anyone know? Hemant or anyone else? Vijay, Vinay, I cannot read your names. Okay, can anyone tell me what is the lining of the cervix? You see, ma'am, it's both. We divide the cervix into two portions. We divide the cervix into two portions. This is known as actocervix and this one is known as endocervix. Okay, because it is outside, this is inside. So actocervix is the continuation of vagina. So this one is squamous. Actocervix is squamous, है ना? And endocervix is the continuation of uterus. So this one is columnar. So in the cervix, we have both lining. We have columnar. So it's an organ which is having both lining. So there is a possibility of both type of metaplasia. Okay. So basically in endocervix, due to some stress, columnar can convert to squamous. So it is known as squamous metaplasia. It can happen in endocervix. And in actocervix, the squamous can convert to columnar due to certain stress. I will tell you the name of the stress. So in actocervix, we have columnar metaplasia. Okay, I will tell you the name of the stress also. Now listen the stress. Hana, imagine the uterus is tied with the ligaments. The ligaments are teared. So uterus will prolapse. Hana, the uterus will fall in itself. The prolapse of the uterus will hit the endocervix, not the actocervix, and it will produce a stress. So this lining will convert from columnar to squamous. So here the stressor is the prolapse of the uterus. Hana, and here the stressor is the estrogen and progesterone. Excess of estrogen and progesterone in the blood will change this lining from squamous to columnar. So here estrogen or progesterone is the stress. Got my point? So please, you have to understand, don't learn. If you know this concept on the spot, you can draw and understand. You have to understand endocervix is an example of squamous metaplasia. Hana? And actocervix is an example of columnar metaplasia. Learn the stressor. In the endocervix, the stressor is the prolapse. And in actocervix, the stressor is the estrogen. Give me a thumbs up if you got it. Give me a thumbs up. Okay, Hana, now you don't have to learn. Absolutely, Leo, you don't have to learn. Now you have to understand. This is the basics. Pathology is a subject you don't have to learn at all. Okay, so same thing I have shown. Currently, I am teaching you squamous metaplasia. So I will say endocervix is an example here. Endocervix. Okay, the uterus prolapse is the stressor because of which it is changing. So I taught you 4 organs. Okay, so I taught you, Hana, squamous, all the 4 organs have columnar epithelia, and because of some stress, they get converted to squamous. So there are 4 examples of squamous metaplasia. This is known as squamous metaplasia. This is known as squamous metaplasia. So there are 4 examples. The first example is the lung or respiratory tract. The second example is the gallbladder. The third is the prostate, and third is endocervix. Hana, now tell me the stressor in all of them. In all of them, the same thing is happening. In all of them, the same thing is happening. In all of them, this is happening. Squamous get converted to columnar, but the stressor is the different. Hana? So in lung, the smoke is doing this conversion in the lung. Okay, this conversion is caused by smoke. In the gallbladder, the same conversion is caused by calculus. Hana? The name of the disease is cholelithiasis. Cholelithiasis. Okay, in the prostate, the same conversion is done by the inflammation, that is prostatitis. Prostatitis, chronic prostatitis or inflammation. And in endocervix, the same conversion is done by uterus prolapse. So basically, the thing is the same in all of them. One thing is happening. Squamous is given by the god, but because of some stress, the lining get converted to columnar. So this is the example of squamous metaplasia. Everyone give me a thumbs up. Can we go ahead? Can we go ahead? So this is squamous metaplasia. Now coming on columnar metaplasia. Can I come on columnar metaplasia? So let's start columnar metaplasia. Here reverse will happen. Here reverse will happen. Hana? So here God has given squamous metaplasia, but because of some stress, it converts to columnar. So tell me 2 organs in which the God has given squamous metaplasia. Tell me 2 organs. The one you already know, actocervix. Actocervix. It is squamous metaplasia. And second is esophagus. Basically lower esophagus. Hana? Now because of the stress, Hana, there is some stress in both of them. The conversion of squamous convert to columnar. The stress is different. Hana? In actocervix, you already know the stress, it's estrogen. I told you because of the estrogen axis, it is happening. Hana? This conversion. In esophagus, the stress is the GERD. Gastroesophagus reflux disease. Hana? So you can see this is the esophagus. Can you see the lining of the esophagus? See the first diagram normally. So this is my esophagus, this is my stomach. So lining of esophagus is squamous and the lining of stomach is columnar. Hana? And there is acid here. But sometimes the acid reflux. Appreciate the reflux here. In the second diagram, appreciate it is refluxing upward. The name of the disease is GERD. Gastroesophageal reflux disease. It's GERD. Hana? So the lower esophagus is exposed to acid. The lower esophagus is exposed. So can you see the lower esophagus here? The lining is squamous. The same lower esophagus converted to columnar. So this portion of the esophagus is known as Barrett esophagus. This portion of the esophagus is Barrett esophagus. Got it? This is the first example. And cervix I already told you. So learn the cervix in both example. Endocervix is an example of squamous metaplasia, and the stressor is the prolapse. And actocervix is an example of columnar metaplasia. The stressor is the estrogen. How many of you got it? There are confusing MCQs over here. So we are done with metaplasia. So I'm teaching you 5 types of adaptations. 4th one is done. The first I taught you is hyperplasia. The second I taught you is hypertrophy. The third I taught you atrophy. The 4th I taught you right now is metaplasia. And the 5th one and the last one is dysplasia. So the first topic will be complete, and damn sure frequently you get questions on that, either on definitions or on example. So we have seen physiological, pathological over here, here and here. But in metaplasia, we do not have physiological and pathological. We have squamous metaplasia and we have columnar metaplasia. What do you mean by squamous? What do you mean by columnar? Here, columnar get converted to squamous. This is the meaning. And here, squamous get converted to columnar. This is the meaning. So you have to learn the examples. Here we have 4 examples. You already know. Just learn the organ. That's it. Learn the organ. We have lung, we have gallbladder, we have prostate, and we have endocervix. You know, in all of them, there is columnar. Because of some stress, it get converted to squamous. Am I right? Am I right? I am right. You know the stressors. Here it is smoke, here it is calculus, here inflammation, here prolapse. Now tell me the 2 organs in which the God has given squamous. It is esophagus and actocervix. Now stress here is GERD and stress here is estrogen. In both of them, squamous get converted to columnar. This is the most simplified version I can tell you. Most simplified version. And these are the heights. No one will tell you more simplified version than that. Okay. Coming on the last one is the dysplasia. Can I start the dysplasia? So let's start the last one. The last type of cell adaptation is dysplasia. What is dysplasia? Dysplasia is disordered cellular development. It's a pre-malignant condition. You will say, ma'am, what do you mean by that? We don't understand dysplasia or disordered development. This is dysplasia. Okay. Yes, MCQ discussion will also be there after the topic. Wait. Okay, let me finish this topic, then we will do the MCQ discussion. Can you see the 2 diagrams? You can see the 2 diagrams, the 2 type of the tissues. Okay, this is normal and this one is dysplastic. This is normal and this one is dysplastic. So basically, there are 7 changes which describe dysplasia. If any cell have these 7 changes, I will say the cell is dysplastic. I will show you all 7 here. Don't learn the 7 like this. No, if you read, you will forget. But if you see the diagram, you will never forget. So I will show you all 7 over here. Got it? Now see the first thing. Count the number of the layers over here. Say, ma'am, only 1 layer. But count the number of the layers over here. They are multiple layers. So number of layers, the first thing. Here number of layers is 1. Here number of layers is increased. You can see, rather than learning, see in the diagram. Number 1. Number 2, here the cells are very orderly arranged. Neat, clean, orderly. And here they are very haphazard. Here they are very haphazard, disordered. So second point is arrangement. Here the arrangement is ordered. Here it is disordered. The second point, arrangement is ordered and disordered. Say yes. Okay. Got my point? The second point is that. The third point is the basal polarity. You will say, ma'am, what is basal polarity? See the normal cells. These are the normal cells. This is the basement membrane. Okay. And this side I'm drawing the dysplastic cell. They are haphazard like this. They are haphazard like this. Okay. Now where is the nucleus in them? Where is the nucleus? Here this is the basement membrane. Here this is the basement membrane. Here the nucleus is away. Here the nucleus is towards the basement membrane. Normally, nucleus is always towards the basement membrane. It's not at the center. And here it's away from the basement membrane. It's away from the. So here basal polarity is maintained. This is known as basal polarity. The nucleus is towards the basement membrane. It is maintained. And here basal polarity is lost. Basal polarity is lost because nucleus is away from the basement membrane. So this is, in dysplasia, basal polarity is lost. Learn this. If you understood, it's good. If you didn't understand, learn it. In dysplasia, the basal polarity is lost. So the third point is about the basal polarity. Here basal polarity is maintained. Here it is lost. You can see the nucleus here. They are all towards the basement membrane. And if you see the nucleus here, they are away from the basement membrane. Say yes. So the third point is that. Fourth point is pleomorphism. Pleomorphism matlab size of the cell. See here, all the cells are same size, same size. So here pleomorphism is absent. But here some are small, some are moderate, some are large. So here pleomorphism is present. So the fourth point is regarding pleomorphism. The fifth point is the ratio, NC ratio. What do you mean by NC ratio? See, this is a normal cell here. I'm drawing. These are the normal cells. Hai na? I'm drawing only one cell. This is the normal cell where the nucleus is towards the basement membrane. And this is a dysplastic cell. Okay? The nucleus is away from the basement membrane. I want to calculate NC ratio over here and NC ratio. The nucleus in the numerator, the size of the cytoplasm in the denominator. Here you can see nucleus is very small and cytoplasm is very large. And here you can see the reverse. The nucleus is very large and the cytoplasm is small. So here NC ratio is less, here NC ratio is more. Because numerator is more here. So in dysplasia, the NC ratio is more. Learn that. You can see the same. In all these cells, see the nucleus is very small, but cytoplasm is large. But here you can see the nucleus is the large, cytoplasm is small. So here NC ratio is more. The fifth point is the NC ratio. How many of you got it? Learn the NC ratio. Okay. The next point is hyperchromatism. What do you mean by chroma? The word chroma. Pathology is a language. You know, chroma means color. What do you mean by chroma? The dictionary meaning of chroma is color. Color. See the color of nucleus here and see the color of the nucleus here. If you see the color of the nucleus here, it's light color. And if you see the color of the nucleus here, they are dark. They are compact because the chromatin is compact. So here hyperchromatism is absent and here hyperchromatism is present. The color is dark. And lastly, here known mitosis, here multiple mitosis. In some of the cell, I can see the spindle formation. So mitosis is present here. So these are the 7 findings which describe dysplasia. What are the 7 findings? Now imagine. Number of layers is increased, yes or no? Yes. Number 2. Arrangement is disordered, yes or no? Yes, the arrangement is disordered. Basal polarity is lost. Pleomorphism is present. Hyperchromatism is present. Mitosis is present. And NC ratio is high. Can you say the features, the 7? Don't learn. In the option, you will get it. I don't recommend you to learn. Just see it so that if it is coming in one of the 4 options, you can pick it. You will get a question, which of the following is a feature of dysplasia or which of the following is not a feature of dysplasia. So if you know these 7, you can easily pick it up. Say yes, respond, people respond. Keep talking, keep saying. Hannah, in the chat box, please writing. Hannah, keep writing, I mean. Okay, what are the 7 features? Increase number of layers, number 1. Okay, disordered arrangement. Arrangement is disordered, number 2. Okay, number 3, the basal polarity is lost. Okay, basal polarity is absent. Basal polarity is lost, but it's okay. One thing is lost, 4 things are present. Hannah, pleomorphism is present. Hannah, hyperchromatism is present. Okay, mitosis is present. Okay, and NC ratio is high. So these are the features. Okay, say yes, everyone. Got it? This is dysplasia. Okay, this is dysplasia. So now read the question. We are done with the first topic. Now we are not revising. We have done the 5 type of dysplasia. Hannah, all 5 type of dysplasia is done. So now we will solve some question. Read the question and tell me the answer. Read the question. Both hypertrophy and hyperplasia is present in what? The 4 options are in front of you. Is it present in breast enlargement during lactation? Is it present in uterus during pregnancy, skeletal muscle during exercise, or left ventricular hypertrophy during heart failure? Say the correct answer. Everyone, please respond. If you understood, you have to tell me the answer. Yes, everyone is right. The correct answer is pregnant uterus. It is an example of both. The second question is in front of you. Transformation of one type of epithelia to another. It is what? It is known as what? Is it dysplasia, hyperplasia, neoplasia, or metaplasia? What is the correct answer? What is the correct answer? Yes, transformation of one type of cell to another. Yes, absolutely right. It's metaplasia. Either squamous to columnar or columnar to squamous. Okay. All are true about metaplasia except what is not true for metaplasia. Tell me what is false for metaplasia. For metaplasia. Is it slow? Yes or no? What is false? Is it reverts back to the normal with appropriate treatment? Is it irreversible? Or if persist may convert to cancer? What is wrong? What is wrong? It can convert to cancer. Metaplasia can lead to this. It is never irreversible. I told you there are 5 types of adaptation and all 5 are reversible. I told you now there is a cell which is in homeostasis. Okay, if you give the stress, 3 things will happen one by one. I start my lecture from this. First thing is cell adaptation, and I told you all 5 adaptations are reversible. Metaplasia is a type of adaptation and it is reversible. Okay, yes, all adaptations are reversible. Absolutely right. So this cannot be irreversible. So this is wrong. All of them are reversible. The next question is very easy. All of the following are adaptations except, which is not an example of adaptation? Hypertrophy, hyperplasia, necrosis, metaplasia. What is not? So hypertrophy is there, hyperplasia is there, metaplasia. But necrosis is a type of cell death. It's not adaptation. So I will cross out. So necrosis is not a type of cell adaptation. Okay. So we are done with first topic. Can I come on the second topic? The second topic is the cell death. Okay. Very important. Here I will teach you two topics quickly. Okay. So cell death, I told you all the cells are in homeostasis. This is a cell of human body. From head to toe, it can be any cell. It is in homeostasis. Whenever the stress is acting on the cell, maybe physiological or pathological, three things happen one by one. The first thing is cell adaptation. There are 5 types of cell adaptation and we have seen them. They all are reversible. If you remove the stress, the cell will become again normal. If the stress is continued, the second thing is reversible cell injury. Okay, if the stress is still continued, finally it's irreversible cell injury. Irreversible cell injury is irreversible. Even on removing the stress, the cell cannot be normal again. No, because irreversible cell injury is actually cell death. Once the cell is dead, anyone is dead, you cannot make it alive again. So cell is dead. That is irreversible cell injury. There are two mechanisms the cell can be dead. The cell can be dead by apoptosis and by necrosis. The cell can be dead either by apoptosis or by necrosis. We compare apoptosis with suicide and we compare necrosis with murder. Why? I will tell you the details when I will explain you the mechanism. You will understand one is suicide, one is murder. Okay, if suicide or murder, ultimately the person dies. Ultimately, by suicide se mare ya murder se mar to gaya, the person is dying. So it is a type of, the cell is also dying. Either by suicide or by murder, the cell is dying. So there are two ways of the cell death. One by one we will see. Let's start with apoptosis. Let's start with apoptosis. You will say, ma'am, what is apoptosis? I told you simply it's cell death, cell suicide. So here I will tell you what does it mean. So for example, this is the cell. This is the nucleus of the cell. This can be any cell from head to toe in human body. Now this cell want to commit suicide. You will say, ma'am, why the cell want to commit suicide? First tell me why. Why? I do not want to commit suicide. Why any cell of my body will commit suicide? Why? What's the reason? There can be two possibilities. Either this cell have done its function in the body and it is no more required. The body is giving the signal, you commit suicide, your function is done. Your function is done now, you are not required, you go away. Or the nucleus of the cell, the DNA of the cell is damaged to such an extent that it cannot, persist now. So DNA is damaged beyond repair, it cannot be repaired. So the nucleus is damaged, so this cell has to commit suicide. So because of these two reasons, the cell has to commit suicide. So this is the reason why the cell is committing suicide. I told you two reasons. Either it is not required or the nucleus is damaged. Now you will say, ma'am, how does the cell commit suicide? What is the mechanism? How does it commit suicide? How does it commit suicide? Okay, so what is the mechanism? You will say, inside the cytoplasm of the cells, there are certain enzymes. The name of the enzyme is caspase. This caspase is present in our cell from head to toe in all the cells, but it is inactive. Normally, it is inactive. It is not active. When the cell receives the signal for the suicide, when the cell will receive the signal that you have to commit suicide, at that time, the caspase will become active. The caspase will become active. Okay. Once the capsases are active, what does they do? They convert the entire cell into multiple small cells. They convert this cell into multiple small cells. These are known as apoptotic bodies. Each apoptotic body contains a small portion of cytoplasm and a small portion of nucleus. The complete cell is converted into small cell. These are known as apoptotic bodies. During the entire process, there is no leakage of cytoplasm outside. No leakage outside. There is no leakage. Since there is no leakage, inflammatory cells do not come to know that anything is happening. So there is no leakage, there is no inflammation. There is no leakage, there is no inflammation. In the end, a phagocyte will come and engulf all of them. A phagocyte will come and engulf. So basically the cell disappeared from the body, disappeared from the world. Chup chup, silently, nobody come to know that the cell disappeared. Suddenly the cell disappeared. Okay, it is not causing shore sharaba, it is not shouting. It is simply quietly because there is no leakage and no inflammation. That's why I said it's suicide. Imagine a person want to do suicide. Person will not take a mic or loudspeaker and announce everywhere, oh, I'm committing suicide. No, it's a silently done in a closed room, silently without knowing anyone. So it is like the suicide because there is no leakage, no inflammation. In contrast to necrosis where the cell burst. So the cytoplasm leak out everywhere and it causes the inflammatory cell. So in necrosis, the leakage is present, the inflammation is present. If someone is murdered, the person will shout, help, 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 and accumulate everyone. So that's why I compare the necrosis with the murder. Because leakage is present, inflammation is present in necrosis. I know, but here there is no leakage, no inflammation. Okay, one more difference between them. Suicide is done by one person. It is not the complete village is doing the suicide. So apoptosis is always done by a single cell. But murder can be done of a multiple person at the time. So necrosis is always a group of cell. Okay, so apoptosis is of single cell, necrosis is a group of cell. In apoptosis, no leakage, no inflammation, it's silent. In necrosis, there is cell bursting, there is leakage, there is inflammation. Say yes. So that's why I compare apoptosis with suicide, and I always compare necrosis with murder, although both of them are the type of the cell death. One is suicide, one is murder. How many of you got it? How many of you got it? Okay. Yes. So this is apoptosis. I'm teaching you apoptosis. So the main thing is there is no leakage, no inflammation. The caspase get activated. The main enzymes are the caspase. They convert the cell into multiple apoptotic bodies. In the end, a phagocyte will come and engulf all of them. There is no leakage, there is no inflammation. What is the mechanism of apoptosis? What is the mechanism of apoptosis? Can you tell me the mechanism of apoptosis? There are two mechanisms of apoptosis. Listen. Extrinsic pathway, intrinsic pathway. It's very interesting. Extrinsic pathway and intrinsic pathway. What do you mean by that? Now this is the cell. This is the nucleus of the cell and this is the DNA of the cell. Now there are two possibilities. Either the cell is receiving the signal from outside that you have to commit the suicide. If the signal is coming from outside, it's extrinsic pathway. Extrinsic matlab outside. Extrinsic. The signal is coming from outside. Sometimes the nucleus get damaged and nucleus only giving the signal to the cell that you commit suicide. So signal is coming from inside of the cell. Here the signal is given by the nucleus only. It's the inside of the cell. That's why known as intrinsic pathway. So extrinsic pathway, the signal comes from outside. And in intrinsic pathway, the signal comes from inside. So first understand the extrinsic and intrinsic, the meaning of that. In extrinsic pathway, the signal comes from outside. And in intrinsic pathway, the signal comes from inside. Please understand it and learn it. Say yes. Now in each of them, there are two phases. Initiation, execution, initiation, execution. There are two phases. Listen. Now I will teach you 3 movie stories based on which I will explain you this. Okay. First, I will teach you the initiation of extrinsic pathway. Okay. I will leave the movie at intermission. Okay. The second half I will tell you later on. Then I will teach you another story that is initiation of intrinsic pathway. Okay, then again, I will leave at the intermission. Okay, then I will combine the 2 intermissions together and make a third story. The third story, that is execution. Execution is common for both of them. I will combine the 2 stories together and make a third story, that is execution. So I hope you got it, what I mean to say. So initiation is different for both of them, but execution is common for both of them. Give me a thumbs up on this point. Give a gesture that you are getting it, because I'm too fast. Every time I cannot ask you, samajh mein aaya, you got it. So whenever I'm giving you a concept, give a thumbs up that you got it. Or if you have any doubt, vice versa, write down that, ma'am, please repeat. Okay. So it will be in a good way. Okay, G, can we go ahead? Yes. So see, the signal is coming from outside, the signal is coming from inside. In each of them, there are two phases: initiation, execution, initiation, execution. Initiation is different in both of them, but execution is common in both of them. So let's do the initiation of both of them and then come on the execution, which is common. So let's start. Okay. Let's start from initiation of the intrinsic pathway. I will continue in the English only. Rosanna, because there are many students here which don't understand Hindi, but I think the English is very simple and you can easily understand it. I'm not using any difficult vocabulary and words here. So English is very simple and any student can easily understand it. So just pay attention. Okay, listen. So coming on the extrinsic pathway, the initiation of the extrinsic pathway. Okay, extrinsic pathway initiation phase. Okay, can you see a cell? Yes, this can be any cell of human body from head to toe. This can be any cell. Now in human body, there are many cells. The cells have death receptor on their surface. Can you see the red color receptors? These are death receptor. They're inactive. We have it on our cells. These are death receptor. Whenever they become active, the cell will commit suicide. That's why known as death receptor. So currently they are inactive. So it can be any cell of mine from head to toe, and it is having death receptor which are at a distance from each other. You can see. You will say, ma'am, what is the name of these death receptor? What is the name of these? There can be 2 types of death receptor. FAST, which is known as CD95. It's a very important PYQ. And second is TNF. FAST and CD95 is one and the same thing. FAST, CD95 or TNF. It can be any. It is a death receptor. Now this cell has committed its function in the body. It has already committed its function in the body. It is no more required. So the body is giving the signal to the cell, please die, please commit suicide. We do not require you more. Your function is done. your function is done in the body. Okay, got it? So the signal is coming from outside. See, it is coming from outside in the form of the ligand. That's why I'm proving its extrinsic pathway, because the signal is coming from outside. In intrinsic, I will show you it will come from inside. Here it is coming from outside in the form of the ligand. Let me zoom this diagram. Can I zoom it? Okay, this is the zoom version. Okay, you can see this is the ligand. It is coming and binding with the death receptor. So once the ligand will come and bind on the surface of the death receptor, multiple death receptor come closer. Multiple death receptor come closer. See, the ligand is coming, binding with the death receptor. Multiple death receptor come closer and they form a domain. They form a domain. It is known as fast associated death domain. What it is known as? Fast associated death domain, FADD. Now in the cytoplasm, how many caspase we have? You see, ma'am, we have many caspase. Caspase 1, 2, 3, 4, 5, 6, 7, 8. Multiple caspase. Because of the formation of this FADD, caspase number 8, and you can write 10 also. 8 and 10 become active. Caspase 8 and caspase 10 are the first two caspase, which get activated in extrinsic pathway. It's a PYQ. You have to understand it. You have to learn it. Okay, got my point? So caspase number 8 and 10 got activated. You will say, ma'am, what's ahead? How this cell will... So this is intermission. This is intermission or climax of the movie or intermission. The later half I will tell you in later on. So this is the thing which I taught you right now. Fast ligand is coming, binding with the fast receptor. Multiple fast receptor come closer and they form a domain which will activate 8 and 10. Caspase 8 and 10. Now, coming on intrinsic pathway. Yahan se I will continue the story in execution pathway later on. Hai na? So, there are two mechanisms, extrinsic, intrinsic. Each of them have initiation, execution, initiation and execution. So, I just finished the initiation. I'm ending the story at activation of 8 and 10. I will continue here later on. But let me tell you one more story, the initiation of the intrinsic. Then I will combine the two stories. Hai na? So, let's come on the initiation of the intrinsic. Initiation of the intrinsic pathway. See a cell in front of you. I want you to see this cell. It's a normal cell. It can be any cell of my body. Okay. It is having the nucleus. Inside the nucleus, it is having the double-stranded DNA. All my cells have this. Hana? We all have mitochondria in all the cells. The mitochondria have two membranes, inner and outer. Between the two membranes of the mitochondria, there is a molecule. The name of that molecule is cytochrome C. Cytochrome C. It is present between the two layers of the mitochondria. It is always present there. Hana? If it comes out now, the cell will commit suicide. The cell will do the apoptosis. So you will say, ma'am, who is preventing cytochrome C to come out? Because mitochondria have the door, no? It is having the exit. Why not cytochrome C come out of that door? Now see, let me zoom out. Let me zoom out. Can you see here? The mitochondria. Concentrate on the mitochondria. Concentrate on the mitochondria. You can see in the mitochondria, this is the transit of the mitochondria. It is known as mitochondrial transit. By mitochondrial transit, I mean the door, darwaza, door. So my question to you, why not cytochrome C come out of this door? Huh? By walking, it is coming out. Why? Who's preventing? There are three guards. 3 chowkidar hain. There are 3 guards who are sitting here. जो उसको डंडा मार के अंदर करते हैं. You just go inside, you cannot come outside. There are 3 guards. What are the name of these 3 guards? It's BCL2, BCLX and MCL1. These are the 3 guards. These are known as anti-apoptotic proteins. Anti-apoptotic proteins because they are preventing apoptosis. They are closing the door. These are anti-apoptotic proteins. They are closing the door. They do not allow cytochrome C to come out in a healthy cell. In a healthy cell, they do not, allow the cytochrome C to come out. Right? Now, imagine the DNA is damaged. Till now, the DNA is okay. It's healthy. But imagine the DNA got damaged due to physical, chemical or biological agent, any agent. This DNA got damaged. Oh my God. The P53 will try to repair it. But if it is beyond repair, the DNA will give the signal to the mitochondria that I am gone. Please commit suicide. This cell cannot survive now because I am gone. Nucleus ke bina cell thodi survive kar sakta hai. There is no cell which can survive without nucleus. So this cell has to commit the suicide now. Okay, now see the signal is coming from inside. It is not outside. That's why it is intrinsic pathway. The signal is coming from inside, not outside. That's why it's intrinsic pathway. As soon as mitochondria receive the signal, the intrinsic signal, mitochondria will do the change of duty of the guards. Hana? Initially, we were having these 3 guards which closes the door. Hana? Now, these guards are replaced by another 4 guards. They will open the door. What is the name of those guards? It's box, bark, BIM and BAD. You get question on that. Okay. So these are replaced. These are known as pro-apoptotic proteins. So anti-apoptotic proteins are replaced by pro-apoptotic. On receiving the signal, anti-apoptotic are replaced by pro-apoptotic proteins. They will open the door. Cytochrome C will come out. Once they open the door, the cytochrome C is leak out and come out. Once the cytochrome C will come out, once, है ना? Now in the cytoplasm there are many caspase, 1, 2, 3, 4, 5, 6. There are many caspase. One of them is procaspase 9. It's inactive. है ना? Procaspase 9 is always in association with APOF1. They are best friend. They travel together. They travel together. They are the best friend. APOF1 is apoptotic activating protein. Now there is a rule. Till they are together, no one can activate procaspase 9. If you want to activate it now, you have to break the pair. You have to break the pair, then only procaspase 9. Once it is alone, it will get activated. Till it is with APOF1, it will not get activated. So what does the cytochrome C will do? Cytochrome C will come और ये APOF1 को पटा के अपने साथ ले जाएगा. Can you come with me? I'm a better friend. You leave procaspase 9. It's not a good person. I'm just telling you a story. You just come with me. You do friendship with me. You leave procaspase 9. So the cytochrome C is taking APOF1 with him. And procaspase 9 become alone and it will become activated. So caspase 9 is the first caspase which get activated in intrinsic pathway. It's also PYQ. है ना? Caspase 8 and 10 are the caspase which get activated there. Okay. And caspase 9 is the caspase which get activated here. So what I taught you, as soon as there is DNA damage, the anti-apoptotic are replaced by pro-apoptotic. Anti-apoptotic are replaced by pro-apoptotic. Anti-apoptotic is BCL2, BCLX and MCL1. They are replaced by Bach's bath Bimbach. So learn the examples. You get many questions. Who is anti-apoptotic? Who's pro-apoptotic? Once the pro-apoptotic are there, they open the door. They increase the permeability. They increase the transit. Cytochrome C will leak out. You have a question on cytochrome C also. Once it come out, it will take APOF1 with him and caspase 9 will get activated. Caspase 9 will get activated. Okay. Now you'll say, ma'am, what's ahead? Aage kya? Now let's combine the two stories together. It's time to do the execution, which is the convergence point of both the pathways. Now what we have learned in extrinsic pathway, in extrinsic pathway, caspase 8 and 10 were activated because of the death receptor, CD95, है ना? Where the signal was coming from outside. And in intrinsic pathway, it is a caspase 9 which is get activated because of cytochrome C, है ना? So from here, caspase 8 and 10 are the first caspase which get activated. In extrinsic pathway, it's the PYQ. In intrinsic pathway, caspase 9 is the first caspase to get activated. It's the PYQ. Now they both will activate 367, the next caspase, and they will activate all other caspase. Ultimately, all the caspase are activated. Can you see a cell? Can you see a cell? In the cell, all the caspase are activated. In the cell, all the caspase are activated. All the caspase 1, 2, 3, 4, ultimately they all are activated. Now either by extrinsic pathway where the signal will come from outside, or by intrinsic pathway where the signal will. Ultimately, summary is that they all get activated. So all the caspase convert the cell into multiple small apoptotic bodies. Multiple small apoptotic bodies are formed. In the end, a phagocyte will come and engulf all of them. Okay, in the end, a phagocyte is coming and engulfing. So the cell is disappeared from the world. We are done with the mechanism of apoptosis. You get many questions on that. How many of you got it? I want a thumbs up from each of you. Whosoever is live. You got it? Either give a thumbs up or write down your doubt. Do one thing, but react. Reaction is important. Do something. Okay. So tell me, you got it, everyone? PYQ means previous year question. CT, it's previous year questions in the FMG I'm talking about. It's PYQ, previous year questions. So we have seen the previous year questions of the last 5 years, 10 years, and we have seen the topics which are important and which questions are repeatedly asked. Okay, I guess you all are learning well. Very good. Very good. Okay. So let me tell you the morphological features in apoptosis. Okay. Can I tell you the morphological features in apoptosis? There are 6 morphological features in apoptosis. You have to learn them in a sequence. Okay. You have to learn them in a sequence. You have to understand them in diagram. It's very easy. See, this is a normal cell. This cell is a normal cell. It's a normal cell. Now it want to undergo apoptosis either by extrinsic pathway or intrinsic pathway. The morphological features are same. Extrinsic, intrinsic, the morphological features are same. Got it? Now this is a normal cell. The first thing it will do is shrinkage. There is cell shrinkage. The cell gets shrinked. The first thing you can see in the diagram also. It's a question. The earliest feature in apoptosis is cell shrinkage. Now the cell have organelles inside that. No, the cell have endoplasmic reticulum, ribosome, mitochondria, many organelles. If the cell gets shrinked, all the organelles come closer. They become compact. Since the organelles come closer, they become compact. The cytoplasm look more pink in color. So the second feature is eosinophilia, which is due to cell shrinkage only. Once the cells get shrinked, the organelles come closer, and that's why the cytoplasm become pink in color. That is known as eosinophilia. So the second thing is eosinophilia. Yes, I will summarize in the end. Okay, I will summarize both the mechanism including morphological. Let me finish it. Okay, got it? So second is eosinophilia, the second feature. The third is the nuclear feature. See the nucleus here. Now the nucleus become more compact, more blue in color. It is known as pycnosis. Pycnosis is compactness of the nucleus or condensation of the nucleus. Condensation or compactness of the nucleus. That is pycnosis. After that, the nucleus becomes fragmented into multiple pieces. The nucleus becomes fragmented. The fragmentation of the nucleus into pieces, it is known as karyoraxis. So first there is pycnosis and karyoraxis. They together are known as nuclear features. The third, pycnosis and karyoraxis. You must understand their definitions also. What is pycnosis? What is karyoraxis? After that, on the cell membrane, multiple small blabs are formed. Can you see? These are the blabs. Blabs are formed. Blab formation. Now each blab will carry, it will separate from the main cell. It will separate from the male cell and from a small body. Each blab separate hote jayenge. They will carry a small portion of the cytoplasm and nucleus with them. So multiple small apoptotic bodies are formed. In the end, a phagocyte will come and engulf all of them. So these are the 6 features. These are the 6 features. Okay, got it? Got it or didn't got it? So tell me the 6 features. Who will tell me the 6 features in a sequence? Tell me the 6 features in a sequence. What is the earliest feature? Say, ma'am, cell shrinkage. The first thing is cell get shrink. Cell shrinkage. The second is eosinophilia. The second is eosinophilia. The first cell gets shrinked, then the cell organelles come closer, eosinophilia, then nuclear features. Pycnosis, that is condensation of the nucleus, and karyoraxis. The pycnosis and the karyoraxis, that is fragmentation of the nucleus. Then blab formation. Now each blab will separate and form an apoptotic body. And finally there is phagocytosis. Now these are the 6 features you can see. You get 3 questions over here. Let me ask you the 3 questions. The first question, earliest change. Everyone can see what is the earliest. It's a very important question, earliest. The last step of apoptosis, it's phagocytosis. Everyone know last. All apoptosis end at phagocytosis. So everyone knows the earliest, everyone know the last. The third question, the specific feature or characteristic feature of apoptosis. So what is specific or characteristic among the 6? So specific or characteristic is the nuclear feature. So specific or characteristic change is the nuclear feature. These are the 3 questions over here. This is the 3 questions over here. Say yes if you got it. So please learn all 3 questions. What is the earliest feature? What is the last feature? What is the specific or characteristic feature? I'm coming on the marker. Wait a while. I'm coming. Okay. Can we go ahead? So please learn these 6 features. Okay. Now coming on the diagnosis of apoptosis. There are 2 ways to diagnose. Finally, apoptosis is over. There are 2 ways of diagnosis of apoptosis. Can I tell you the 2 ways? Okay. Okay, ma'am, you forget, but you have to learn. Chalo. There are 2 ways to diagnose the apoptosis. For example, if I'm giving you a slide, H&E slide, and it contains many cells, it contains hundreds of cells or thousands of cells on that. And if I'm asking you to identify the apoptotic cell, you see under microscope, now you have confusion which cell is apoptotic or which is not apoptotic. There is a marker available. So what do? The name of the marker is annexin 5. Annexin 5 is the name of the marker. You spread it over the slide. Over this only, and after that keep it there for some time and then wash it. Only apoptotic cell will take that marker. Other cells will not take that marker. Now watch it, see it under the microscope. You will see apoptotic cell get highlighted and other cells are not highlighted. So who is the marker of apoptosis? It's annexin 5. It's the question. Annexin 5. Okay. Annexin 5 is the marker of the apoptosis. It's the apoptotic marker. You have to learn. It's also a question. Now you may be thinking, ma'am, why only apoptotic cell is taking annexin 5, not others? So I have to draw the diagram. Can you see this is a normal cell membrane? This is a normal cell. And during apoptosis, it is forming the blabs. So this is an apoptotic cell. Apoptotic cell. Normal cell have a phospholipid on the inner surface of the cell membrane. Okay, inner surface of the cell membrane. It is known as phosphatidylserine. What is it known as? It is known as phosphatidylserine on the inner surface of the cell membrane. But during apoptosis, there is flip-flap, ulta-pulti. There is flip-flap of the cell membrane. So inner membrane become outer, outer become inner. So basically phosphatidylserine comes on the outer side. Now you spread annexin 5 over both of them. Annexin 5 form a bond with phosphatidylserine. So it cannot bind here. It will bind here. So that's why it highlight only apoptotic cell, not others. So principal is phosphatidylserine. You can see same in the diagram. Can you see here? The cell membrane of the 2 cells, the normal cell and apoptotic cell. This is a normal cell and this is a apoptotic cell. See where is phosphatidylserine. Here phosphatidylserine present on inner side. So annexin 5 cannot bind. And here flip-flap occurs. So phosphatidylserine comes on the outer side. So it's forming a bond with annexin 5 and getting highlighted. So this is the principle of annexin 5 if you got it. Okay, got it? So annexin 5 repeated ask question. The next is electrophoresis. It is agarose gel electrophoresis. Let me explain you. Okay, now see, this is a normal cell and this is the nucleus of the normal cell. Okay, and this is the apoptotic cell. This is the nucleus of apoptotic cell. The nucleus is fragmented because of carrier axis. I told you, the fragmentation of the nucleus is the carrier axis. The fragmentation of the nucleus is done by an enzyme known as endonuclease. Ye bhi question hai. The carrier axis is done by an enzyme known as endonuclease. Now do the electrophoresis of both of them. Can you do the electrophoresis? Do the electrophoresis, agarose gel electrophoresis. So here nucleus is in one piece. Hai na? So you will get only one band. The nucleus, the complete nucleus is in one piece. And here the nucleus is in multiple pieces. So you will get like this. So in apoptotic cell on agarose gel electrophoresis, you get this pattern. It is looking like a ladder. CD ke jaisa lag raha hai. It is known as step ladder pattern. It is known as step ladder pattern. So in agarose gel electrophoresis, apoptotic cell shows step ladder pattern due to the enzyme endonuclease. The normal cell do not show. See this diagram. See this diagram. In this diagram, can you see the cell? It is showing ladder-like pattern. So this is apoptotic. And these are the healthy cells, which is having some fragmentation in between, but not much. Say yes or say no, respond. So step ladder pattern is seen in apoptosis. So these are the two ways of diagnosis of apoptosis. So what we have learned, what are the differences between apoptosis and necrosis? What are the differences between apoptosis and, so apoptosis is a suicide. Now I'm going to teach you necrosis next. Necrosis is murder. Apoptosis is suicide, necrosis is murder. Apoptosis takes place of single cell, necrosis takes place of a cluster of cell, because suicide is done by one person, but murder can be done of multiple person at a time. Okay, in apoptosis the cells shrink. That's why cell membrane remain intact. No leakage, no inflammation. But in necrosis the cells swell. By swelling it will just burst out. It will burst out. So cytoplasm leakage is there, inflammation is there. Since there is no leakage, no inflammation, it's silent like suicide. And here leakage is there, inflammation, it's calling everyone. It's like the murder, it's shouting. Say yes. Now you get many questions over here. Everyone give me a thumbs up. Got it? Can we go ahead? Huh? So we are done with apoptosis. We will solve some question. I want each and every one of you to answer. Don't keep silent here. Just answer. Okay? Read the question and tell me the answer. CD95 is a marker of. Is it intrinsic pathway of apoptosis or extrinsic pathway of apoptosis? What is CD95? Let me give you a clue. CD95 is the other name of the FAS. You know, FAS ligand. It's the other name of the FAS. So CD95 is the other name of the FAS. So it is the marker of intrinsic pathway or extrinsic pathway. It is the marker of which pathway? Intrinsic pathway or extrinsic pathway? I'm asking you. Yes. So it is a pathway. It is involved in extrinsic pathway. I told you two death receptors. CD95 FAS and TNF. If I change the question over here, instead of CD95, if I ask you cytochrome C, it is a marker of which pathway? Now what is your answer? Cytochrome C, where it was involved? It is present between the two layers of the mitochondria and it leaks out and causes apoptosis. So that is involved in intrinsic pathway. The same question we can change multiple times. So in that case, your answer will become A. Okay. The next question, in apoptosis, cytochrome C acts through what? After leaking out from the mitochondria, between the two membranes of the mitochondria, when cytochrome C is coming in the cytoplasm, it is acting through what? It is acting through APOF1, BCL2, FADD or TNF. How does it act? I'm asking you. Yes, how does it act? So it takes APOF1 with him so that caspase 9 become alone and it get activated. So mechanism of action is APOF1. It acts via APOF1. The mechanism of action is APOF1. The next question is in front of you. The following is an anti-apoptotic gene. Which of the following is an anti-apoptotic gene? Can you tell me which of the following is an anti-apoptotic gene? So I told you there are two types of genes, anti-apoptotic and pro-apoptotic. Anti-apoptotic are the one which closes the door and they do not allow the cytochrome C to leak out. And pro-apoptotic are the one which open the door and they allow the cytochrome C to leak out. So tell me the examples. Here we have three examples, BCL2, BCLX and MCL. Okay, and MCL1. Here we have BARC, BAD, BIM and BARC. Now tell me the answer. You get many questions over here. Everyone tell me. They are asking which of the following is anti. So yes, BCLX. The remaining three are pro-apoptotic. So we can flip the question multiple times. The next question, what is the earliest change in apoptosis? Earliest. Yes, what is your answer? What is the earliest change in apoptosis? Can you tell me the answer? What is the earliest change? Yes. The earliest change in apoptosis is cell shrinkage. The cell is getting shrinked. This is the earliest change. Okay. If I change the question, instead of earliest, if I ask you specific or characteristic change of apoptosis, what is the answer now? I'm asking characteristic or the specific change instead of earliest. What is your answer in that case? In that case, your answer will become pycnosis. Pycnosis and karyoraxis will become answer in that case. Absolutely right. So please understand the question well. Instead of learning, understand the question. The next question is in front of you. Characteristic feature of apoptosis. Can you tell me the characteristic feature? What is the important feature? Cell membrane remain intact, yes or no? There is basophilia, yes or no? Nuclear molding, yes or no? And cell swelling, yes or no? Huh? Who will tell me? What is the correct answer? Huh? Yes, cell membrane remain intact. That's why there is no leakage, no inflammation. But basophilia nahi hota. There is no basophilia. There is eosinophilia. Huh? There is no nuclear molding. There is pycnosis and karyoraxis. ठीक है? There is no cell swelling. There is cell shrinkage. The cell gets shrink. The other three options are wrong. So correct answer is A. Nuclear molding is not there. No. No bus. Nuclear molding is not there. Nuclear pycnosis and karyoraxis is there. Right? So cell membrane intact is the only correct answer here. We are done with apoptosis. Anyone have any confusion till now? Anyone have any confusion? Can I start necrosis? Can I start necrosis? Anyone have any confusion in apoptosis? If you have, kindly let me know. What is the specific doubt? Kindly let me know. So can I start necrosis? Say yes if I can start necrosis. Give me a minute. Give me a minute. In the morning, I was feeling very cold, but now I don't think I required my blazer. Just a second. Chalo. So let's continue with, just a second. Let's continue with necrosis. I don't think anyone have any doubt. So let's continue with necrosis. The next topic is the necrosis. So I told you there are two ways of the cell death. Okay, apoptosis and necrosis. This is the suicide we have done. Let's talk about the murder now. So that is necrosis. Necrosis is equivalent to the murder. So let's start necrosis. Let's start necrosis. Necrosis is the cell death. It is equivalent to murder. Now we have to understand 5 types of necrosis. I will teach you these 5 types of necrosis in detail. But to understand the difference between the 5 types, you have to understand a cell. Please understand a cell. Can you see a cell in front of you? Please see a cell in front of you. In this cell, you can see 3 details. What in any cell of human body, you have to see 3 details. How many cells human body have? You say, ma'am, we have hundreds or 1,000 type of the cell. RBC, WBC, brain cell, liver cell, kidney cell, ye cell, wo cell, skin cell, fat cell. Can you identify different type of cells? If I give you a particular diagram, can you identify ye kaun sa cell hai? Can you identify what is the cell? What is the cell? What is the cell? This cell. Can you identify? If you want to identify any cell, you have to see the 3 details. What are the 3 details? Number 1, see the outline of the cell. Number 1, see the outline of the cell. It is known as architectural detail. Architectural detail is the outline of the cell. That is architecture. Shape of the cell, I mean. Number 2, see its cytoplasm. The color of the cytoplasm, the amount of the cytoplasm. Is it pink? Is it blue? Is it granular? It is non-granular. It is abundant. It is scanty. See the details. And number 3, see its nucleus. Again, what is the color of the nucleus? How does it look like? Is it central or eccentric? Looking at the 3 details, you can identify a cell. Now see the 3 details. See their shape is different. See their color of cytoplasm is different. See their color of nucleus is different. So looking at the 3 details, we can identify a cell. We have to see the architectural detail of a cell. Okay. We have to see the cytoplasmic detail and nuclear detail. By looking at the 3 details of a cell, we can identify a cell. If I have to do identity of any human, I will ask 3 questions. Number 1, the country of the origin. Number 2, what is your name, surname? And number 3, what is your address? Like that. So we can identify, okay, this person belonging to this country, residing here, and that is the name of the person or whatever. So in this way, we are asking 3 details to the cell. What is your shape? What is your cytoplasmic detail? And what is your nuclear detail? Okay, got my point? So you have to understand these 3 details. Yes, I'm going to take all 3 portions one by one. Okay. Chalo. So there are 5 types of necrosis I will be teaching you. Okay. Coagulative necrosis. There are 5 types of necrosis. Coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis, and fibrinoid necrosis. These are the 5 types. Liquefactive is also known as colligative. It is also known as colligative necrosis. So we can learn a mnemonic. There are 5 types of necrosis, triple C, double F. One is coagulative, one is colligative, which is liquefactive. The third is the caseous. The fourth is the fat. Fifth is the fibrinoid. So triple C, double F, these are the 5 types of necrosis. I want you to understand the definition of each of them. They all are murders, but they are not suicide. They are murder, but the murder is of 5 types. You will say, no, ma'am, murder is of 5 types. What do you mean by that? I will explain you what I mean. So there are 5 types of murders. Say yes, I'm going to explain you 5 types of murders. They all are murders. They all are necrosis. They are not suicide. They are not apoptosis. So first thing, you have to understand the difference between the 5 types of the murders, the definitions. Then tell me the causes. Gross is not important. You can skip and see the diagram of their microscopy. You can get an image-based question in the microscopy, the diagrams. Okay, so let me start with coagulative necrosis. Among the 5, this is the most common. Among the 5, this one is the most common among the 5. Coagulative necrosis. This is the most common among the 5. Got it? This is the most common among the 5. Now, can you see a group of live cell here? This is a group of live cell. Can you see here? Yes, this is a group of live cell. Now it undergo coagulative necrosis here. It undergo coagulative necrosis here. What you can see? See, ma'am, I can see it is having architecture, it is having cytoplasm, it is having nucleus. See the 3 details over here. Architecture, cytoplasm, and nucleus. You see, ma'am, architecture is still same. Whatever shape we have, outline we have here, the same shape and outline we have here also. So architecture is still maintained. Even after necrosis, the architecture is maintained, but cytoplasm color is changed. So cytoplasmic details are lost and nuclear details are also lost. You can see nuclear details here. We have a uniform nucleus. Here nucleus is either fragmented or it's disappeared. Pycnotic, fragmented and disappeared. So only architectural detail is maintained. Cytoplasmic nuclear details are lost. Say yes. So only architecture is maintained, but cytoplasmic and nuclear details are lost in coagulative necrosis. So that's why the cells undergoing coagulative necrosis, they are compared with a ghost. है ना? What do you mean by ghost? Have you seen a ghost? भूत कहते हैं भूत. भूत देखा है कभी? The ghost. मैंने तो नहीं देखा. I have never seen a ghost or भूत. But we have seen in the movies, है ना? So the ghost have only outline. It don't have inner detail. That's why we are comparing this cell with ghost cell. So please learn. So coagulative necrosis, the cells are known as ghost cell. It's a question. It's a question in your exam. Okay. Or else we compare it with tombstone. What is a tombstone? Tombstone is a stone which is placed over graveyard. Hana, stone have only outline. Stone don't have inner detail. It don't have. Again, the same thing. It's have only outline, no inner detail. That's why we call them tombstone. So either say ghost cell or tombstone. So this is a definition. So can you tell me what is coagulative necrosis, people? People, what is coagulative necrosis? Say, ma'am, it's a necrosis in which architectural detail is persist, but cytoplasmic and nuclear detail is lost. Since only architecture is there, outline is there, no other detail, the group of the cell is known as ghost cell or tombstone cell. One and the same thing. Give me a thumbs up if you got it. Everyone. Why only 2-3 people reply? Others are not sitting silently. Keep interacting. Now it's a live session. I know. Chalo. What are the causes of the coagulative necrosis? There are 3 causes. I know. If any organ of human body, any organ of human body do not get blood, the cells of that organ start dying. Imagine if the kidneys are not getting blood, the spleen is not getting blood, the heart is not getting blood. Hai na? If any organ do not get blood, the cells of that organ start dying because of coagulative necrosis, except brain. Brain is an exception and you get many questions on that. Brain may be never have coagulative necrosis. In brain if do not get the blood, the cells of the brain will also die. But not of coagulative necrosis. It is because of liquefactive necrosis, the second one. So in the brain, there is liquefactive necrosis. Hana? So ischemia of any organ leads to coagulative necrosis, but ischemia of brain leads to liquefactive necrosis. So you get questions on that. Okay? You get questions on that. Okay? So this is the first example. Second is burns, thermal injury. Imagine I'm cooking and I have a burn over here in my finger, or there are deep burns someone is having. So burn means the group of the cell is dead. Hana, it is dead because of coagulative necrosis. Okay, number 2. Number 3, Zanker's degeneration you can learn. So these are the 2 or 3 examples you have to learn in coagulative necrosis. So definition is done, examples is done. Coming on gross. We will fill this table in the end. Okay, coming on gross. Gross may don't learn, it's pale yellow. You can just see it's pale yellow, nothing important. Microscopy. The last is the microscopy. Can you see this diagram? In this diagram, this portion I can see, it is a diagram of kidney. I can see the glomerulus. Okay, this is a kidney, healthy kidney, viable kidney, live kidney. And this is a coagulative necrotic kidney. Compare the 2 kidneys. Compare the 2. And at the junction of the 2, I can see inflammation. Because there is no necrosis without inflammation. All 5 necrosis will have inflammation. Inflammation is a hallmark feature of necrosis. All 5 necrosis have inflammation. It is the murder. You know, inflammation is always there. It is not apoptosis. It differentiated from the apoptosis, having inflammation. So at the junction of the two kidney, I can see the lymphocytes, it's inflammation. Okay, so on one side there is viable kidney, and on one side we have dead kidney. Now compare the two. You can compare. Can you do the comparison for me? Now see the cells over here. These are the tubules. See the cells. See the outline, cytoplasm, nucleus, and see the cells here. I can see only outline. Cytoplasm color is changed, Hannah, and the nucleus is absent. So only outline is maintained. Hannah, see the cells over here and see the cells over here. You can see only outline is same, but cytoplasmic and inner details are lost. So same thing, whatever I told you in the definition, same thing I'm showing you in the microscopy. So here also I'm saying only the outlines are maintained, but cytoplasmic and nuclear details are lost. That's why the cells are known as tombstone. So the same thing I'm showing you in the diagram. The same thing I'm showing you in the diagram. Okay. Okay. Okay, so coming on this is the first type of necrosis we have completed, the coagulative necrosis. Okay, coagulative necrosis. Now I am coming on liquefactive necrosis, the second type. Liquefactive necrosis also known as colligative necrosis. Now see, this is a group of live cell, and see it is undergoing coagulative necrosis. This is also a group of live cell. This is undergoing liquefactive necrosis. Can you see? Now see, tell me the change. Can you tell me the change? Here at least architecture was maintained, but other two details are lost. Cytoplasmic detail is lost and nuclear detail is lost. Hannah, we have seen in coagulative necrosis. But in liquefactive necrosis, here I can see the cell outline, cytoplasm, nucleus. But here I can see nothing. I can see dot, 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 dot. That's it. I can see nothing. All three details are lost. Architecture is also lost. I can't see even outline. No cytoplasm, no nucleus. I can see nothing. So basically a group of live cells is getting converted into a gel-like material. It is getting converted into a gel. It is getting converted into a gel-like material. Okay, so this is ultimately converting into a gel-like material, semi-liquid. That's why it is known as liquefactive necrosis. It is a semi-liquid. It is known as liquefactive necrosis. So now the definition, all three details are lost. No architecture, no cytoplasm, no nucleus. All three details are lost, and ultimately a gel-like material is formed. That is liquefactive. That's why it is known as liquefactive. One example you already know, the ischemia of the brain. Ischemia of all body organs leads to coagulative necrosis, but ischemia of brain leads to liquefactive necrosis. So ischemia of brain is already there. First example. Second example you have to learn is the pyogenic bacterial infection. The second example is the pyogenic bacterial infections. Anywhere we have pus. For example, I'm having pus here, anywhere. So pus is a semi-liquid. Now it's a gel-like material. So actually what is pus? The cells of that area undergo liquefactive necrosis, and they are forming a gel-like material, that is pus. So pyogenic infection, the second example. Grossly, you can see this is a diagram of brain. Intentionally, I'm showing you brain to learn that in brain we have liquefactive necrosis. See, it's like a cavity inside which the gel is filled. The gel-like material, liquefied material is filled here. That is the gross. Hannah, now microscopy. Can you see the microscopy? See, this is a normal brain. And see, this is a liquefactive necrotic brain. And see, at the junction, you have the inflammation. At the junction, we have the inflammation. Say yes. Okay, got it, Hannah? So at the junction, there is inflammation. On one side, there is healthy tissue. On other side, it's liquefactive necrosis. And at the junction, we can see the inflammation. See the normal brain. In the normal brain, I can see the cells having all three. These are the neurons, oligodendrocytes. I mean, these are the brain cell having all three details. I can see their outline. I can see their cytoplasm. I can see their nucleus. I can see everything over here. I can see everything over here. Hannah, now during liquefactive necrosis, it get converted into what? A dot, 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 dot like thing. No cytoplasmic detail, no outline, no nuclear detail. All three details are lost. What I can see is the gel-like material. It is the liquefactive necrosis. We can see it here. And at the junction, I can see the inflammation. Okay, coming on the third necrosis, the caseous necrosis. Can I start caseous necrosis? Say yes, everyone. Say yes. Can we go ahead? The caseous necrosis. In the caseous necrosis, you can see what's the difference now. Tell me the definition first. This is a group of live cell. This is a group of live cell. This is a group of live cell. Hannah, here in coagulative necrosis, architecture was maintained, but other two details are lost. So only architecture is there. That's why the cells are known as ghost cell or tombstone cell. Here, all three details are lost. No architecture, no cytoplasm, no nucleus. Here in caseous also all three details are lost. No architecture, no cytoplasm, no nucleus. Then you may be thinking, ma'am, what is the difference between liquefactive and caseous necrosis? You are saying all three details are lost here also, all three details are lost here also. But see, what is the group of cell it is forming? The group of cell here, it is forming a liquid material, a liquefied material, And here the group of cell getting converted into granular material. So if it is liquefied material, it is liquefactive. But if it is granular dry material, it's caseous because it looks like cheese. Cheese, matlab caseous का मतलब होता है cheese. So have you seen cheese? This is the cottage cheese. How does the cheese look like? Remember, it's dry and granular. Dry and granular. It's not liquid. It's dry and granular in appearance. So here the group of cell get converted into dry and granular. That is caseous necrosis. What are the causes? 2 causes are bacterial and 2 are fungal. There are 4 causes, 2 bacterial and 2 fungal. The 2 bacterial is TB and syphilis, and 2 fungal are histoplasma and coccidiomycosis. Learn the 4 causes. Grossly, it look like cheese. See, the caseous necrosis in the lung, having TB in the lung, you can see it's look like cheese. It's dry, yellowish, granular. That is, Hana. Microscopy, what I can see here. In this diagram, I can see it is a diagram of a lymph node. This is a normal lymph node. This is a necrotic lymph node. And at the junction, I can see the inflammation. On one side, there is normal lymph node. On one side, there is necrotic lymph node. And at the junction, there is inflammation as usual. So see the normal. In the normal lymph node, I can see the lymphocytes. They have architecture. They have cytoplasm. They have nucleus. They have beautiful all 3 details. But here, all 3 details are lost. No architecture, no cytoplasm, no nucleus. I can see the granularity. They have granular appearance. That's it. And at the junction, there is a special type of inflammation, that is granulomatous inflammation, in which giant cells are there. Hannah, coming on the 4th type of necrosis, the fat necrosis. Can I come on the fat necrosis? The 4th one is the fat necrosis. What do you mean by fat necrosis? It is the death of the adipose tissue in living body. Death of adipose tissue in living body. That is the fat necrosis. Naam mein hi hai matlab uska. It is a necrosis of the fat. Now tell me the human 3 organs in which abundant of fat is present. Can you tell me in human body, what are the 3 organs in which abundant fat is present? Yes, one is mesentery, in which abundant fat is there. One is pancreas, in which abundant fat is there. And one is female breast, in which abundant fat is there. So if death occurs of cell of any of this tissue, it is fat necrosis. In the breast, it can be trauma. In the pancreas, it can be pancreatitis. In the mesentery, it can be inflammation. So it will lead to fat necrosis. Grossly, it looks yellowish deposits. Yellowish white deposits, and microscopically it's look cloudy. Can you see it's cloudy in appearance? It's cloudy in appearance. That is the microscopy. The last one, the 5th one, is the fibrinoid necrosis. What is the 5th one? The 5th one is the fibrinoid necrosis. It occurs in the wall of the blood vessel. That's it. It occurs in the wall of the blood vessel. Blood vessel के walls में होता है. In the wall of the blood vessel, we are having 3 layers: intima, media, and externa. This is the lumen of the blood vessel containing the blood. Okay, this is intima. Now this is complete media. This is complete media. In the media, I can see a ribbon-like material. Can you see a ribbon-like material? It is fibrinoid necrosis present in the media. It is fibrinoid necrosis. A ribbon-like material is present. It is the fibrin-like material, pink color. So it is present in vasculitis. It is present in vasculitis. We are done with 5 types of necrosis. We will revise them quickly. Can you please help me out? Please everyone participate. Okay. So please, can you see? Tell me the 5 types of necrosis. Tell me their names first. What are the 5 types of necrosis we have? We have coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis, and fibrinoid necrosis. Okay, triple C double F. In coagulative necrosis, only architecture is maintained. The other 2 details are lost. That's why the group of the cell is known as ghost cell or tombstone cell. In liquefactive, all 3 details are lost. In caseous also, all 3 details are lost. Then what is the difference between them? Here all 3 details are lost, but the group of cells converted into gel. Here all 3 details are lost, but the group of cells converted into granular debris. Okay, fat necrosis, fat-rich location, the 3 fat-rich location. And fibrinoid necrosis occurs in the media of the blood vessel. Say yes if you got it, everyone. Okay, so this is the definition. Now see the causes. Here ischemia of all organ except brain. Here ischemia of brain along with pyogenic infection. Here, you know, the 2 bacteria and the 2 fungus, TB, syphilis, histococcidio. Here, the 3 fat-rich organ, breast, mesentery or omentum is one and the same thing, and pancreas. And here we have blood vessels, vasculitis. Okay, gross is not important. Microscopy, I told you the diagram of all 5. We are done with necrosis. Read the question and tell me the answer quickly. Read the question and tell me the answer. Quick, fast. We have many important topics to be covered. So in a short span of time, we have covered many important topics yet. I have taught you the 5 types of adaptation. I have taught you the cell death. I have taught you the apoptosis. I taught you the necrosis. Ultra important topics we are taking in a short span of time. What is the correct answer? Necrosis, in which the cells are retained as ghost cell. What type of necrosis it is? Everyone please participate. Yes. So ghost cell, it is seen in coagulative necrosis. If I change the word ghost cell to tombstone appearance, What is the answer now? Tombstone appearance is also seen in coagulated necrosis. It is also seen in coagulated necrosis. The next question is in front of you. All of the following organs likely undergo coagulated necrosis except. Tell me the organ in which coagulated necrosis never happened. Tell me a organ in which coagulated necrosis never happened. What is that organ? Is it spleen, heart, kidney, or brain? Yes, the correct answer is D. In the brain, coagulated necrosis never happened. Okay, so coming on the next topic, gangrene. Can I start gangrene? Someone was asking now, what is gangrene? Gangrene is one step ahead of necrosis. है ना? Necrosis तो है ही है. Along with necrosis, if putrefaction also occurs, the combination is known as gangrene. So basically, gangrene is equal to necrosis plus putrefaction. What do you mean by putrefaction? हिंदी में कहना degradation, है ना? हिंदी में कहूँ तो सड़ना, है ना? Dead body सड़ जाती है ना, सड़ना. The degradation, decay and degradation, है ना? So whenever there is a necrotic tissue, it's dead tissue and it attracts the bacteria. Whenever there is a necrotic tissue, by necrotic tissue I mean the dead tissue, it's murdered, it's dead, and it attracts the bacteria. All dead tissue attract the bacteria. Now there are two possibilities. If less bacteria get attracted or more bacteria get attracted. If less bacteria get attracted, there is less putrefaction. They will do less putrefaction. कम सड़ाएंगे क्योंकि बैक्टीरिया कम है. Less bacteria get attracted, less putrefaction. More bacteria get attracted, more putrefaction. So there are two type of gangrene. Here putrefaction is less, so organ look dry. It's dry. This is dry gangrene. And here putrefaction is more. कभी देखा है? If some dead body इतनी सड़ गई कि it get converted into a gel-like material. You know. So here putrefaction is abundant. What I mean here, the putrefaction is abundant and it look wet. That's why known as wet gangrene. So what are the two type of gangrene? Tell me what is gangrene. Gangrene is equal to necrosis is already there, but it is superimposed by putrefaction. Now it depends. It depends how much is the putrefaction. है ना? So whenever there is a necrosis, the bacteria get attracted. Now less bacteria, less putrefaction, and the organ look dry. That's why dry gangrene. More bacteria, more putrefaction, the organ look wet. That's why known as wet gangrene. People respond quickly. Okay, got it? So this is the definition. There are basically two type of gangrene, the dry gangrene and the wet gangrene. And the third type of special gangrene is gas gangrene. Gas gangrene is a variant of wet gangrene. I will explain you that also. Okay, so see the two type of gangrene. See, this is dry gangrene and this is wet gangrene. I will explain you both. So see the difference. Dry gangrene occurs in limbs. Can you see? It usually occurs on the limbs. And wet gangrene occurs in the bowel. It occurs in the bowel. The wet gangrene occurs in the bowel. The dry gangrene occurs in the limbs. The wet gangrene occurs in the bowel. Dry gangrene occurs due to artery occlusion. The wet gangrene occurs due to occlusion of both artery and vein. Here only artery get occluded. Here artery plus vein both get occluded. This one occurs in limbs. We can see in the diagram. No need to learn. And this one occurs in bowel. No need to learn. It's seen in the diagram. Okay. This one also black in color. This one also black in color. Both important nahi hai. Here bacteria are less. That's why putrefaction is less. है ना? Putrefaction is less because bacteria are less. Here bacteria are more, so putrefaction is more. Obviously bacteria less putrefaction. That's why organ is dry. Here bacteria is more, putrefaction is more. That's why it is wet. The most important question which you get here is the line of demarcation, LOD. है ना? In the dry gangrene, I can make out a line. I'm sorry. I can make out a line that this tissue is dead and remaining is viable. I can make out a line. I can make out a line of demarcation. This is dead, this is viable. This is dead, this is viable. But here I cannot make a line. It just happens that I cannot make a line. So here LOD is present. We can make line of demarcation. But here LOD is absent. We cannot make line of demarcation. You usually get question on line of demarcation. So here line of demarcation is present in the dry gangrene. It's absent in the wet gangrene. Say yes if you got it. Hana, so this is the two type of gangrene and a special type of gangrene. Special type of gangrene is gas gangrene. Yes. So diabetic foot. Very, very good question. Diabetic foot is an example of what? You know, in diabetic foot, there is gangrene. Is it dry or wet? I'm asking you, is it dry or wet? First you answer. Health first. You first answer. You are asking, no? Dr. KP, you first answer. Diabetic foot. Diabetic gangrene. You know, diabetic foot in which there is a very frequent gangrene in the diabetes in the foot. It is an example of which type of gangrene, dry or wet. So you will say, ma'am, ये foot है, तो foot के हिसाब से तो dry होना चाहिए. You said कि dry occurs in the limbs, है ना? But it's wet. It's not dry. So please learn why it's wet. I will explain you. Diabetic foot is an example of wet gangrene, not dry. It's an example of wet. Although it's a foot, but it's wet. Because what happens in diabetes? Diabetes में क्या होता है? Tell me the definition of diabetes. Tell me the definition. Diabetes में there is more glucose in the blood. More glucose in the blood. That's the disease diabetes. Na? More glucose in the blood. More glucose attract more bacteria. Because there is more glucose, it attracts more bacteria. More bacteria means more putrefaction, and it will lead to wet gangrene. This is the reason. Although it's a food, but it's an exception. It's an example of wet gangrene, not the dry. Say yes if you got it. Say yes if you got it. Everyone, so it's an example of wet, not dry. Take in consideration. The third type of the gangrene is the gas gangrene. You know, it's wet gangrene only, but the bacteria, which abundant bacteria are present, abundant putrefaction, because it's wet gangrene only. More bacteria, more putrefaction. But the only thing, the bacteria is a gas forming bacteria here. Which bacteria is there? Here the bacteria is a gas forming bacteria. Which bacteria form the gas? It's Clostridium. Which bacteria form the gas? It's Clostridium. It's Clostridium. Got it? It's Clostridium. So imagine this person was traveling on a motorcycle and he got an accident, road traffic accident. So he fell down in the soil. The soil was contaminated with Clostridium perfringens spores. So he got a wound over the thigh and the spores get infiltrate into the wound. After going in the wound, the spores get germinate and the bacteria start forming the gas. And so it's a necrotic tissue having the gas in that. It's a gas gangrene. So we are done with this topic also. Give me a thumbs up if you got it. Can we go on the next topic? The next topic is pathologic calcification. I guess this is the last topic of this unit and we quickly move to the next unit. Pathologic calcification. What do you mean by pathologic calcification? What do you mean by pathologic calcification? I'm asking. What is pathologic calcification? What do you mean by pathologic calcification? What is pathologic calcification? Where is calcium present in human body? In organ. In which organ? Calcium is present in the blood. Okay. Where is calcium present in human organ? Only 2 organs. My teeth have calcium, the enamel of my teeth, and my bones have the calcium. Bones, the osteoid of the bone. So calcium is present in the teeth and the bone, nowhere else. If calcium present in any other organ, it's abnormal, and it is known as pathologic calcification. So pathologic calcification is the deposition of calcium anywhere else apart from these two. Any other organ of my body, if it is having the calcium deposition, it's pathologic calcification. So calcium deposition apart from the bone or the tooth, the osteoid of the bone and enamel of the tooth. If anywhere else is the calcium is calcification. There are 2 types of calcification. Abnormal calcification, pathologic calcification, dystrophic and metastatic. You have to understand the difference between them. What is dystrophic calcification? What is metastatic calcification? In our blood, calcium is present. What is the normal concentration of calcium? It's 9 to 11 milligram per deciliter. See, this is calcium flowing in the blood vessel. Can you see the blood vessel inside which the calcium is there? Now it never comes out. Okay? Here, the tissue is dead and degenerated. Imagine a dead and degenerated. So calcium loves dead tissue. As soon as it is traveling from here and calcium saw outside, oh my God, there is a dead tissue. It jumps out. It jumps out. It comes extravascular and get deposited over this tissue. And get deposited this tissue. This tissue can be any tissue. It is apart from bone and tooth. This can be any tissue. So this type of calcification is dystrophic. Here, the tissue is dead and degenerated. So that's why dystrophic. D for dead, D for degenerated, D for dystrophic. So dystrophic calcification occurs in dead and degenerated. Dystrophic calcification occurs in dead and degenerated tissue. Here the blood calcium level is normal. Here it's 9 to 11 milligram per deciliter. Still calcium comes out of the blood because it loves dead and degenerated tissue. It's jumping out. It's just jumping out. Say yes. See the second possibility. Tissue is absolutely healthy. It's absolutely healthy. Yes, it's not dead. It's not degenerated. Still the calcium is jumping out and getting deposited here. Now why it is jumping out? Why? Because see the concentration of calcium in the blood is more. Here it's hypercalcemia. Here the concentration of the calcium in the blood is more than 11 milligram per deciliter. It's hypercalcemia. Here calcium level was normal. There was a problem in the tissue. Here the tissue is normal, but there is a problem in the calcium concentration in the blood. Why the calcium concentration will be more? For absorption of calcium, 2 things are required in the blood. Vitamin D, so either vitamin D is more, hypervitaminosis, or parathormone. Hyperparathormone is there. Or the parathormone is more. So vitamin D is more or parathormone is more, it will lead to hypercalcemia. And if it leads to hypercalcemia, more calcium, it will be spitted out from the blood and get deposited. This type of calcification is metastatic. So I'm teaching you 2 types of calcification. What are the 2 types of calcification? People say fast, dystrophic and metastatic. What is the difference between them? Tell me, what about the tissue? And what about the blood level of calcium? Tell me the 2 things in both. Here tissue is dead and degenerated. Here tissue is normal. Okay? Here calcium level is normal, but here calcium level is more because of more vitamin D or more parathormone. How many of you got it? So this is dystrophic and metastatic. Please learn it. Okay, got it? Can we go ahead? Metastatic and this thing. What you are asking some question to me? Please write it again. I skipped the chat, I guess. If you're asking something, write down again. Okay. Now, what are the sites of dead and degenerated? Tell me some sites of dead and degenerated tissue where the dystrophic calcification take place. So dead tissue like any necrotic tissue, caseous necrosis, dead parasite, fat necrosis, infarct, thrombi, these are the dead. And degenerated tissue is the atherosclerosis, monkey bug atherosclerosis. These are the dead and degenerated tissue. Okay, and what are the sites of the metastatic calcification? Hana, these are all the sites where, here the tissue is healthy, but its pH is alkaline. Hana, so calcium level is more in the blood. So as soon as it see alkaline pH, it just jump out. So all these tissues have alkaline pH. So don't learn the list, have a look on that. Okay, so we are done with calcification also. Okay, so can I come on the next chapter? Everyone is satisfied till now? Everyone, can we go ahead? Can we start second unit with the same method? You want any change? Can we start? So I want to teach you the important chapters here, the big chapters, not the small one. So we are done with the biggest chapter, now inflammation and neoplasia. These two are ultra important and they are very big. Okay, so let's start with inflammation. Okay, so let's continue with the second chapter, inflammation. Let me start with inflammation. What is inflammation? Okay, if any microorganism enters human body, it can be a bacteria, it can be a virus, it can be a fungus, it can be a parasite. What does it causes? Once it enters the human body, it will cause infection in human body. And just suppose if any of them is entering in me, they will cause infection in me. I do not want to have infection. So my body will oppose it. And that is known as inflammation. So my body will oppose it, and that is known as inflammation. So inflammation is the defense. So what the microorganism is causing to the human body is infection. And what the body is causing to the microorganism is inflammation. So inflammation is a defense reaction. Inflammation is a body's defense reaction. It's like the army. In the body, we have the army. The army is the WBCs. WBCs, God has provided us an army. Imagine I call the microorganism as terrorist. Who's a terrorist? Terrorist is the person who is foreign and causes harm to the country people. So in the same way, microorganism is foreign, and after entering in human body, it causes harm to us. It causes infection. So can I say microorganisms are terrorist? The terrorist can be bacteria, virus, fungus or parasite. They are the terrorist. So we have army in us. God has provided us army. In the army, we have the soldiers, the B and the T lymphocytes. They are our soldiers. What does they do? They fight with the terrorist. Now look who is winning in the fight. If the terrorist win in the fight, the person have infection. If the army is winning in the fight, the person have inflammation. Okay, if you have a good immunity, you will have inflammation. Got my point? So this is the thing. This is the basic you must understand. There are two types of inflammation, acute and chronic. Let's start with acute inflammation. I'm starting with acute inflammation. Can I start with acute inflammation? So let's start with acute inflammation. Please start with acute inflammation. Listen, acute inflammation can occur in any organ from head to toe. Let's start with the head. It can be meningitis, it can be encephalitis, it can be endophthalmitis, it can be rhinitis, it can be tonsillitis, it can be pneumonitis, it can be any organ, appendicitis, gastritis, it can be any organ. So from head to toe in all organ we have acute inflammation. But I always consider the example of tonsillitis because we have it in our life now. I guess everyone have tonsillitis till now, once, at least once. So we are aware of it. How does tonsillitis occur? But it can occur in any organ. So whenever you think about the acute inflammation, think about tonsillitis, you can imagine it better, although it can occur in any organ. Now there are 5 things occur in all acute inflammation. In all acute inflammation, 5 things occurs. It is known as cardinal sign. Organ become red in color. Can you see the tonsils become red in color? Number 1. Number 2, the temperature of that organ, the tonsil, is more as compared to surrounding temperature. So increase local temperature. Number 2. Number 3, the tonsil swells up. The organ swells up. Number 3 is swelling. Number 4, there is pain in that organ. We have pain in the tonsils. And number 5, temporary loss of function of that organ. Number 5 is the temporary loss of function of that organ. These are the 5 signs you have to learn. These are known as cardinal sign. But you don't have to learn them in English language. You have to learn them in Latin. Latin. Does anyone know Latin among the audience? किसी को Latin पता है क्या among the audience? Do you know Latin? You have to learn that. Redness in Latin is known as rubor. Okay, increased temperature in Latin is known as Cellular. Swelling in Latin is known as tumor. Tumor is not neoplasia here. Tumor in English is neoplasia. In Latin it is a swelling. Pain in Latin is known as dolor. And loss of function is functionalisia. So you have to learn the 5 cardinal signs. If acute inflammation occur in any organ from head to toe, 5 things happen in that organ. What 5 things? Say the 5 things. Say the 5 things. Okay, so 5 things are rubor, that is redness. Calor is increased temperature. Tumor, matlab swelling. Dolor means pain. And functiolacia means temporary loss of function. So please learn the 5 cardinal sign. You get simple question on that. Okay, now let's start acute inflammation. Okay, so I will teach you acute inflammation ke steps. Quickly, we will revise. And chronic inflammation ke steps. Quickly, we will revise. So in acute inflammation, there are 11 steps. It's a big topic. है ना? In chronic inflammation, only 3 steps are there. है ना? Chronic inflammation में granuloma बनता है. That's why chronic inflammation also known as granulomatous inflammation. Acute में never granulomas are formed. So I'm going to teach you the 11 steps here and 3 steps here. Can I start? Can I start the 11 and the 3 steps? So let's start with the 11 steps of the acute inflammation. One by one, we will see the 11 steps. Okay, G, say yes. Say yes, respond, say yes. So let's start with acute inflammation, the 11 steps. Hai na? There are 5 vascular and 6 cellular. I will tell you like a movie story again. It's very interesting if you understand with the help of my story. So there are 5 vascular, 6 cellular, total 11 events are there. Hai na? These are the 5 vascular you can see in front of you. These are the 6 cellular you can see in front of you. So 5 plus 6, total 11 events are there. I do not want to read it. I will explain you directly. I will explain you all 11 events. All 11 events in one master diagram. Now, please understand this master diagram. If you understood this master diagram, the next 11 events you can understand. If you didn't understand, it's wastage for the next half an hour. You will not understand anything. So please, everyone, concentrate on your gadgets and please have a look on this diagram. What is this diagram? The master diagram. Now see, can you see a yellow color thing in this? This yellow color thing. This yellow. It is my skin. It can be any part. Just suppose it is skin of this area. So, I'm sorry. It is the skin of this area. Okay, just below the skin, we have the blood vessel. We have blood vessel everywhere. So just below the skin, we are having a blood vessel over here. You can see this is the blood vessel. The blood vessel is lined by the endothelial lining. So this is the endothelial lining you can see. The blood vessel is lined by endothelial lining. Inside the blood vessel, we have RBCs also, platelet also, but I'm not interested in RBC platelet. I'm interested in WBC currently, the army. So this is my army. By army, I mean WBC. That is the army. Hai now, some terrorists have entered. Who's the terrorist? This one is the terrorist. It can be bacteria, it can be virus, it can be fungus, it can be parasite. I will call it a terrorist. I will call it a terrorist. Hai so the terrorist is present, the army. This is the army. You can see the WBCs are the army. Hai I want to make them fight. Let's see who is winning. If the terrorist is winning, the person have infection. If the army is winning, the person have inflammation. So we say, what is the problem? Let them fight. Let's see who is winning. Let them fight. There is a problem. The problem is that the terrorist is extravascular and the army is intravascular. That is the problem. The problem is that the terrorist is extravascular and the army is intravascular. How I can make them fight till they can't meet? If we want to make them fight, we have to meet them. We have to meet them. Then only they can fight. Otherwise, they cannot fight. So there are 2 possibilities to meet them. One is extravascular, one is intravascular. Either take the terrorist inside, take the bacteria inside. No, it's a bad idea because bacteria will spread everywhere in all the organs. It will cause the infection. That is sepsis. We cannot afford that. The other way around, take the army out. Yes, it sounds good. So take the army out. Take WBC out. For taking WBC out, I require 11 steps. And that's the steps. So I will teach you 11 steps one by one. Okay. Got my point? I will teach you all 11 steps one by one. Anyone have any doubt what you are asking? Good teaching, almost covered like live session. Oh. Okay, listen. So I'm going to teach you all 11 steps one by one. Hana, in this master diagram, we will understand with the help of the terrorist and WBC. So it is not one step, just take the WBC out and make them fight. It requires 11 steps. Hana. So there are 5 vascular. First, let's finish them. And then 6 cellular. Let's first after come on that. So start with the vascular events. Okay, now understand this. Listen, this is the terrorist. Now you can see this is the terrorist. So the portion of the blood vessel just below the terrorist, just below the microorganism. Jaise hi microorganism aaya, this is the microorganism or the terrorist. So this portion of the blood vessel, it get afraid, it get vasoconstricted. It is transient. Only for few seconds, vasoconstriction is there. Transient vasoconstriction. So the step number 1 is transient vasoconstriction of the blood vessel. It is focal blood vessel just below the terrorist. Step number 1. Step number 2, the same blood vessel undergo vasodilatation now, which was first undergoing vasoconstriction. So first reaction is vasoconstriction. This is the earliest change. But the point is that it's transient. It's transient in nature, only for a few seconds. After that, it's vasodilatation and this one is persistent and prolonged. It is for many years. It is persistent and prolonged. Just suppose this is the point. Hannah, I'm talking about this is my skin. Imagine just below that there is a terrorist, and just below that there is a blood vessel. So blood vessel of that portion undergo vasodilatate. So if I'm looking from above over here, this area will look more red to me as compared to surrounding area because it is having more blood. It is vasodilated. So this area will look redder to me. And if I touch this area, it is more warm. The temperature is more as compared to surrounding areas because this area is having more blood. So because this areas have more blood as compared to surrounding area, it is red and it is warm. So out of the 5 cardinal signs, I have proven 2 here. I have proven 2 here, rubor and calor. Rubor and calor. You got my point? So rubor and calor, I have proven it here out of the 5 cardinal signs. Have you ever have experience of mosquito bite? I'm having many. So everyone have, at least you have seen if the mosquito is biting or any insect is biting, what happens. So that area become red. Imagine that area is warm as compared to, so it's the best example you can imagine here, mosquito bite. Hannah, so whatever happening to you one by one, it's like this only. Hannah, it is the best example. You can imagine it here. Okay, can we go ahead? So persistent vasodilatation. Persistent vasodilatation is there. The second step is vasodilatation, in which that portion of the blood vessel undergo. So first there is vasoconstriction, then there is vasodilatation. Now the third step, you have to understand Starling's law to understand the third step. You know there are 2 types of pressures in a blood vessel who are holding: outward pressure and inward pressure. Outward pressure is hydrostatic pressure. Inward pressure is oncotic pressure. Now I'm saying there is vasodilatation. Vasodilatation means more blood. More blood means more water. More water means hydrostatic pressure will rise. Oncotic pressure is due to protein. Protein wala nahi बढ़ रहा है. Hydrostatic pressure is due to water. It is rising. So outward pressure increases and inward falls. Normally outward and inward they cancel each out. But here the outward is more. Inward is less. So you know the fluid is coming out. The fluid will come out and it will accumulate over here. The fluid will accumulate over here. It will lead to edema. It will lead to edema, that is tumor. Only fluid is coming out. So it will lead to edema or tumor, step number 3. Anna, so till now we have seen 3 steps. Can you summarize? Out of the 5, I want to teach you 5 vascular events. Anna, then 6 cellular. I want to teach you 5 vascular. I taught you 3. I taught you 3 till now. Okay. So what is the first event? Say ma'am, vasoconstriction, which is transient. Second is vasodilatation, which is persistent. Okay. And third is increased hydrostatic pressure. Till now I taught you 3. Anna, the first don't have any consequence. Second step lead to rubor and calor. And third step leads to edema. Edema. That is transudate type of edema. I will explain you what do you mean by transudate type of edema. Got it? Anyone have any confusion? Can I go to the next one? The 4th step. Now I'm saying you why we are doing all this. Why? What is the purpose? You say that, ma'am, you told us we want to take WBC out. We want to take the army out so that it can fight with the terrorist. We want to take this WBC or army out so that it can fight with the terrorist. That's why we are doing all this stuff. Anna. So I will say, is it possible to take WBC out? Because if you see the wall of the blood vessel, it's continuous. There is no gap. There is no gap. If there is no gap, how you will take the WBC out? You have to create the gap. The 4th step is the main step. The main step is the 4th step. That is creation of gaps. Can you see the diagram? Can you see the blood vessel? Can you see the wall of the blood vessel? I have created the gaps. I'm not taking the WBC out right now. I will take it further in the next step. But currently I'm creating the gaps. From this gap, I will take the WBC out later on. So creation of gap is known as increased vascular permeability. Increased vascular permeability is creation of gaps. Creation of gaps is known as increased vascular permeability. Creation of the gaps from which this WBC will come out. This is the hallmark of acute inflammation. Out of the 11 steps which I am teaching you, this is hallmark step. You get a question on that. Out of the 11 steps, what is the hallmark step? It is increased because creation of gap is ultra important. If you can't create a gap, you cannot take the WBC out. है ना? Now WBC तो बाद में बाहर आएगा. We will take WBC later on. The gaps are created right now. है ना? So before the WBC come out, the protein is coming out. The protein from the gap leak out. है ना? So we already have the fluid over here. है ना? Initially we have only fluid. So it was transudate edema. Now the fluid में protein भी आ गया. The proteins are also leaking out. So the fluid along with protein, such a edema is known as exudate edema. Now the edema from transudate get converted to exudate. So now we have exudate type of edema. Can you see the 3 diagrams? I will explain you. See the first diagram. See the wall of the blood vessel. It's continuous. There is no gap. I can't see any gap. I can't see any gap. I can see the endothelial lining. It's continuous. No gap. And outward pressure is equal to inward pressure. So no edema. No edema. See the second diagram. Still the wall is continuous. There is no gap. I can't see any gap. The wall is continuous. I can see, but outward pressure is more, inward is less. You can see the arrow size. Outward is more and inward is less. So it will create an imbalance. And that's why the fluid is coming out, not anything else. Only the fluid is leaking out. So you can see the fluid is accumulating over here. Accumulating over here. The fluid is leaking out. And this edema is known as transudate edema. It contains only fluid. Only fluid is coming out. Now see the third diagram. See the third diagram. You will understand. See, the gaps are created. I want you to appreciate the gaps. I want to appreciate these small gaps, from which the protein will also leak out. Fluid to tha hi tha. Fluid was already there. But along with the fluid, you can see the dot is there. Okay. The protein will also leak out. The protein will also leak out and accumulate in the background. So now, fluid with protein, with cells will also leak out. Such edema is known as exudate. So still edema is there. Yahan bhi edema hai, yahan bhi edema. But it will exaggerate. How many of you got it? How many of you got it? Say, everyone? Everyone got it? Okay. So please say. So this is the thing. Just a second. Okay. So I taught you 4 steps out of the 5. 1, 2, 3, 4, 5. The first step I taught you is vasoconstriction, which is transient. The second is vasodilatation, which is persistent. Third is increased hydrostatic pressure. And fourth is increased vascular permeability. What is the consequences of this? Here we don't have any. Here it will lead to rubor and calor. Here it will lead to edema. Here it will lead to edema. But this one lead to transudate edema and this one lead to exudate edema. So you have 2 questions over here. 2 PYQs over here. So which step lead to transudate edema? Answer is increased hydrostatic pressure, step number 3. And which step leads to exudate type of edema, which contain protein and cells also? So this is increased vascular permeability. That is 4th step. Out of all the steps, this step is the hallmark step. Ye bhi question hai. This step is the hallmark step. Okay, what is the question, Amit? Please write down your question. Amit, Raj, you want to ask some question? Please write down specifically. Okay, I'm sorry if I'm missing some question. In the chat, please write down relevant stuff. If you have some query, write down. Otherwise, you can give what you say, emojis, that you got it. You can give a thumbs up. I will get that you got it. If you have any query, otherwise your doubts will get diluted. I will miss some. Okay, if you have any doubt, please write down. Okay, so till now we have covered the 4th step, and now I'm coming on the 5th and the last. The 5th and the last step in the vascular events is the stasis of the blood. The blood have stasis over here. Blood ruk jayega. It is stasis. So these are the 5 steps we are done. We are done with the 5 steps. Now read the question and tell me the answer. Can you read the question and tell me the answer? Yes, please read the question. We are done with 5 vascular events. And now I will start with 6 cellular. First, we will complete the questions of the 5 vascular and then we will come on 6 cellular. Chalo, read the question and tell me the answer. Can you tell me the sequence of events in the acute inflammation? What is the sequence of event in the acute inflammation? Quick, fast. I told you. Now, this is a very favorite question. Repeatedly asked. Yes, what is the correct answer? So first there is vasoconstriction. Then vasodilatation. Then increased hydrostatic pressure is not given. Step number 3 is missing. Step 4 is increased permeability. Step 5 is stasis. So this is the correct answer. Answer is D. Can you identify? No, not C. Vasoconstriction is there. Vasodilatation, but stasis is the last step. You have to learn the sequence. First is vasoconstriction, then vasodilatation, then increased hydrostatic pressure, increased vascular permeability and stasis. Learn it. I've shown you the diagrams, the corresponding diagrams and their consequences also. Please learn the sequence. Please. I request you to learn the sequence. Okay. So you get a question on the sequence very frequently. Okay. The next question. First to appear in the acute inflammation. Can you tell me what appears first? What is the earliest step? Is it vasodilatation, vasoconstriction, increased vascular permeability or decreased vascular permeability? What is first to appear? What is first to appear? The first to appear is the vasoconstriction. Although it's transient, but it is the earliest step. Okay, it is the earliest step. Okay, all of the following are vascular events except. Which of the following is not a vascular event? All of the following are vascular events except. Which is not a vascular event? Can you tell me which of the following is not a vascular event? All of the following are vascular. So vasodilatation occurs. Yes, step number 2. Stasis occur. Yes, step number 5. Increased vascular permeability. Yes, it's the hallmark step number 4. But is it decreased hydrostatic pressure? No. It is increased hydrostatic pressure which occurs in step number 3. So incorrect among them is D. Yes, it should be increased hydrostatic pressure. Absolutely right. So we are done with 5 vascular events. Let's quickly finish 6 cellular. So total 11 are done. Okay, let's come on the 6 cellular events quickly. Okay, what are the 6? What's the summary of the 5 vascular? First tell me. This is the summary. In the vascular events, we have already created a gap. Gap is already there. We have already created a gap. Okay, here the gap is already there. Now we want to take WBC out of this gap. And for that we require 6 steps. Okay, that's the cellular 6 steps. You got it? Now gap is already there. You will say, ma'am, why 6 steps are required? You already have the gap now. Just take the WBC out. Why you require 6 steps over there? There is a problem. The problem is that Bernoulli's theorem. Have you heard about Bernoulli's theorem? What does the Bernoulli's theorem says? Now this is the a hollow vessel. For example, this is a pipe. In a pipe, whenever any fluid travel, the Bernoulli's theorem says that heavy portion in the fluid travels at the center and the light portion travels at the periphery. The light portion travels at the periphery. This is the Bernoulli's theorem. Now let's imagine the blood vessel is also a vessel. The blood vessel is also a hollow vessel inside which we are having 4 things: RBC, WBC, platelet and plasma. Who is heaviest? Unfortunately, heaviest is the WBC. So WBC travels at the center. Surrounded by RBCs, which is lighter, relatively lighter. Surrounded by platelets, which are more lighter. This is platelet, and most surrounded by plasma, the lightest. So here we have plasma at the most periphery. Now here is my gap. Here is my gap. I want to take WBC out, which is present at the center. So if it was good, if the WBC present at the periphery, we can take it directly, but we cannot take it from the center to the outside. First, we have to take the WBC from the center to the periphery, and then we have to take it outside. That's why it requires 6 steps. Now, what are the 6 steps? Now see, all 6 steps are shown in this master diagram. Please have a look. Concentrate. Please concentrate. Can you see? This is a WBC present at the center. This is the WBC which is present at the center of the blood vessel. First, WBC leave the center and come at the periphery. Leave the center, come at the periphery. So when the WBC is at the center, it's known as axial blood flow. It is leaving the center and coming at the periphery. It's reverse axial blood flow. So this step is known as margination. The first step is margination because WBC is coming at the margin. This is margination. This one is margination. After that, we have a gap at certain distance. This is the gap, but it is at certain distance. So WBC has to roll till there. So second step is rolling. WBC is rolling, 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 rolling. Rolling like a tire on a road. Again, I repeat. Rolling like a tire on a road. So this is the second step, rolling. Okay, second step is always rolling. You can see just before the gap, it will stop. It will stop. That is adhesion. Okay, that is adhesion. After that, it comes out. This is known as transmigration, also known as diapediasis. Transmigration or diapediasis is one and the same thing. So fourth step is transmigration or diapediasis. It's coming out, the most important. Now, after coming out, WBC don't have eyes. It's a 3-dimensional space. WBC don't have eyes. Here is the bacteria, here is the bacteria. I have to move here. I don't have to. How does WBC come to know? This way I have to go, this way I do not have to go. How does WBC come to know? So bacteria will secrete certain chemicals. The microorganism, the terrorist will secrete that will attract the WBC. That I am here, just come and fight me. So the movement is towards the chemical. It is known as chemotaxis. Can you see the next step? It's chemotaxis. The WBC is moving towards the organism, which is a chemical gradient oriented movement. Chemical oriented movement. That is chemotaxis. And finally, the WBC will eat the bacteria. Can you see the WBC is engulfing the bacteria? It is engulfing the bacteria. So last step is phagocytosis. Can you close your eyes and tell me the 6 steps? First, tell me the sequence. First, WBC leave the center and come at the periphery. That is margination. After coming at the periphery, it will roll. Rolling. Just before the gap, it will stop. That is adhesion. Okay. After that, it comes out. That is diapediasis. Diapediasis. It will come out. After coming out, it will move towards the bacteria, which is a chemical oriented movement. That is chemotaxis. And after that, it will eat the bacteria. That is phagocytosis. Phagocytosis. So 1, 2, 3, 4, 5, 6. These are the 6 steps. I hope everyone got it. So learn the sequence of the 6 steps. You get the question on the 6th. Margination, we will see the little bit detail and end it. Okay. So margination, I told you, axial blood flow convert into reverse axial blood flow. Reverse. You see WBC leaving the center and coming at the periphery. Axial convert into reverse axial. After that, rolling. Can you see the WBC is rolling like a tire on the road. And then adhesion. Just before the gap, it's stopping. So margination, rolling, adhesion. Now, how does rolling adhesion takes place? And the next is the transmigration. It's coming out. It's coming out of the gap. How does rolling adhesion and transmigration takes place? It's with the help of the receptor. It's with the help of the receptor. You have to learn the pairs of the receptor. You know, I always say road and tire. Now, listen, this is the road and the tire. Who's the road? Who's the road? The road is the endothelium. Please understand, the road is the endothelium. This is the endothelium. This is the road. This is the road. Okay, the cells of the endothelium. And who's the tire? Who's the tire over here? The tire is the WBC. The WBC is the tire. So can you see there are pairs? Can you appreciate the pairs of the receptors? These are the pairs. These are the pairs of the receptors. Hana? So because of the bond formation between them. So the bond form between them, then again break. Then again the bond form, then again break. In this way, transient bond formation, it will roll, adhesion and comes out. So it is with the help of receptor. You have to learn these pairs. There are 6 pairs. You have to learn the pairs. In each pair, which component, which receptor present over the road and which component is present on the tire in each pair. So learn the pairs. So let's talk about the first 2 pair on the endothelium, that is on the road. And this is the tire. The WBC is the tire. Hana? On the road, we have P-selectin and E-selectin. Hana? They will form bond with Cellular X. Let me show you. Can you see here is P-selectin, here is E-selectin. Can you see this is P-selectin, this is E-selectin. They are forming bond with Cellular X there. Cellular X on the tire. It's Cellular X. Cellular X. So you have to learn the 2 pair. First pair is P-selectin Cellular X. Second pair is E-selectin Cellular X. You have to learn the 2 pairs. The third selectin, there are 3 selectin. The third selectin is L-selectin, which is present on the WBC. L for leukocyte. So the third selectin present on WBC and it form a bond with glycan. So see, L-selectin. These 2 selectins are present on endothelium. The third selectin present on the WBC. It form a bond with the glycan. Glycan के 2 बड़े भाई हैं. Glycan के 2 बड़े भाई हैं, ICAM and VCAM. है ना? They form bond with the beta-2 integrin. Beta-2 and beta-1 integrin. So glycam, ICAM, VCAM, beta-2 and beta-1 integrin. And finally, last pair is PCAM with PCAM. The last pair is common. PCAM CD31 or PCAM with CD31. So there are 6 pairs. You have to learn first 6 pairs. Say yes if you got the 6 pairs. Can you help me in writing? Tell me what is present on endothelium, that is road, and what is present on WBC, that is tire. First tell me. Tell me the pairs. So I will write 3 selectin. P-selectin, E-selectin, and third is L-selectin. Okay, now tell their pairs. Huh? P-selectin and E-selectin, they form bond with Cellular X. This is how I learn. L-selectin will form a bond with glycam. Glycam के 2 भाई, ICAM and VCAM. है ना? They form bond with integrin. है ना? Beta-2 integrin and beta-1 integrin. And last pair is very simple, PCAM with PCAM. PCAM also known as CD31. CD31 with CD31. Now you have to learn which pair is responsible for what. Okay, which pair is responsible for what. Okay, the first and the third pair is responsible for rolling. The fourth pair is responsible for, fourth and fifth is responsible for adhesion. Okay, है ना? And last pair is responsible for diapediasis, PCAM wala, diapediasis. And the second pair is responsible for both rolling and adhesion. You get many questions on this. E-selectin and Cellular X is responsible for both. This one is responsible for both. This is rolling. This is adhesion, and this is, you can see, the PCAM wala pair. It is responsible for transmigration. Okay, if you got it, it's good. You get many questions out of that. Okay. It's not very hard to remember. Dr. A. Anna, if you make the table and don't change the sequence, it's easy. It's easy to go. So this is how transmigration takes place. Now, the next is the chemotaxis. How does the chemo, once it is out, name the chemical which is secreted by the bacteria which is attracting it. Name the chemical. There are 4 chemicals. Hana, there are 4 chemicals. One is leukotriene, one is interleukin, and 2 are complement. Leukotriene is B4. Interleukin is 8. And complement is C3A and C5A. You have to learn the numbers. Out of it, C5A is most potent. Ye bhi PYQ. So please learn. Hana. So leukotriene B4, interleukin 8, C3A and C5A. These are the 4 chemicals secreted by the bacteria which attract it. You get questions on that. And finally, there is phagocytosis. You know, the WBC is eating the bacteria and the job is done. All of them are done. Okay, we are done. Finally, read the question, tell me the answer. Read the question, tell me the answer. Okay. Read the question, tell me the answer. What is the correct sequence of the cellular events? What is the correct sequence? I'm asking. Yes, first there is margination, then rolling, then adhesion, then transmigration. Absolutely right. The last 2 are not given. After that, chemotaxis and phagocytosis. Okay, which is important for diapediasis? Very important question. It is PCAM. PCAM with PCAM, the bond between PCAM and PCAM. Okay, chemotaxis ke liye I told you four chemicals now. Leukotriene B4, okay, interleukin 8, complement C3A and C5A. So what's the correct answer among them? You can match. So it is leukotriene B4 and C5A. C5 is the most potent. You have to learn the name of the chemicals. Okay, we are done with acute inflammation. Now, one more thing I want to teach you here is the granulomatous inflammation. So, inflammation chapter will be over. So, today I will teach you granulomatous inflammation, that is chronic inflammation. After this, I will start, I will teach you main points in the genetics. I mean the examples of autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive, only example portion. Hypersensitivity, again the mnemonics and the example wala portion, because it is a last time revision. I cannot give you the mechanism of each of them. And from the neoplasia, I want to teach you few important topics. That is the differences between benign versus malignant, metastasis, and tumor markers. So these all findings will be more important in the general, but currently we will take a break. Hana. So we will take a small break, 30 minutes break, and after that we will continue with the session. So currently I'm going to teach you 3 hours more, approx 2 to 3 hours more after the break, in which I will try to finish all these topics. So that general pathology may say any question coming, you can do it. And tomorrow we are going to start with the hematology and systemic pathology. Important topics. Say yes if you all got it. So let's take a small break. Currently it's 12:05. I will come again at 12:35. So there is break till 12:35 for half an hour, 30 minutes. I request you, to have a cup of tea, coffee, refresh yourself for 30 minutes and come back after 30 minutes. After 30 minutes, we will continue with the chronic inflammation, granulomatous inflammation, which is an ultra important topic. After the break, we are having 2 to 3 hours more in the lecture. All the topics still it is not finished. We are not going to end it. So please come back. Okay. So I'm not ending it. In the same link, you will get it. Okay, G. After 30 minutes, we will meet again, each and every one of you. Okay. Hello there. Am I live? Am I back? Can you see? Can you hear? Can we continue? Kindly write down in the chat box if clear everything is good to go. I guess it's good. So can we continue? Okay, thank you. Thank you for responding. Okay. So let's continue with the inflammation. So we have already covered acute inflammation and now we are coming up with the chronic inflammation. So we are studying the general pathology as a compact crash course in which we are covering all the important topics of general pathology today, Hannah, for the FMG preparation. So acute inflammation is over. I taught you the 11 steps of the acute inflammation and now I am teaching you the 3 steps of the chronic inflammation. In chronic inflammation, the granulomas are formed. That's why chronic inflammation is also known as granulomatous inflammation. Okay, so what are the 3 steps? I will draw the 3 steps for you. Imagine there is an antigen enters in human body. The property of this antigen, it's a non-degradable antigen. Hannah, for example, it is Mycobacterium tuberculosis, Mycobacterium leprosy, or talcum powder, or any non-degradable antigen when enters in human body. The first cell with which it comes in contact, the first cell with which it comes in contact is antigen presenting cell, APC, antigen presenting cell. The antigen presenting cell will engulf it. The first step is engulfment. The antigen presenting cell is engulfing the antigen, try to degrade it, but unable to degrade it because it is a non-degradable antigen. If it was a degradable antigen, the story was over. But here it is a non-degradable antigen. So it will carry this antigen to the next cell. Who's the next cell? That is the second step. The next cell is helper Th1 cell. CD4 lymphocytes, helper Th1 cell that will get stimulated. So APC is giving the signal to the helper Th1 cell that there is a non-degradable antigen who entered human body and I have engulfed it, I am unable to degrade it. So this helper Th1 cell will secrete 3 cytokines from it, the third step. It will secrete 3 cytokines from it. I will tell you the names of the 3 cytokines. You have to learn the name of the 3 cytokines. The first cytokine is interferon gamma. The first is interferon gamma. The second is interleukin 1, 2, 12. Many interleukins are there. And third is TNF. These are the 3 cytokines which is secreted by helper Th1 cell. What does these cytokines will do? What does these cytokines will do? All these cytokines will take one cell out of the blood vessel and accumulate and form a granuloma. So which cytokine is taking which cell out? Let's talk about interferon gamma. Interferon gamma will take the monocyte out. In the blood we have monocytes. We have 5 types of WBC. One of them is monocytes. So interferon gamma take the monocytes out of the blood vessel. Once the blood vessel are monocytes are out of the blood vessel, they are known as macrophage. They are no more monocytes now and they are known as macrophages. So once the monocyte out of the blood vessel, they are known as macrophages. Interferon gamma not only taking the monocytes out, they are modifying it also. So making their nucleus more vesicular and causing the vacuoles in the cytoplasm. So a modified macrophage is known as epithelioid cell. So they convert the macrophage into modified macrophage, that is epithelioid cell. And after that, multiple epithelioid cell fuses together and they form the giant cell. So all this work is done by the interferon gamma. So can you tell me the summary of the interferon gamma? What does the interferon gamma is doing? The interferon gamma is taking the monocyte out of the blood vessel, converting into macrophage, modifying the macrophage, converting into epithelioid cell and fusing the epithelioid cell together and form few giant cells. So this is all done by interferon gamma. Let's come on the next cell, the next cytokine, that is interleukin 1 and 2. Interleukin 1 and 2 take the T lymphocytes out. They just take the T lymphocytes out and they cause the migration and proliferation of the T lymphocytes there. And finally, let's come on the TNF. TNF take the fibroblast out. They just do the proliferation and migration of the fibroblast. So finally, we are having all these cells. They will rearrange themselves and they form a granuloma. So basically, the epithelioid cells and the giant cells, they form the center of the granuloma. Okay, I will draw on the next page. The T lymphocytes will form the middle zone of the granuloma and finally the fibroblast will form the outermost zone of the granuloma. So end result is granuloma. This is chronic inflammation. These are the 3 steps of the chronic inflammation. So how does the granuloma is formed? In the center, we have epithelioid cells and few of them fuses together to form the giant cells. So this is the center. The center is formed by epithelioid cells and giant cells always. The middle zone is formed by the T lymphocytes. You can see this is the middle zone. It is formed by T lymphocyte. And outermost zone is formed by fibroblast. You can see this is outermost zone and this one is formed by, this is the outermost zone. It is formed by fibroblast. So you can see the 3 layers in front of you. The central zone is formed by epithelioid cells. The middle zone is formed by T lymphocytes and outermost zone is formed by fibroblast. And you know the which cytokine is responsible for which of them. This is granuloma. Granulomas are of two types. This is a hard granuloma. It don't have caseous necrosis at the center. Sometimes the center have the caseous necrosis. It is known as soft granuloma. Granuloma or tubercle, whatever you say. So this is the pathogenesis of the chronic inflammation. Everyone give me a thumbs up if you got it. So what is chronic inflammation? The 3 steps. The first step is the engulfment by the macrophage. The same story is shown to you. You can see this is a granuloma. So first engulfment by the macrophage. So as soon as the antigen is coming, macrophage antigen presenting cell is engulfing it, try to destroy it, but unable to destroy it. Then it is presenting to CD4 T lymphocyte helper Th1 cell. And it is secreting 3 cytokines. It is secreting interleukins, interferon gamma and TNF. All the 3 cytokines accumulating the 3 type of cells. Interferon gamma accumulate the macrophage and convert into epithelioid cell. Interleukins accumulate the T lymphocyte and TNF accumulate the fibroblast. And finally, they form a granuloma. The structure of a granuloma is in front of you. Okay, how many types of giant cells you know? How many type of giant cells you know? There are three type of inflammatory giant cells. The fourth one is the giant cell in tumor, not important. 3 type of inflammatory giant cells are there. What are the 3 type of giant cells? Foreign body giant cell, Langerhans giant cell and Totten giant cell. What is foreign body giant cell? In foreign body giant cell, all the giant cell have multiple nucleus. But in foreign body, the nucleus is present haphazard anywhere in the cytoplasm. Can you see it's haphazard? Anywhere in the cytoplasm. There is no fixed pattern. That is foreign body giant cell. In Langerhans giant cell, the nucleus is present at the peripheral 2/3. It is at the periphery 2/3. Peripheral 2/3. It is known as horseshoe ring shaped nucleus. Horseshoe ring shaped nucleus. Or it is present at the 2 poles. Or it is polar in nature. It is present at the 2 poles. It is present at the 2 poles. Langerhans. And third is Totten. In the Totten, the nucleus is forming a ring. Can you see? The nucleus is forming a ring at the center and the cytoplasm contains the vacuoles. This is Totten type. So there are 3 type of giant cells. Sometimes you get an image-based question or theory question on the giant type of the giant cells. So foreign body giant cells, the nucleus is scattered through the nucleus, throughout the cell. Langerhans giant cell, the nucleus is present either in the horseshoe or at the 2 poles. And in Totten giant cells, the nucleus will form a ring and the vacuoles are present in the cytoplasm. That is the 3 type of giant cells. Now, sometimes you get an MCQ on special type of granuloma. I told you the structure of the granuloma. In the center, we have epithelioid cells. In the middle zone, we have T lymphocytes. And in the outermost zone, we have fibroblasts. There are no neutrophils. Normally, granuloma don't have neutrophils. But there is a special type of granuloma which is known as naked granuloma. Okay. They have only epithelioid cells and giant cells at the center. Okay, they don't have T lymphocytes and fibroblasts. That's why they are known as naked. They have only central zone. They don't have middle zone and outer zone. So there is only epithelioid cells and giant cells at the center, and they don't have the outer rim of the T lymphocytes. Okay, the second is a stellate granuloma. Stellate का मतलब होता है star shaped. What do you mean by stellate? Stellate का मतलब होता है star shaped. Can you see here? The granuloma is star shaped. The granuloma is star shaped. It is seen in cat scratch disease and lymphogranuloma vanorum, LGV. Learn 2 examples, you get question on that. Anna. And this is a special granuloma. The center contains the neutrophils. Normally, granuloma don't have neutrophils, but it is a granuloma in which the center have the neutrophils. So it is a special type of granuloma. And finally, you have to learn the examples of granulomatous inflammation. How many examples you know? Of granulomatous inflammation के कितने examples तुम्हें पता है? How many examples you know? There are 8 bacterial. You can read the names. It is TB, leprosy, syphilis, LGV, brucella, cat scratch, tularemia, glandus. These are the bacterial. There are 4 fungal examples. Actinomycosis, blastomycosis, cryptococcidio. There is 1 parasite, schistosomiasis. And there are many miscellaneous like sarcoidosis, Crohn's disease, silicosis, berylliosis. These are the foreign body, these are the miscellaneous granulomas. So these are the examples of the granulomatous inflammation. Sometimes you get questions on the examples. Read the question. We are done with chronic inflammation also. Read the question. Granulomatous inflammation is seen in all of the following except. So the question is based on the examples. You can read the question. Is it Mycobacterium TB, Mycobacterium leprosy, Yersinia pestis and Mycoplasma, which is not present in this list? Which is not present. So Mycoplasma is not coming. Okay, I told you the name of the 8 bacteria and these are among them. Okay, so you have to learn the list. Okay, I'm skipping the questions. This question is very common, very frequently asked. Stellate granuloma is a feature of. Is it seen in Crohn's disease, cat scratch disease, Hodgkin's disease, or berylliosis? So very frequently asked, stellate granuloma is seen in cat scratch disease and LGV. It is a special type of star-shaped granuloma. The center contains the neutrophils. It's a very common question. Okay, so we are done with the important topics here, and now I'm teaching you few important topics in the hemodynamics followed by neoplasia. Okay, chalo. So let's come on hemodynamics. Let me teach you the next important topic, edema. What is edema? Okay. Human body is made up of organs. From head to toe, we have multiple organs. Imagine this is any organ. Let me draw organ. Imagine this is any organ. All the organs are made up of cell. These are the cells of that organ. This can be kidney, this can be spleen, this can be liver, this can be any organ. I want to teach you the space between the organ is known as interstitial space. Can you see the space? I'm talking about this space. The space between the cells in any organ, the space between the cells is known as, interstitial space. Can you see? So this is interstitial space. Normally nothing is present in the interstitial space. The interstitial space is dry. Normally the interstitial space is dry, person don't have edema. If fluid comes in the interstitial space, it is known as edema. So what is the definition of edema? Edema in layman language, it is known as swelling. Swelling of any part of the body. You can see swelling. Hindi में कहते हैं सूजन आ गई. So person is saying कि डॉक्टर साहब मुझे सूजन आ गई है, मुझे swelling है. At any part of the body there is swelling. है ना? So what actually edema is? Edema is accumulation of fluid in the interstitial space. Can you see? This is the interstitial space. So if there is accumulation of fluid in the space between the cell, it is known as edema. So first you learn the definition. It is abnormal and excessive accumulation of fluid in the interstitial space. That is known as edema, number one. Okay, what is the effusion? Effusion is the term related to the edema. Okay, you know human body have certain cavities. We have pleural cavity around the lungs. We have pericardial cavity around the heart. Okay, if the fluid get accumulated in any cavity, like the pleural cavity, like the pericardial cavity, it is known as effusion. So edema and effusion, the pathogenesis is same. Whether I say edema or whether I say effusion, the pathogenesis is same. Edema is accumulation of fluid in interstitial space, and effusion is accumulation of fluid in cavities. So pathogenesis of both of them is same. Now the thing is that why does edema occur? Or why does effusion occur? To understand this, you have to understand the Starling's law. There are 5 causes of edema. Frequently you get questions on that. So we will see the 5 causes of edema. Let me tell you the 5 causes of edema. Listen, please understand. Can you see? This is the organ. These are the cells of the organ. You know all organs are supplied by capillary. Hai So organ is supplied by artery. Let me draw organ for you. So this is the organ. Okay, the organ have the cells in that. Hai This is the artery supplying blood to this organ. This is the artery coming to this organ. So after supplying the blood, it is the vein which is coming out. And in between the organ, artery will split into the capillaries, and capillaries combine together to form the vein. So basically organ have the capillaries. So on the next page, I'm drawing the capillary inside the organ. So this is the organ. These are the cells of the organ. And this is the capillary. Let me draw capillary. This is a capillary. So capillary have 2 ends. This is the arterial end of the capillary from which pure blood is entering. Supplying the blood to this organ. And this is the venous end of the capillary. It is meeting with the vein from which impure blood is coming. So my question to you, how does pure blood, oxygenated blood, get converted to deoxygenated blood while it is passing through the organ? Why the blood convert from oxygenated to deoxygenated in a capillary? Capillary have 2 ends, the arterial end and the venous end. How many of you got it? The capillary have 2 ends, the arterial end and the venous end. And how does the blood get converted from the oxygenated to deoxygenated? I'm asking you. Does anyone know the answer? Does anyone know the answer? Yes or no? So listen. You have to understand 2 types of pressure. Hydrostatic pressure and oncotic pressure. Hydrostatic pressure is due to water. Okay. And oncotic pressure is due to protein. So oncotic pressure everywhere is 25. Here also it's 25 mm. Here also it's 25 mm. Oncotic pressure is always same. But hydrostatic pressure changes. At arterial end, the hydrostatic pressure is 38. Don't learn the figures. It's for your understanding. And here, the hydrostatic pressure is only 12. By reaching here, hydrostatic pressure fall and it is only 12. Hydrostatic pressure is outward and oncotic is inward. Now you tell me here which is more. Of course, hydrostatic is more than oncotic. So outward is more than inward by a figure of 13. 38 minus 25 is 13. So by 13 mm, the fluid will go out. The fluid will go out. The fluid will go out, and here, which is more? 25 is more. I mean oncotic pressure. Again, the difference is 13. But this time, this 13 is inward. This 13 is inward. So basically, as soon as the blood is coming, listen. As soon as the blood is coming and entering here, the blood is coming and entering here. After entering with 13 mm, the fluid goes out, does the exchange. Gives oxygen to the cell, take carbon dioxide. Give oxygen, take carbon dioxide. Does the exchange, and here, the same 13 mm, it is coming in. So with whatever pressure the fluid goes out, after exchange, the fluid comes in. So tissue remains dry in the end. We don't have edema. This is the reason we don't have edema. You know, the outward and inward pressure is balanced. Outward pressure is hydrostatic and inward pressure is oncotic. How many of you got it? Give me a thumbs up if you got this. Huh? So this is normal. At each and every level in our organ, this is happening. You know, the net outward is equal to net inward. It is 13 mm. With 13 mm, the fluid goes out, does the exchange. With 13 mm, the same fluid comes in. So 13 is equal to 13, they cancel each out. Hana? Now imagine a person in which outward is more. Outward pressure, hydrostatic pressure is more. So more fluid will come out, but the inward is less. Less will. Imagine the fluid is coming with 20 mm and going back by 13 mm. So you know the remaining fluid will accumulate. Or else, the outward is normal, but inward is less. Either the outward pressure is more, so more fluid is coming out, or inward is less. Inward is less. In any of the reason and any of the cause, there is accumulation of the fluid. So what are the two causes of the edema? The two causes of the edema is increased hydrostatic pressure or decreased osmotic pressure. Any of them, if there is accumulation of the fluid. We want outward is equal to inward. But if outward is more and inward is less, it will lead to edema. How many of you got it? Please give a gesture that you got it. So these are the two. So same story. You don't have to learn. This is the physiology. You may have read this in physiology. So normally outward is equal to inward. With whatever pressure the fluid is coming out, with the same pressure it goes in. 13 mm is equal to 13 mm. But if outward is more or inward is less, I mean increase hydrostatic pressure or decrease osmotic pressure, that will lead to edema. These are the two causes of the edema. You know, there are lymphatics. What is lymphatics? The lymphatics is the backup. Imagine if there is little bit of increase or decrease in the edema. God has given us backup also. Thoda sa zyada kam hai to backup bhi hai. So lymphatics will take care of the edema. The third reason, if the lymphatic got obstructed. By any reason, if the lymphatic got obstructed, the person can have edema. The backup, the lymphatics got obstructed. So I taught you three reasons. The outward is more, the inward is less, and lymphatic got obstructed. Now the fourth cause, outward is normal. Inward is normal, and lymphatic is open. Still the person can have edema. You say, ma'am, now why the person is having edema? You are saying outward pressure and inward pressure, they are equal. And the lymphatic is also open. Still the person can have edema. The fourth cause, the person can have more sodium in the body and more water in the body. More sodium and water, that will cause the edema. Still the pressures are normal and lymphatic is open. This is the fourth cause. And the fifth and the last cause of the edema, everything is normal. Outward, inward, lymphatic, normal sodium, normal water. Still the person have edema if there is gap in the capillary. You know, capillary mein gap. I told you in inflammation, increased vascular permeability. If the gaps in the capillary is there during inflammation, fluid will leak out. Fluid, that is known as increased vascular permeability, that is inflammatory edema. How many of you got it? Can you tell me the 5 causes of edema? You frequently get questions on that. What are the 5 causes of edema? Acha, before that, you tell me what is edema. What is edema? Who will tell me what is edema? What is the definition of edema? Edema is accumulation of fluid in interstitial space. Why does the fluid get accumulated in the interstitial space? Tell me the 5 reasons. 1, 2, 3, 4, 5. So first cause is, yes. What is the first cause? Increase hydrostatic pressure. The second cause is decrease osmotic pressure. The third cause is lymphatic obstruction. The fourth is sodium and water retention. And last is increased vascular permeability in inflammation. Due to any cause, the fluid get accumulated and it will lead to edema. You have to learn. You get a frequent question, MCQ, which of the following is a cause of edema? You will get one of them. Or which of the following is not a cause of edema? You will get 3 options from here and one something else. Okay, so you have to learn the causes of edema. Very correct, very correct. Please everyone reply, no? Please everyone reply. So these are the 5 causes of edema you have to learn. Now edema is of 2 types. Whatever cause it is of 2 types, transudate and exudate. These 4 leads to transudate type of edema. The last one, this one, leads to exudate type of edema. Let me explain you what is transudate and exudate. These are the 5 causes of edema we have seen. Okay, now what is transudate edema and what is exudate edema? Let me explain you. So I told you if only fluid is coming, you can see the 3 diagrams. I've already explained you this thing in the inflammation. You can see here the blood vessel is continuous. It is continuous. The wall of the blood vessel and outward is equal to inward, so there is no edema. In the second, you can see still the wall is continuous. But outward pressure is more, inward is less. So only fluid is coming, nothing else. So this is transudate. You can see only fluid is coming. Nothing else is coming. This type of edema is transudate, which contains only fluid, nothing else. But see the third possibility. There are gaps. In the wall of the blood vessel, there is gap. It's not continuous. So along with the fluid, you can see the protein is also coming and the cells are also coming. So if only fluid is coming, it's transudate. But along with protein, fluid, protein and cells are also coming. It's known as exudate type of edema. So this edema is known as exudate. So there are two type of edema. Transudate, exudate. Transudate is protein poor, cell poor. है ना? So it is having less protein and less cells. Less protein and less cells. But exudate is protein rich, cell rich. It is having more protein, more cells. Since here protein and cells are less, specific gravity is also less. है ना? Specific gravity is also less and LDH is also less. Here specific gravity is more and LDH more. है ना? And you have to learn the pH is opposite. Here pH is more and pH is less. pH is opposite. How many of you got it? So there are two types of edema. What are the two types of edema? Transudate and exudate. These are the two types of edema. Tell me their definitions. What is their definitions? Tell me protein किसमें ज़्यादा किसमें कम, cells किसमें ज़्यादा किसमें कम, specific gravity किसमें ज़्यादा किसमें कम, है ना? LDH किसमें ज़्यादा किसमें कम and pH किसमें ज़्यादा किसमें कम. हाँ? So this is protein poor, cell poor. This is protein rich, cell rich. So here protein is less, cell is less, specific gravity is less, LDH is less. Everything is more here apart from pH. Here pH is more and here pH is less. So pH is something that is opposite. Got my point? Got my point? Thank you so much for the compliment. Thank you. So can we move? So this is the two type of edema. Now read the question and tell me the answer. Increased accumulation of fluid in the interstitial space is known as. Of course, the question is very simple. Very simple. What is the correct answer here? The accumulation of fluid in the interstitial space is known as edema. It's very correct. The correct answer is edema. Okay. But if I change the question, instead of interstitial space, if I give you cavity, what is the answer now? If there is accumulation of fluid in the cavity, what is it known as? If there is accumulation of fluid in the cavity, what is it known as? Yes, it is known as effusion. In that case, the answer will become effusion. Okay. So the next question, edema is due to. I told you 5 causes of edema. No? Which one of them is given here? Is it increased oncotic pressure? Oncotic and osmotic pressure is same. Or is it decreased hydrostatic pressure? Or is it both of them? Or is it both of them? Or is it decreased lymphatic flow? What's the correct answer? What is the correct answer? What do you say? Let's see who is telling me the correct answer. What is the correct answer? No, you got confused. Dr. Amir? No, Dr. Amir is right. Dr. A. C is not the answer. I told you increase hydrostatic pressure and decrease osmotic pressure are the causes of edema. Here opposite is given. Here they are saying increase osmotic pressure. No, it cannot cause edema. And decrease hydrostatic pressure. No, it cannot cause edema. So both of them is incorrect. The only correct is decrease lymphatic flow, that is lymphatic obstruction. So lymphatic obstruction can cause the edema. So correct answer is D. Okay. So in this way you get many questions on that. The next topic I am teaching you here is thrombosis. What is thrombosis? Let me explain you what is thrombosis. Okay, what is a thrombus? Imagine I got a cut over here. So what will happen? I will bleed. And anyone have any injury over the body, the person will bleed. But for how long I will bleed? I will bleed for the next few seconds or few minutes. After that, the bleeding will stop automatically. Why the bleeding will stop automatically here? Because here there is a clot formation that will cause the sealing of the injured blood vessel. Otherwise, imagine if there is no clot formation, I'm having 5 liters of blood and all of that will leak out of the injured area. But that doesn't happen, thankfully. Thankfully, the God has given us the mechanism in which the clot is formed at the injured area. So whenever we have injury to the CVS, the clot is formed. This is known as hemostasis. This is a physiological phenomenon. It's not a disease. Hemostasis. Hemo means bleeding. Stasis matlab stoppage. It is stoppage of bleeding. Thankfully, we have this mechanism. Hana? So that is clot formation. Hana? If the same clot is formed without injury, imagine a blood vessel. This one is injured. Here there is an injury. You can see this is injured. And imagine a blood vessel which is not injured. This one is not injured. So if a clot is formed in an injured blood vessel, it's good. The platelets are coming and sealing it to stop the blood vessel bleeding. This is known as hemostasis. This one is good. It's physiological. But if the same clot is formed in an uninjured blood vessel, it's a disease. It's a disease. It's not good. It's harmful because it is causing obstruction in the way. In the way of the blood vessel, it's producing obstruction. And this one is known as thrombus. This one is known as thrombus. So thrombus is the clot formation in an uninjured blood vessel. How many of you got it? Give me a thumbs up. What is thrombus? Thrombus is the formation of the clot in an uninjured blood vessel. Hemostasis is formation of clot in an injured blood vessel. But thrombus is the formation of clot in an uninjured blood vessel. That is thrombus. You can see the clot is formed by the same mechanism. But the blood vessel is uninjured here. So what is the reason? What is the pathophysiology behind that? So there is a Virchow triad. We learn there is a triad which is known as Virchow triad. है ना? Virchow is the scientist who explained the 3 causes of the thrombus. What are the 3 causes? Now sometimes what happens, this is a blood vessel and this is the endothelium. Endothelium got injured. This is the reason where the endothelium is injured. It's not bleeding who's taking place. It's just endothelium injured. If the endothelium get injured, the platelet get activated and it will form the clot. Sometimes the platelet get activated and form the clot in a injured, only endothelium is injured. So endothelial injury is one of the cause. If the blood keep on moving, I told you Bernoulli's theorem. So plasma is at the periphery. At the periphery, we have plasma. At the center, we have WBC, and surrounding this, we have RBCs and platelets. So my point is that when the blood is flowing, platelet don't come in contact with the endothelium, but there is stasis of the blood. Due to any reason, if there is stasis of blood, the platelet will fall. Due to the gravity, the platelet will fall, and platelet will come in contact with the endothelium and form a clot here. So stasis is the second reason. The second reason is stasis. And third, sometimes the blood is hypercoagulable. So there are 3 causes. What are the 3 causes? Number 1, endothelial injury, stasis of the blood, and hypercoagulability. These are the 3 causes which is known as Virchow triad. Very important question. Repeated MCQ in your exam. Which of the following is not a component of Virchow? They will give you 3 options as this and 4th is something else. So please learn. Now I'm teaching you thrombus. I hope you all got what is thrombus. So imagine this is an organ. This is the artery of the organ. Okay, and this is the vein of this organ. Neither the artery is injured nor the vein is injured. Nothing is injured. So if the clot is formed in an uninjured artery, it's a thrombus. It is arterial thrombus. It is formed in the artery. And if the clot is formed in the vein, in an uninjured vein, it's a venous thrombus. This one is venous thrombus. So the clot can be formed in the artery. It can be formed in the vein. It can be arterial thrombus. It can be venous thrombus. They are not injured. If they are injured, it is good to form. It is hemostasis. But in an uninjured blood vessel, they can be formed. So thrombus are of 2 types. Arterial thrombus, venous thrombus. If it is formed in the artery, it's arterial thrombus. It is formed in the vein, it's venous thrombus. Tell me the effects. Here, arterial thrombus, pure blood cannot come to this organ. So the organ will have ischemia. It will result in ischemia and infarction. And here, if vein got obstructed, the impure blood cannot leave the organ. The organ will have edema. So arterial thrombus leads to ischemia, venous thrombus leads to edema. No need to learn, you can understand. How many of you got it? There are 2 types of thrombus. Arterial and venous. Can you see the same diagram? It can form in the artery and it can form in the vein. Please respond. It can form in the artery, it can form in the vein. You can see the arrow. Artery is carrying pure blood towards the organ. Vein is carrying impure blood away from the organ. Okay, tell me the differences. Arterial one is white in color. Can you see I have drawn with yellow or white? So it is pale or white in color because it is having more platelets inside that. And venous one is red in color because it is having more RBCs inside that. So color is different. Here it is yellow or pale color, white color, here red color. Okay, arterial one partially obstruct the lumen. Can you see it's partially obstructing? Still we have a space over here. But venous one is obstructing through and through, packed through and through. So mural matlab partial. This one is partial. And occlusive matlab complete. This one is completely obstructing, the venous one. The third is the lines of Zahan. Can you see arterial one? In the arterial one, you can see alternate light, dark, light, dark, light, dark lines are there. These are lines of Zahan. So arterial one have lines of Zahan. But in the venous one, I can't find any lines. So lines of Zahan are absent in venous. These all are your questions. If the arterial one is there, it will lead to ischemia of the organ because pure blood is not coming. If the venous one is there, it will cause edema of the organ because impure blood cannot leave the organ. Say yes. Listen, one more difference. See the point of the origin. This is the point of the origin. Okay, the arterial one is arising from here and it is growing in opposite direction to that of blood flow. It will propagate, grows in opposite direction to that of blood flow. It is retrograde in propagation. But the venous one grows in the same direction as that of blood flow. So this is antigrade. How many of you got it? So you get many questions on that. The 2 types of the thrombus. Arterial thrombus and venous thrombus. Venous thrombus. So we have 2 types of thrombus, arterial and venous. Tell me their color. Tell me how does they obstruct, complete or partial, obstructing the lumen. Tell me their effects. Tell me lines of Zahan. Lines of Zahan are present or absent in which of them? Lines of Zahan. One more difference we have now. Color, obstruction, lines of Zahan, effects and propagation. In which direction they propagate. Tell me, you get questions on that. Tell me, the color, this one is pale or white in color because it is having more platelet. This one is red in color because it is having more RBCs. Hana, obstruction, this one is partial, that is mural. And this one is complete. Hana, complete, that is occlusive. Okay, lines of Zahan, I told you, we have present in artery and these are absent in venous. Propagation, I told you, this one arterial one propagate retrograde. It's very important question. And this one propagate antegrade in the same direction as that of blood flow. And finally, we have seen the effects. Effects of arterial one is ischemia and infarction. And effects of venous one is edema. Effects of venous one is edema. So you get questions on that. Please, rather than learning this table, can you see the lines of Zahan here? Let me show you the lines of Zahan. Can you see alternate light, dark, light, dark? Here also alternate light, dark bands. These are lines of Zahan. Instead of learning this table, I request you to learn the diagram. You will get all the things from this diagram. Can we solve some questions? We are done with thrombus also. Read the question and tell me the answer. Can you read the question and tell me the answer, please? Virchow triad for thrombus includes all of the following except. It includes all of the following except. What is not present in Virchow triad? I'm asking what is not present in Virchow triad. I told you 3 components: stasis, endothelial injury, hypercoagulability, and platelet thrombus. Yes, Dr. Amir, absolutely right. I told you Virchow triad, these are the 3 causes of the thrombus without injury, but platelet thrombus is not in them. The next topic I'm teaching you is the embolism. What is embolism? Embolism is any solid or liquid or gaseous mass which is freely flowing in the lumen of the blood from here to there, here to there. That is a detachable mass, intravascular mass, solid, liquid, or gas. That is an embolism. It can be solid, it can be liquid, it can be gas. The best example of solid is thromboembolism. You know, I told you what is thrombus. Can you see this is a thrombus? Can you see in this blood vessel, this is a thrombus. It is attached to the blood vessel. The point it is attached, it is a thrombus. The point it will get detached, it is no more thrombus, it is freely moving thrombus. It is known as thromboembolism. So best example of solid is thromboembolism, the same diagram. Liquid mein, it can be amniotic fluid. It can be fat or amniotic fluid. And gaseous mein, it can be air. So that is embolism. That is embolism. Got it? So just remember this one. Just a second. Let me come on the next topic. Give me a second to switch the next topic. Now the next topic I'm teaching you, last topic here is the shock in hemodynamics. Then we will come on neoplasia quickly. So the last topic here I'm teaching you is shock. You know what is shock? Shock, maybe you get many questions in the shock. Oh, I'm sorry. Just a second. Okay, is it? Okay. So let's come on the next topic, that is shock. Okay. Why it is shifting again and again there? Give me a minute. Give me a minute. I guess it's fixed now. Okay, chalo. So what is shock? What is shock? Let me tell you what is shock. So can you tell me the definition of the shock? What's the definition of the shock? What's the definition of the shock? You know, human body from head to toe, we are made up of organs. Organs are made up of cell. All cell require blood. Why all cell require blood? Because blood provides oxygen to all cell, and without oxygen cell cannot survive. Blood, the pure blood via artery, it is supplying the oxygen to all my cells from head to toe. Oxygen is required for ATP synthesis. If no blood to the organ, they will not get the oxygen, they will not synthesize the ATP and they will die. Without energy, cell cannot survive. That's why blood is required in all the organ. From head to toe, we have blood in all the organ that is supplied via aorta. The pure blood is supplying through all the organs. Now imagine if all organs simultaneously do not get the blood. That is poor perfusion. What is the reason? I will tell you. There can be multiple reasons. In shock, all the human body organ from head to toe, they are not getting the blood. They are getting less blood or not getting the blood. Poor tissue perfusion. So what will happen? The cells of that organ become non-functional, of that particular multiple organ. So cells of that organ start dying. Multiple organ. So multiple organ failure will be there. The complete body failure will be there. And ultimately it's a death. So shock is a syndrome. Shock is a syndrome, it's not a disease. The main thing in the shock is poor tissue perfusion from head to toe. Poor tissue perfusion. The cells are not getting the blood. Multiple organ. There are three types of shock. What are the three types of shock? Hypovolumic shock, cardiogenic shock, and septic shock. There are three types of shock. Hypovolumic, cardiogenic, and septic. Let me tell you what do you mean by that. Let's start with hypovolumic shock. What is hypovolumic shock? नाम में ही है. How much blood we have? We all have 5 liters of blood. The adult human body have 5 liters of blood. Imagine someone got an accident. Someone have a surgery. Someone have diarrhea. Someone have vomiting. है ना? Or someone have diuresis. है ना? Due to any reason, if the blood or the fluid is lost, diarrhea, vomiting, accident, है ना? It can be dehydration. It can be surgery. The blood is lost. So less than 5 liters of blood is present. Either 2 liter, 3 liter, 4 milliliters. So it is hypovolumic. नाम में ही है. The volume is less. Hana. So if I'm having 5 liters of blood, so when my heart is pumping, it is doing the systole. The left ventricle eject blood and it is distributed with a fixed proportion to all the organ. Whenever I'm having 5 liters, the brain is getting this percentage, kidney is getting this percentage, lungs are getting this percentage. There is a fixed percentage out of the total 5 liters, how much each of them is getting. But if the blood is less, all organs will receive less blood. So poor tissue perfusion. The complete body will get less blood. The complete body, all organs get less blood. So multiple organ failure. The cells in multiple organ will die. Multiple organ failure, that will lead to shock. So that is the meaning of hypovolumic shock. The name itself depicts its meaning. Hypovolumic shock. So in each shock, I want you to learn the causes, pathogenesis, and symptom. Let's start with the first one, hypovolumic shock. This is the most common shock among the three. Hypovolumic shock, most common. I told you here the volume of the blood is less than 5 liters of blood is present. Hannah, it is not 5 less, either due to surgery or due to accident, due to hemorrhage, due to diarrhea, vomiting, burns में the water get evaporate. Hannah, diuretics due to any reason. The ultimately less than 5 liters of blood is present. If less blood is present, less venous return, less cardiac output, less blood flow to all organ. भाई blood ही नहीं है तो आएगा कहाँ से? All the organs are receiving less blood. है ना? Less blood मतलब less oxygen. So all the organs are receiving less oxygen. Less oxygen मतलब anoxia. It's anoxia and that will lead to shock. So such a shock is known as hypovolemic shock. How many of you got it? Huh? What are the symptoms? What are the symptoms of such shock? If my all organs are receiving less blood, my heart will try to compensate. It will pump fast. It will eject the blood fast. So tachycardia. The heart rate will rise. To compensate, the heart is doing so. Hannah. But if I'm having 5 liters of blood, my blood pressure is 120/80. If I'm having 5 liters of blood in my blood vessel. Now, if my blood vessel don't have 5 liters of blood, it is having less than 5 liters of blood. So blood pressure will fall. Obviously, less blood, less pressure. So the blood pressure will fall. BP will fall. So heart rate will rise, but BP will fall. Tachycardia with hypotension. Hannah. Now, all organs are not getting blood, but 2 organs are ultra sensitive. Brain and kidney. Hannah. If brain don't get blood, the person will go in confused state and the person can be comatose. Okay, and if the kidneys are not getting blood, the kidney will go in acute renal failure and the person can have oliguria and anuria. So these are the symptoms. Got it? Hannah. Now there are 3 stages in hypovolemic shock. How much blood is lost? Hannah. Less than 20%, matlab 1 liter is lost. Still the person is having 4 liters. Hannah. 20 to 40, matlab 2 liters are lost. Still person have 3 liters. Hannah. More than 40% is lost. So mild, moderate and severe. The second type of shock is cardiogenic shock. Can I come on cardiogenic? Here person have exactly 5 liters of blood. Still the organs are not receiving the blood. You will say, ma'am, why? Why the organs are not receiving blood? What is the problem now? The problem is not in volume. The problem is in the left ventricle. Left ventricle is not pumping. Left ventricular failure is there. Left ventricle is not pumping. If the left ventricle is not doing the systole, blood is not going in the aorta. If the blood is not going in the aorta, all the organs are not receiving blood or they are receiving less blood. Less blood in all organ, less oxygen in all organ. So multiple organ failure and that will lead to shock. The cause of the shock is the heart, the left ventricle, and that's why it is known as cardiogenic shock. Here the volume is 5 liters. Hannah, but the problem is inadequate pumping from the heart. Hannah, it's not hypovolumic, it's normovolumic. Got it? Now why the left ventricle is not pumping? Maybe the wall of the left ventricle have MI. The most common cause is the MI. It can be cardiomyopathy, it can be rupture, arrhythmia, it can be any cause. The left ventricular wall is damaged. More than 40% damage. That's why it's not pumping. Got my point? So that is cardiogenic shock. How many of you got it? That is cardiogenic shock, है ना? So here all the symptoms which are present there वो तो यहाँ भी होंगे. All the organs are receiving less blood. Kidney receive less blood, so oliguria. Brain receive less blood, so comatose and confusion. But you know, here the left ventricle is not pumping. The problem is that the left ventricle is not pumping. So blood is not going in aorta. So where does it go? Where does it go? It's going backward. Come on, it's going backward. It's not going forward because the left ventricle is not pumping. It is accumulating and getting backward. From left ventricle, it is going to left auricle. From left auricle, it is going in pulmonary vein. From pulmonary vein, it's going backward, backward, backward. It is accumulating in the lungs, producing pulmonary edema that is leading to dyspnea. So dyspnea is the additional finding here, है ना? If the person have tachycardia, है ना, hypotension, oliguria, anuria, coma. So this is hypovolemic shock. But if I say all these symptoms plus dyspnea bhi hai, so it is cardiogenic shock. So cardiogenic shock, dyspnea, which is differentiating it from hypovolemic shock. How many of you got it? How many of you got it? Yes. So this is cardiogenic shock. The third shock is very difficult to understand. The third and the last shock is septic shock. है ना? What is sepsis? The bacteria in the blood. If the bacteria is present in the blood, the person has sepsis. वो तो समझ में आता है. We understand that. But why sepsis lead to shock? What is shock? Shock के लिए one thing is compulsory. All the organs from head to toe, they do not receive oxygen. They do not receive blood simultaneously. If there is less than 5 liters of blood, all organs are receiving less blood. It's hypovolemic shock. If the heart, left ventricle is not pumping, all the organs receive less blood. It is cardiogenic shock. But why the infection in the blood leads to shock? The sepsis lead to shock. So that is my question to you. Let me explain you. Hana, there are two type of bacteria: gram-positive bacteria, gram-negative bacteria. So there are two type of septicemia: gram-positive, gram-negative. Both of them can lead to shock. Hana, let me explain you. Hana, listen. Gram negative, make it negative. Gram negative bacteria have lipopolysaccharide in their cell wall, and gram positive bacteria have lipoticoic acid in their cell wall. Whether it is gram positive or it is gram negative, है ना? The lipopolysaccharide and lipoticoic acid correspondingly they stimulate macrophages present in the blood. Macrophage will secrete certain cytokines that will do two things. Please understand, it's difficult. First, they cause vasodilation, then cause increased vascular permeability. Let me explain. Imagine this is a blood vessel of a human being, inside which the person has sepsis. Now, one of them will be present, either gram-positive bacteria or gram-negative bacteria, any of them. Gram-positive bacteria have lipoticoic acid in the cell wall. Gram-negative bacteria have lipopolysaccharide in the cell wall. Hana, whatever it is stimulating the macrophage. It is stimulating the macrophages present in the blood. The macrophage gets stimulated. Macrophage will secrete certain cytokines that will cause two things. Very important है, two things. Number one, this is the organ, है ना, to which this blood vessel is supplying. Number one, it is causing vasodilation. What is vasodilation? Vasodilation may, you tell me this is an organ, है ना? So by causing vasodilation, this is vasodilation. I have dilated the blood vessel. I am supplying more blood to the organ or less blood to the organ? I am asking you. Can you answer? Anyone? Organ is receiving more blood or less blood? By causing vasodilation, what we are doing? We are giving more blood to the organ or less? Common sense. We are doing vasodilation. Vasodilation means more blood. I am providing more blood to the organ. You will say, ma'am, are you mad? You are telling that on one hand, you are saying that in shock, all the organs are receiving less blood. And on the other hand, you are saying here the organ is receiving more blood. Huh? So septic shock is something unique. Here the organ receives more blood at the initial phase. Instead of getting less blood, it is receiving more blood. Yes, it's hyperdynamic shock. This shock is known as hyperdynamic, which is in contrast with the other two type of shock, which I have taught you. That is hypovolemic and cardiogenic. Here the blood supply initially increases. Initially there is more supply to the organ. So if another two shock, that is hypovolemic and cardiogenic, if you touch the extremities are always cold. हाथ और पैर एकदम ठंडे होते हैं. But in septic shock, if you touch the extremities, they are warm. Initially they are warm. Later on, there is increased vascular permeability. What do you mean by increased vascular permeability? Due to cytokines only. Increased vascular permeability means creation of gap. So gaps will be created here. In the wall, in the endothelial lining, the gaps will be created, so fluid will leak out. Fluid will leak out. The fluid will leak out. So less fluid will remain. Now the organ will receive less blood and now the person will go in shock. So initially there is hyperdynamic stage in septic shock and later on the person goes in the shock. इस पे बहुत question आता है. So first there is vasodilation followed by increased vascular permeability, finally leading to shock. How many of you got it? So in septic shock, there are two stages. Initially hyperdynamic stage. In which organ receive more blood? The extremities are warm, but later on, hypodynamic stage. How many of you got it? We are done with the shock also, the 3 type of shock. We are done with this unit. बड़े मैंने 3 यूनिट कराए. In a compact span of 3-4 hours, I have taught you maximum chunk of general pathology. Appreciate my efforts. Huh? Are you getting it? Is it useful for you? Is this lecture? It is a compact version of complete pathology. Okay. So maximum questions will be from this portions only, which I am teaching you in your exam. Okay. We have one more day tomorrow. Okay. Chalo. So we have completed the 3 type of shock. Hypovolumic shock is due to blood loss. Less than 5 liter of blood is present due to any reason. है ना? Cardiogenic shock is due to destruction of the wall of the left ventricle. The left ventricle is not pumping. And septic shock is due to infection. है ना? So that is the main thing here. है ना? Okay, read the question and tell me the answer. Read the question and tell me the answer. Perioperative shock is an example of. Perioperative shock. During operation, during surgery, the blood loss is there. The person have blood loss. We all have 5 liters of blood. But during operation, during a surgery, the more blood can be lost. Na? So person have hypovolumic shock or septic shock or cardiogenic shock or neurogenic shock. Which shock the person will have? Yes, the person will have hypovolumic shock. Absolutely right. Okay. In shock, what is the characteristic feature which is present in all 3 type of shock? Tell me a unique thing which is present in all 3 type of shocks. Is it cardiac failure, poor tissue perfusion, cyanosis, or edema? What is the correct answer? What is the correct answer? What is the correct answer? Yes, poor tissue perfusion. Whatever shock it is, ultimately poor tissue perfusion of multiple organs simultaneously. That is the shock. Okay, so poor tissue perfusion is there. So we are done with all these important topics right now. In the genetics, I will hardly take 5 minutes. I just want to show you the 4 mnemonics. I will not read the mnemonics. I will give you the PDF. You can learn by yourself. So in genetics, I just want to do that. And after that, I want to come on the neoplasia directly. I know. So maximum chunk of the general pathology we are covering. So coming on the genetics, in the genetics, we know humans have cells. Inside the cells, inside the nucleus of the cells, how many chromosomes we have? We all have 46 chromosomes in every cell. Rather than saying 46 chromosomes, it's better to say 23 pairs of chromosomes. How many chromosomes we have? We have 23 pairs. So this is pair number 1, pair number 2, pair number 3, pair number 4. Likewise, we have 23 pairs. So you can see this is the 23 pairs of the chromosome. Out of the 23 pairs of the chromosome, we all have the first 22 pairs. You can see the first 22 pairs is common in all the persons. It's common. But the last pair decides the gender of the person. Whether the person is male or female, that is decided by the last pair, that is sex chromosome. In males, it's XY, in females, it's XX. We know that. So these are the sex chromosomes. So total 23 pairs are there. Now, there are 4 types of diseases in genetics you have to learn, on which MCQs come in FMGE exam specifically I'm talking about. There are 4 types of inheritance: autosomal dominant, autosomal recessive, X-linked dominant, and X-linked recessive. These are the 4 types of inheritance we are talking about. So you have to learn the pedigree and the example of each of them. Let's start with autosomal dominant. Now, autosomal dominant and autosomal recessive, they are not related to gender of the person. But X-linked dominant, X-linked recessive, they have the gender bias. First start with autosomal dominant. This is autosomal dominant. Have a look at the pedigree. You know, in the pedigree, the square is a male and the circle is a female. I guess everyone knows. If you don't know, learn the basics. Okay, here in this pedigree, you can see in this generation, there is infection to some person. There is the disease to some person. This next generation also have the disease person. The next generation also have the disease person. So there is no generation skip. There is no generation skip. All the generations have the disease. It is transmitted to all. So grandfather is giving to father, father is giving to the son, and grandfather is giving to the mother, mother is also giving to son and all. Like it is generated in all the, it is transmitted in all generation. There is no generation skip. You can see it. The next thing you can see, the male is giving disease to male and female both. And the female is also giving disease to male and female. So there is no gender bias. Both can transmit disease to both. So there is no gender bias. And it is heterozygous. We know dominant conditions are heterozygous. This is examples you learn by yourself. I will give you the mnemonic in the end. Autosomal recessive, there is generation skip. You see, disease person is present in this generation, not in this, and again in this. So 2 generations are skipped. So generation skip is common here. So based, if this pedigree is given, you can identify it's autosomal dominant because there is no generation skip. But here clearly I can see बीच में generations are skipped. Generation की generation छूट गई. There is none of the person having the disease in this generation. Okay, so generation skip is present. Gender bias यहाँ पे भी नहीं है, but this one is homozygous. How many of you got it? So this is the second thing. Hana, examples I will teach you. The third is X-linked dominant. Hana, we have seen autosomal dominant, no generation skip, autosomal recessive generation skip. And there is no gender bias in both of them. Now coming on X-linked dominant and X-linked recessive. Hana, can I come on X-linked dominant? Please respond, people. Keep responding. If you want my energy levels to be high, you have to be interactive. So see, X-linked dominant. See here. See the mother. If the mother is having the disease, she got married with a normal husband. I mean, the husband don't have the disease, the wife is having. The mother is giving, there are 4 children. This mother is having 4 children, 4 pregnancies. है ना? 2 daughters, 2 sons. ठीक है? She is giving the disease to 50% of the daughters. 1 daughter is affected, 1 is normal. Out of the 2 sons, 1 is affected, 1 is normal. So she is giving disease to 50% daughters, 50% son. Okay, the mother. And what about the father? If the father is infected, out of the 4 children, है ना? The disease is given only to daughters. What I said, fathers transmit disease to daughters only. 100% daughters. Father is doing a bias. And the mother is not doing any bias. Mother is giving disease to 50% daughters, 50% son. This is a typical inheritance seen in X-linked dominant disease. How many of you got it? The father gave disease to 100% daughters. And the mother gave the disease to 50% of the son and 50% of the daughter. Please respond. Ankit, Mukutraj, Prince, Ramaya, Vasudev, you got it, or others, anyone who is watching me live. Give me a thumbs up. Got it? So what I said, the affected father, father is doing a partiality. Father don't like the daughters. And I'm taking an example. Father liking son only. So father is giving the disease only to the daughters, not to the son. Father is loving the son. So father is giving the disease to 100% daughter. But mother is not partial. Mother is giving the disease to 50% daughters and 50% sons. You can get a pedigree like this. And last is X-linked recessive. The last one is X-linked recessive. In X-linked recessive, the females are always carrier. The dot at the center is carrier and males are the cases. Disease never occur in females. See, none of the circle is black. The circles have a dot inside that is their carrier. So females are carriers. So if this pedigree is coming to you with a dot in a circle, it's X-linked recessive. If this pedigree is coming to you with a partiality, it's X-linked dominant. This pedigree in which generation skip is there, it's X-linked recessive. And this pedigree, if there is no generation in between, it's X-linked dominant. So you can get a question on the pedigree. Pehli baat. Now learn the 4 example. And I will give you 4 mnemonic. So come, I will give you 4 mnemonic. Autosomal dominant, autosomal recessive, X-linked dominant and X-linked recessive. So I'm going to give you 4 mnemonics one by one. Let's start with autosomal dominant. The mnemonic is in front of you. वो familial hypercholesteremia autosomal DOMINANT dominant है. So this is the mnemonic. V stand for वो. V stand for von Willebrand. Familial stand for familial adenomatous polyposis. Hypercholesteremia is hypercholesteremia. A stand for adult polycystic kidney. D stand for dystrophica myotonica. O stand for osteogenesis imperfecta. M stand for Marfan. I stand for intermittent porphyria. So please you read the full form by yourself. I'm not wasting the time because there is nothing to understand, but you get many questions out of that. And with the mnemonic, at least it will be easy and you can apply it on the spot and try. Okay. Autosomal recessive, the mnemonic is ABCD, EFGH, SPW. A stand for albinism and alpha antitrypsin deficiency. B for beta thalassemia. C for cystic fibrosis. D for deafness, sensory neural deafness and Dubin-Johnson. A, B, C, D. E, F, G, H. E for enzyme deficiency, that is glycogen storage disorders. F for Friedreich ataxia and Fanconi. दोनों पे question है. G for galactosemia, है ना? H for hemochromatosis. S for sickle cell. P for phenylketonuria and W पे Wilson पे भी PYQ है. So please learn it, है ना? X-linked dominant, only 4 examples are there. Pair, जिसमें maximum question is on Alport. And X-linked recessive, the mnemonic is Graham Bell. G stand for G6PD, it's having a PYQ. और ये जो Graham Bell का B है, it's color blindness, इस पे भी PYQ. So please read the full form. I'm not reading it because the time is limited. I wish if I could read और मैं तुम्हें learn करवाती, है ना? I wish. लेकिन time is limited now. What to do? Okay, this is not a conceptual thing. It's simply facts are there. You have to learn that. Learn the 4 mnemonics and try to say their full form. Okay. वो familial hypercholesteremia autosomal dominant है. This is the mnemonic. Autosomal recessive is ABCD, EFGH, SPW. Okay, G. X-linked dominant is fair. Fair ka A is Alport, never forget. And X-linked recessive is Graham Bell, GRAHAMBELL, Graham Bell. Okay, please learn and G is G6PD deficiency, never forget. So you get many questions out of that. So that is about the genetics, है ना? So I'm skipping like tuberous sclerosis. It is which dominant? So वो familial hypercholesteremia autosomal dominant कट्टी है ये. So answer will be autosomal dominant, है ना? Wilson's SPW, ABCD, EFGH, SPW का W है ये. So answer will be autosomal recessive. Apply the mnemonic, you will get the answer. Which of the following is X-linked recessive? So which of the following is coming in Graham-Bell? G6PD deficiency is coming in Graham-Bell. If you know the mnemonic, it's very easy. They will give you the pedigree to analyze. है ना? You can see the partiality. You can see the partiality. The father is giving to daughters only, and the mother is giving to 50% son, 50% daughter. है ना? So it's X-linked dominant. Okay, so you get many questions out of that. है ना? Learn three more things here. Trisomy 21 is down, trisomy 13 is Patau, and trisomy 18 is Edward. I guess you know that. If you don't know, I'm just revising you. Just a second. Let me come on the next topic. So we are done with the genetics also, and now I am coming on the transplant. है ना? Transplant में से भी you get questions, and after that I will come on the last portion, neoplasia. See, this is transplant. Can you see it? I hope you can see it. Yes? Can you see it? Huh? So what is transplant? What is transplant? In the transplant, in all transplant, है ना? Whatever, it is a kidney transplant, it is a lung transplant, it is a heart transplant. Nowadays, we can perform many transplant. There is a donor, there is a recipient. The recipient is known as host. So we take the tissue, the graft from the donor and transmit it to the recipient. So donor to recipient transmission is there. From the donor to the recipient, we are doing the transmission. That is the transplant. That is the transplant. What's the main problem in the transplant? The main problem, just suppose we are doing kidney transplant. So we take the kidney from the donor and we transmitted, transplant inside the recipient. For recipient, this is foreign. For recipient, this is foreign tissue. So the immune system for the recipient, it will reject it. We do not want the rejection because in this patient, both the kidneys are failed. That's why we are doing a transplant. We do not want the rejection. But rejection will occur because it is a foreign thing. Rejection is the main thing here. Hana? So tell me the types of the transplant. Who is the best donor? In which rejection chances are nil? Who is the best donor? In which there is 0% rejection chances. कोई ऐसा donor है? Who is the best donor? Based on the donor, there are 4 types of transplant. The best donor is myself. I mean the patient self. खुद का ही खुद में ही लगा दो. So take a tissue from the same person and transmit it to the same person. So you say, ma'am, how it is possible? For example, I am having burns over the face or anywhere. I can take the skin of my back or thigh and transplant it from one side to another. So this type of transplant is known as auto. So I'm taking my skin only and transmitting it to me only. So my body will not found it foreign. It will not do the rejection. So such a transplant is known as autograft. This is autogenic graft. The best transplant, है ना? No rejection. ठीक है? But it is not always possible. In case of plastic surgery, skin, it is possible. It is not always possible. Who's the second best donor? The second best donor is the identical twin. Imagine if someone is having identical twin. I'm not talking about non-identical twin. I'm talking about monozygotic twins. Monoamniotic, monochorionic, monozygotic twins. So they are genetically exactly same. So if we take the organ from the genetical identical twin and transmit it to the person, there will be no rejection. Because they are genetically identical, na? Body will not find it foreign. It is known as syn graft or isograft. The donor is the twin, but identical twin. Hana? But very few people have identical twin. No, I don't have identical twin. I'm having my siblings, but we are not identical twins. Hana? So if someone don't have identical twin and the person require a transplant, who's the next best donor? The next best donor is any human. Any human. At least the species is the same. Hana? It is any human. The same species. Hana? If multiple donors are available, it can be a relative, it can be a non-relative, it can be a friend, it can be anyone, but a human. If multiple donors are available, we will do the HLA testing and we will see maximum matching jisme hogi, the chances of rejection are minimal in that. We will choose that donor. Hana? So such a graft is known as allograft, in which same species is there. And the worst graft are the xeno, we don't perform them. We take the organ from the animals and transmit to the person. These are known as xeno or heterograft. How many of you got it? So based on the donor, we are having 4 types of transplant. Based on the donor, we are having 4 types of transplant. What are the 4 types of transplant? If the donor is the self, if the donor is the identical twin, if the donor is same species, that is human, or if the donor is different species, that is any animal. Name the transplant. Name the transplant. Here it is known as autograft. Here it is known as iso या फिर syn graft. Here it is known as allo allograft, also known as homograft because the species is same. And here it is known as xenograft, or also known as heterograft because the species is different. So you have to learn the type of the graft based on the transplant. This is the type of the graft. In these two, rejection is 0. There is no rejection at all. In these two, rejection is there. Maximum rejections are seen here. So you get simple questions over there. Read the question and tell me the answer. Tell me the graft between identical twin is known as. Graft between identical twin is known as. Yes, what is the correct answer? Identical twin. Yes, the correct answer is autograft. Absolutely right. I'm sorry. Identical twin, it is known as isograft. Isograft or syn graft. Best example of syn genetic graft. The same question is asked in a different way. So is it between dizygotic twin or monozygotic? Of course, we all know it is between the monozygotic twin. So you get simple questions out of that. Let's come on the last topic, that is neoplasia, ultra important chapter. And a few more minutes, then we are going to pack it. So at least general pathology, all the important topics we have covered today. And tomorrow my target is to cover the important topics, high yielding topics for your exam from hematology and systemic pathology. So don't dare to miss tomorrow's session also. Okay, can I come on the neoplasia? What is neoplasia? The cancer, the tumor. What is neoplasia? Can you see this is a normal cell? Hannah, how to differentiate a normal cell? How does a normal cell get converted into neoplastic cell? How does a normal cell get converted to neoplastic cell? Can you see this is a normal cell? What do you mean by normal cell? All the normal cells have receptor on their surface. Can you see this is a receptor? They have a receptor on their surface. So whenever a growth factor is coming, binding with the growth receptor, whenever growth factor is coming, binding with the growth receptor, then only cell is doing mitosis and divide into multiple cell. It is forming 2 cells out of 1. So that is mitosis occurs only if the growth factor is coming. That is stimulus is coming. Otherwise, mitosis do not take place. This is a normal cell. Can you see this is a neoplastic cell? You tell me what is the difference between this cell and this cell? Here also mitosis takes place. Here also you can see. But here there is absence of growth factor. So even without growth factor is not present. It is not binding with the growth receptor. So here even without stimulus, the cell is dividing. You know, the mitosis is uncontrolled. So from 1 cell to 2 are formed, 2 to 4, 4 to 8, 8 to 16, 16 to 32, 32 to 64, and so on. A bunch of cells is formed. That is uncontrolled mitosis. Uncontrolled mitosis leads to cancer. So what is a neoplastic cell? The neoplastic cell is such a cell in which mitosis is not under control. The cell division is uncoordinated, it's not controlled. Even after cessation of stimulus, it keeps going. Even after cessation of the stimulus, it keeps dividing. How many of you got it? Say yes. So this is the definition of cancer. Okay, neoplasia. Now there is a special type of cancer that is known as teratoma. There is a special type of cancer which is known as teratoma. You know, in human body, we have many organs. During embryonic life, there are 3 germ cell layers. There are 3 germ layers, from which the complete organs are formed. Ectoderm, mesoderm, and endoderm. So all the organs are formed from one of the layer. Ectoderm or mesoderm or endoderm. From one of the layer, most of the organs are formed. So in each organ, we have 1 germ layer. So for example, the blood vessels, the cardiovascular system is derived from the mesoderm. The central nervous system is derived from the ectoderm, like that. So one organ have 1 germ cell layer. So whenever we have cancer, humans have cancer in any organ, it is derived from 1 germ cell layer. Teratoma are the tumors of totipotent cell. What are totipotent cells? Totipotent cells are the cell which can differentiate into any of the germ cell layer. They can differentiate into ectoderm or mesoderm or endoderm. They can differentiate in anyone. So the tumor have all 3 germ cell layers. So only tumor which have all 3 germ cell layer, it is known as teratoma. So it is a tumor which have technically anything inside that. If you cut the tumor, now where does it occur? It occurs in gonads. In females, it is in ovaries. In males, it is in testes. Okay. So just suppose it is a female who is having an ovarian mass and I'm a surgeon. I'm operating the lady. I'm taking the mass outside. If I cut the mass, I can find anything inside that mass. You can see I can find the hairs, I can find the bone, I can find the tooth. So technically anything, I can find the brain, salivary gland, fat, or anything inside the mass. That is teratoma. So usually it comes as a spotter image in your exam. They will give you a spotter image and they will ask you to identify what is it. So identification, it's a teratoma because it contains, usually they will give you hairs to identify. So that is the teratoma. Okay. So that is the teratoma I taught you. The biggest thing I want to teach you here, the benign versus malignant tumor. The most important thing I want to teach you here is the benign versus malignant tumor. There are two types of tumor, benign and malignant. How to differentiate them? Benign tumor requires only surgery as a treatment. Malignant tumor, after surgery, they require chemotherapy, radiotherapy, targeted therapy, hormonal therapy. Here, no chances of recurrence. And here, there is always a chance of recurrence. Here, they have very good prognosis. They never recur. Here, the prognosis is sometimes poor. They can reoccur and they can cause the metastasis. So that's why we want to differentiate. Is it a benign neoplasm, benign tumor, or malignant? How to differentiate? How to differentiate between a benign cancer or tumor and a malignant tumor? Does anyone know what are the differences? How to differentiate between the two? Between a benign tumor and a malignant tumor? What are the differences? Can you tell me? So in benign tumor, the rate of growth is slow. They are very slow growing, but malignant tumor are very fast growing. The doubling time is very less. They just grow very fast. So we have to see the doubling time. Here, doubling time is very high. Just suppose there is a lady coming to my clinic that, doctor, I'm having a lump in my breast. I'm feeling since last, so the first question I will ask, since how long you are feeling it? If the lady is saying it, I'm feeling it since last 1 year, 2 years, so it's going to be benign, mostly, because it is very slow growing. But if the lady is saying, no, it's growing very fast, within a 1 week, I have felt, when I felt it was like a very small, like a peanut, and not the size of 2 to 3 centimeter, so it's growing very fast. So usually malignant tumors are fast growing. This is usual. Exceptions are there, but this is usual. Benign tumors are usually asymptomatic and malignant are usually symptomatic. Again, exceptions are there. This is again a rough criteria. Grossly, benign tumors are circular, spherical in shape, and they have a capsule over them. I will show you the diagram. Malignant are irregular in shape and they infiltrate inside the organ. They don't have any capsule. So this is the third difference. Let me come on the fourth and fifth. Let me show you these three. So first thing is the rate of growth. Benign tumors are slow growing. Malignant tumors are very fast growing. Benign tumors are slow growing, malignant are fast. Benign tumors are asymptomatic, malignant are symptomatic. Benign tumors are spherical, encapsulated, they are irregular, and they invade the tissue. They invade. Can you see the breast? Both of them are the breast. Can you see a tumor in the breast here and there? In both of them, there is a tumor. Let me show you this tumor. Can you see? It's circular, spherical, well encapsulated. This is the benign tumor of the breast, that is fibroadenoma. Can you see this tumor? It's irregular, infiltrating into the tissue, no capsule. This is malignant tumor of the breast. So grossly also we can identify. But these are the rough criteria. Rough. The main criteria is the microscopy. Cut it and make a slide. Cut and make a slide, cut and make a slide. On the slide, we will look for anaplasia. What is anaplasia? These 10 features are known as anaplasia. In benign tumor, all the 10 are absent. In malignant tumor, all 10 are present. So this is anaplasia. So anaplasia is the hallmark of malignancy. First learn that. Anaplasia matlab malignancy. Anaplasia is the hallmark of malignancy. These 10 features are absent in benign and these 10 features are present in malignant. Got my point? The 10 features together is known as anaplasia. Anaplasia. So anaplasia is the hallmark of malignancy. In the slide, now I'm a pathologist, you are a surgeon. There is a lady coming to you that, doctor, I'm having a lump in my breast. You are doing a biopsy. You are doing a wise decision. You are just taking a biopsy and sending it to the pathologist. You are sending it to me. Okay, ma'am, you are giving a call. Ma'am, have a look and tell me whether it is benign or malignant. If you say benign, I will just operate the lady and let her go. If you say it is malignant, I will look for other options also. After surgery, I will give the chemo, radio and all that. So my plan of action will be different and prognosis of both will be different. So it is the pathologist who is going to decide whether it is benign or malignant. Based on the gross, based on the rate of the growth, based on the symptoms, the surgeon can only guess whether it is benign or malignant, but ultimately it will be the pathology. So if you are giving me the slide, I will look for these 10 features. All these 10 features together known as anaplasia. If the 10 features are absent, I will make my report that anaplasia is absent, that's why it's benign. If the 10 features are present, I will make my report that anaplasia is present, that's malignant. So what are the 10 features which define anaplasia? Most of them are same as that of dysplasia. Today morning I told you, basal polarity. In benign tumors, basal polarity is maintained. In malignant tumors, it's lost. The second is pleomorphism. In benign tumor, pleomorphism is absent. In malignant, the pleomorphism is present. The NC ratio here low, here high. Here nucleus is of same size. Here nucleus is of, here can you see all the nucleus are of same size. Here some are small, some are large. That is anisonucleosis. Here anisonucleosis is absent. Here it's present. Here the color is normal. Here it's dark color, hyperchromatism. So all the features, don't learn the features, just learn anaplasia. Anaplasia is absent in benign and present in malignancy. That is the feature which is going to differentiate benign and malignant. Fourth and the fifth and the last. Let me explain you the fifth and the last. Hana. So what are the differences between benign and malignant? I'm teaching you 5 differences. Listen, listen, listen. The ultra important among all these is the fifth. Let me explain you the differences again. So if there is a lump at any organ in any person, how you are going to decide is it benign or malignant? How you are going to decide is it benign or is it malignant? How you are going to decide? Is it benign or malignant? How you are going to decide? Huh? Just suppose again the breast, the female is having a lump in the breast. So first is rate of growth. If it is slow growing, it's benign. If it is fast growing, it's malignant. Second is clinical feature. Usually, if it is asymptomatic, it's benign. If it is symptomatic, it's malignant. Again, exceptions are there. Grossly, if it is spherical, well encapsulated, pushing the surrounding tissue, it's benign. But if it is irregular, non-capsulated, infiltrating the surrounding organ, it's malignant. The fourth is microscopy. Hannah, here anaplasia is absent and here anaplasia is present. Anaplasia is the 10 features, the cluster of the 10 features. Read the list, don't learn it. The most important and the fifth feature which differentiate benign and malignant is the spread of the tumor. Spread of the tumor. There are 2 types of spread of tumor. Hana, local spread and distant spread. What do you mean by local and distant? For example, there is a person having a stomach cancer, gastric cancer. Hana, let me draw. There is a person who is having the gastric cancer. Okay, there is a person. This is the gastric cancer. Hannah, these are other organs. Maybe this is pancreas, maybe this is the intestine, this is spleen, Hannah, other organs. Now this cancer, and this is the blood vessel. This is the blood vessel. So this cancer will spread, it will grow. And in continuity, it is involving other organs. So it is known as local spread. Local spread, matlab in continuation, it is involving multiple organs. That is local spread. It is a possibility few of the tumor cells will leave the tumor cell and go in the blood or in the lymphatic, and via blood or lymphatic it is spreading to multiple organs and forming multiple secondaries. This is known as distant spread or metastasis. Hannah, so there are 2 types of spread. If it is continuous, it's local, and if it is discontinuous, multiple secondaries are formed via blood or lymphatic, it is spreading throughout the body. It is distant spread or metastasis. Both the things are absent in benign, both the things are present in malignant. I repeat my words. Local spread and distant spread are absent in benign, and local spread and distant spread both are present in malignant. Say yes if you got it. Both the things are absent in benign. Benign tumors neither show local spread nor show distant spread. Malignant shows both. Got it? Now, among the 5 differences, I told you 5 differences between benign and malignant, which is the most reliable feature. Which is the most reliable feature to differentiate the two. Not a guess. मतलब वो है तो पक्का ही benign or malignant है without any confusion. Which is the most reliable feature? I'm asking you. Which is the surest sign of malignancy? In other words, it's the question. So it's metastasis. If metastasis is present, it has to be malignant. So most important feature to differentiate benign and malignant is metastasis. Second most reliable is the local invasion. Hana? Third most reliable is the anaplasia. This is the sequence. And these are rough criteria based on which I can differentiate benign and malignant. No, anaplasia is not the surest sign. The surest sign is the metastasis. Hannah, but we do not wait. Just suppose a lady is coming to me. The lady is saying that, doctor, I'm having a lesion in my breast. I feel a mass in my breast, one of the breast, maybe right, maybe left. She is having a mass. So I cannot say कि okay, there can be 2 possibilities. It can be benign, it can be malignant. But I cannot say कि wait, देखते हैं metastasis हुआ तो it will be malignant, नहीं हुआ तो benign है. देखते हैं local invasion हुआ तो it's malignant, नहीं हुआ तो benign है. We cannot wait till that stage. Hannah, we will do a biopsy and based on anaplasia we decide. But it's the third most important criteria that will differentiate. Most important is metastasis and local spread. How many of you got it? So this is the metastasis. It's a बहुत frequent question आता है. So these are the 5 differences I told you. The 5th one is ultra important. Spread of tumor. The 2 type of the spread, local and distant. Hana, benign tumor neither show local nor show metastasis. And malignant tumor show local invasion as well as metastasis. Both of them are present in the malignancy. Both of them are absent in benign. Both of them are present in malignancy. Metastasis is the most reliable sign of malignancy. Second most important feature is invasiveness, local invasiveness. Got my point? Anyone have any confusion? So same difference table is given to you. You have to read this table. You get many questions out of that. Okay, got it, Hannah? So I'm skipping the questions as you can solve it by yourself. And this is the thing. And one more last thing I want to tell you here is the tumor markers. Okay, Just a second. You frequently get questions on the tumor markers. Let me tell you that. What are tumor markers? I will share the PDF with you, okay? So no need to write anything. I will share the PDF. Okay, so listen. What are tumor markers? Let's come on tumor markers. Let's come on tumor markers. Can I come on tumor markers? What are tumor markers? Listen, I told you whenever any patient present with any mass, for example, the same patient present with a colon cancer, है ना? The patient is having a colon cancer. ठीक है, here is the cancer. So what I will do? Of course, I will do the biopsy. The most important feature to diagnose a cancer is do the biopsy. Do the biopsy. See for anaplasia. If anaplasia is absent, it is benign. If it is present, it is malignant. So best is do the biopsy. And once I have done the biopsy, now I started the patient treatment. I mean chemotherapy, radiotherapy. Now I want to see whether the tumor is responding or not responding, whether it is regressing or not regressing. Or if the patient is completely treated, I want to do the follow-up. And a follow-up में मुझे देखना है कि it is coming again or not coming, it is regressing. So I cannot do biopsy multiple times. Once I can do for confirmation, but every time I cannot do the biopsy because it is a very lengthy procedure. I have to admit the patient, I have to give anesthesia. It's costly also. Repeating also takes time. So there are many drawbacks. है ना? So I cannot offer biopsy every time. It's invasive. है ना? So what I can do, some tumor cells, what they do, they secrete, this is a blood vessel. They secrete a protein in the blood. I will take the blood sample. Taking blood sample again and again is very easy. Doing biopsy again and again is not easy. I will ask the patient, give a blood test. Blood ka ek janch kara lo. So we will take the blood sample and look for that marker, the protein secreted by the tumor in the blood. If that marker is present, I will do a baseline and I will start the treatment. Now after treatment, I will again test for that marker. Like colon cancer secretes CEA in blood. So before starting treatment, I will check the CEA, and after finishing or meanwhile the treatment, I will again check the CEA. If CEA is falling gradually, it means the tumor is responding. So this is how we use them as an adjuvant. We don't use them for diagnosis, tumor markers. These are the markers that are secreted by the tumor cells into the blood. Hannah, these are the biological indicators of the tumor. How many of you got it? You have to learn the list. That which tumors secrete which protein in the blood. You have to learn the list. Most important is CA125. Ovarian cancer secreted in the blood. Hannah, CA19.9. It is secreted in the blood by colon cancer. It is an indicator of colon cancer. And CA15.3, it is an indicator of breast cancer. Okay, PSA, it is an indicator of prostate cancer. Okay, CEA, it is an indicator of colon cancer. I told you. Alpha fetoprotein and beta HCG, they are the indicators of the testicular tumors. You have to learn this list. How many of you got it? How many of you got it? Huh? So you get many questions on the markers. You have to learn all these markers. Okay. So today I have covered general pathology. General pathology ke high yielding topics. First, how was the session? You find it useful? I taught you all the high yielding topics of general pathology which are important for specifically FMGE exam. You need to revise them before going to your exam. I try to compact them as much as possible. In a less span of time, we covered many things in the fastest way possible. Was it useful? What is the feedback? So in the same manner, you want one more session? One more session of pathology tomorrow, in which I am going to cover entire systemic pathology and hematology. In the hematology, I will focus on the leukemias, the 4 leukemias, because you frequently get an image-based question on the leukemia and anemias. Few important anemias, not all. And in systemic pathology, there are 15 important topics which are very frequently and repeatedly asked in your exam. So we will revise those 15 important topics, one from each system. The ultra important topics. Okay, you want that? How many of you want that? So tomorrow also we are going to continue with the pathology, the hematology and systemic pathology. I will again start tomorrow morning 9:30 a.m. Tomorrow morning. So don't dare to miss it. Whosoever, your colleague, your friend, your batchmate, or your known person who is targeting for the FMG in January and want to revise pathology very quickly. So please share the link with them. It is on the same YouTube channel. The link you will get it from here only. Thank you so much. Thank you for your patience, for your time, for your attention, and wishing you all the best for your exam. Hannah, hope to see you again tomorrow, not in the next batch. I want to clear your exam. I want all of you to clarify your exam in this shot only, in this attempt only. So just I want to see you tomorrow for the rapid revision of remaining pathology, and I want to get a message from your side once the results are declared after the exam that ma'am, I cleared my FMG. That's it. Okay, that is the best wishes I want to give you. Thank you so much, and hope to see you tomorrow morning 9:30 a.m. sharp. Bye bye. I will start with hemat followed by systemic. Bye-bye. I'm ending this session. Thank you so much.